dot on the time basically.
Because the schedule otherwise will get delayed.
Yeah, it has to be started.
Yes, sir. And people will join us slowly.
Yeah, please.
Dr. Pawan, good morning.
Yes, sir. Good morning, sir. Good morning, sir.
Nice to see you.
Congratulations, sir.
Thank you, sir. Thank you, sir.
Yes, sir.
Me under support.
Sir, I will try background, GERICON background, sir. Just 1 minute. Give me 1 minute time, sir.
Try and
I will rejoin. Just 1 minute, sir.
Sure.
Because
you could ask somebody to share with me the background also. I'll also change the background here.
ठीक है सर, मैं आपको भिजाऊं आपके WhatsApp पे
हाँ,
भिजाऊं?
भिजा दीजिए प्लीज, WhatsApp पे भिजा दीजिए.
Immediately भिजा
मैं
दो सर.
फिर थोड़ा चेंज कर लेता हूँ प्लीज.
जी.
ठीक है प्लीज. And now it is 9, so you'll have to start now.
जी. साहब आपको भिजा दिया मैंने.
Thank you. I received it. Now I'll switch over and join back. You please start your program. Thank you.
Please, sir. Right.
So I want to put the virtual background. Choose virtual background. I'm going to go and change. Choose virtual background filters. Add one. Okay. Add image. Now the thing is in this, but the one they have given is not showing because it's in some other file. Avinash, sorry, I'll show you the thing.
So open it on your desktop, Dr. Prasad.
Sure, I'm doing that.
Sure. As soon as you're done, with your permission, shall we start the conference?
Please go ahead. Please go ahead. Please go ahead, Dr. Raju.
Dr. Bijin hasn't yet logged in. He's the first speaker. As soon as he comes on, we'll start.
Sir, please start, sir.
The first speaker is Dr. Bijin, na?
Dr. Pawan, please.
Pawan.
Dr. Pawan, please read about the speaker, Prem Narasimhan.
I think Pawan
Sir, first.
Getting the background.
Okay.
Schedule ko change ayinda.
Avun sir, first speaker Prem Narasimhan sir.
Is it hall A or hall B?
Hall B, sir.
How do I get on to hall A then? I think మీరు తప్పు పెట్టారు. Hall A.
అదేరా మనకి వినిపించట్లేదు, ఏం జరుగుతుంది ఇక్కడ?
నేను ఇయర్ ఫోన్స్ పెట్టుకున్నాను.
ఇయర్ ఫోన్స్ పెట్టు.
అంటే ఇక్కడ కూడా ఉంది కదా సార్.
సార్ అక్కడ ప్లే చేయండి అయితే. అట్లీస్ట్ ఒకటి నాకు వినిపించాలి కదా.
నేను చదివేసేనా?
Yes, sir.
ఎందుకంటే హాల్ ఏ స్టార్టింగ్ యాక్చువల్లీ at 8:50, హాల్ బి at 9. కానీ వీఆర్ ఆల్ లాగ్డ్ ఇన్ టు హాల్ ఏ. మళ్ళీ స్విచ్ చేస్తారా మీరు? ఎందుకంటే ఈ లింక్ మాకు హాల్ ఏ అని ఇచ్చారు.
సార్ మీరే స్విచ్ అవ్వాలి సార్.
ఎక్కడికి హాల్ ఏకా?
ఎస్ సార్.
నాకు అది పంపిస్తారా? బికాజ్ డాక్టర్ ప్రసాద్, డాక్టర్ అరవింద్ మాథుర్ వీళ్ళందరూ హాల్ ఏ వాళ్ళు. ఆ లింక్ తప్పించారు.
ఎస్ సార్ పంపిస్తున్నాను సార్ ఇప్పుడు.
నాకు కొద్దిగా పంపించారా? నా మెయిల్ పంపిస్తారా?
వాట్సాప్ చేస్తాను.
ఓకేనండి. I think we'll kickstart this hall B. Okay. Prem, you are ready?
Yes, I am ready.
Pavan? We'll just wait a few minutes because Dr. Pavan is trying to get his background ready. Uma Kalyani madam, good morning.
Good morning, sir.
Thank you for the Suprabhatam. Morning, Dr. Magesh.
Good morning, Dr. Raju and all the respected seniors. Nice.
Thank you very much. Especially the other chairperson for Prem's lecture is trying to get in. Dr. Pavan?
Welcome, Dr. Sapna. Good morning.
Good morning. Good morning. Thank you very much for the invitation.
Thank you, Dr. Swapna. I'm Dr. Raju.
Yeah, good morning, Dr. Raju.
Dr. Magesh, shall we get started?
Yes, Dr. Raju, we can.
I think Dr. Pavan is having a little this thing. The whole thing will again get delayed. So for the first talk in Hall B, which kickstarts this 18th GERICON, the annual conference of the IAG, welcome you all to the academic feast. The first talk is telemedicine in an older adults, boon or bane, by Dr. Prem Narasimhan. He is a specialist in the Department of Geriatric Medicine, Jaslok Hospital and Research Center, Mumbai. He has published a chapter in International Gerontology and Geriatric Medicine, Hazard Textbook of Gerontology and Geriatric 7th edition. He is the chief editor of Gerontology and Geriatric Update, organizing secretary, GERICON 2017, founder member of the research wing of IAG. His particular interests are in geriatric syndrome, dementia, urinary incontinence, orthogeriatrics, geriatric oncology, and perioperative care of elderly. And then he has given a lot of talks and a very academically dynamic young guy. Over to you, Dr. Prem.
Yeah, good morning, everybody. Thanks a lot, Dr. Raju sir, and of course, Indian Academy of Geriatrics and the organizing secretary, Dr. Chandrasekhar, for inviting me on this platform. The fact that we are on a bit of technology and we kickstart with telemedicine, because I think this last 1.5 years has sort of taught us a lot in how telemedicine can obviously be helpful. I would want them to just enable me or make me as host so that I can share my screen.
So try again, sir.
Yeah. Okay. So yeah, I mean, today, of course, I would want to put up whether it's a boon or bane, and of course, I'm sure the verdict will be out. So what is exactly telemedicine? Telemedicine, of course, is the delivery of healthcare services where distance is a critical factor. It is given by all healthcare professionals. The using is of information and communication technologies for exchange of valid information, of course, diagnosis, treatment, and prevention of the disease, and of course, injuries as far as even older adults are concerned. Now, there are many forms of telemedicine. The types of telehealth, sometimes telemedicine and telehealth is interchangeable, but telehealth as such, there is a type which is known as synchronous telehealth. Synchronous telehealth refers to the real-time communication. So two-way video conferencing is used to communicate with patients from afar. Now here, of course, the internet connection and a low-cost microphone and webcam is all sort of needed for the patient, from the patient side, and of course from the doctor's side to make sure that the doctor's visit is possible. Then there is something known as asynchronous telehealth. So synchronous telehealth is usually a store and forward process similar to email. So there will be a secure platform. Providers can share the medical data with their patients and other healthcare specialists. So there are a lot of platforms, of course, which are available. So this is that kind of. So all involved can view the information at different times as opposed to live communication. So basically, it could be like a secure server in which the patient will have access, as well as the healthcare specialists who are taking care of the older adults. Then there is, of course, remote patient monitoring, which is really sort of coming in a big way. It allows us to obviously track all the vital signs using sensors, cameras, and other devices to follow the activities of high-risk patients. Now, all these telehealth will allow us as healthcare providers to offer a vast array of healthcare management services that might not always need home or office visits, but within the same quality of care. So it's trying to basically abridge everything and make sure that everything can be provided in that platform. So types of care that can be provided, yes, of course, there's a primary and follow-up care. Then there will be a home-based care, mental health care, and of course, urgent care. I think mental health care has really took off in the pandemic through telemedicine, in which obviously during COVID-19, people have been isolated at home, especially the older adults. Now, if you look at the benefits, then yes, it will minimize the unnecessary hospital visits, reduces the medical and travel costs, improves the care access, provides ongoing support to patients and family members. Now, increases, of course, the chances of continued independent or you can say community home living, because telemedicine can be provided even to assisted living. Then increases patient access to a variety of doctors and specialists in rural or remote areas. Then decreases the wait time for appointments and decreases exposure to germs frequently, which can be there in the clinic or hospital waiting area. So that is also something which, from our perspective, can be reduced. Now, if you see a bit of disadvantages, one is, of course, it reduces the face-to-face visits with doctors, which may lead to missing key symptoms or concerns. Now, it requires technical ability and access to technology, and may or may not be covered with insurance, and of course, the legalities, which has obviously become more and more sort of easier as we have gone ahead. Because of COVID-19, there are obviously proper telemedicine guidelines which have been put into place. Now, more than the advantages and disadvantages, how to make sure that we have an effective telemedicine in older adults. Now, if we follow the principles of age-friendly health systems, then we will be able to provide a good telemedicine to older adults. So in our consult, what we need to make sure is we need to talk about what matters. So know and align where the older adult has got those specific health outcomes and care. And it should not be limited to end of life, but basically all across all settings. Then medications, I think, are very, very important in older adult care. So we'll have to see that it does not interfere with what matters the most, but at the same time, we are able to get that knowledge. Thirdly, mentation. I think we need to know, of course, in brief through short tests, which can be done through the video as well, that what exactly is their mentation. We'll have to prevent, identify, treat, especially the three big Ds. That is, of course, dementia, then delirium and depression. And we all, as we all know, delirium and we are even in dementia to a great extent, and depression, we want to prevent them rather than only treat them. And mobility, I think, ensure the older adults are moving in that so that it can align in what matters. So usually what I do is try to do a very sort of a up tug, that is a turned up and go test, which I try to do through the video so that I am able to know what their mobility status is. Now, it's very easy to say that we can do telemedicine. Yes, the technology is available, everything is available, but how do we make sure that we are providing the technological support to older adults? So here we have to understand that the clientele that we are involved with, that is the older adults, also need help. So call, or we have to make the staff call to provide the verbal instructions, maybe test the platform if we're involved in the platform kind of consultations, and ensure that the patient knows how to use the technology. Secondly, provide clear written instructions in an easy to read format, including screenshots of the steps. Remember, it is not that the older adult themselves might be the ones who are doing everything. There might be a strong chance that it is actually the relatives who might be younger who might be helping them out. Now, advise the patient either verbally or in written form on ways to enhance the ability to use the technology. I think that is also very important. Now, for example, the patient could raise the display of the illumination, adjust the volume settings, use the captioning, and keep the video platform clear of background noises. Now, a lot of times what happens is as soon as we go on the platform and during the consultation also, there is a lot of noise in the background, which we have obviously at various instances even encountered while presenting. Now, what are the barriers for older adults, especially for giving them an effective telemedicine or a telehealth? Now, one is, of course, lack of access to technology. Now, we have to understand that we are living in a setting which is a mix of urban and rural, and even in urban areas, there are a lot of areas who are not technologically as ahead as maybe certain areas. So, unfortunately, when there is an absence of these technologies, it will be only limited to phone calls, which might work for simple services. But for in-depth care, there is a difficulty. And of course, ultimately, there is a great extent. We also understand that it's not easy just to prescribe the medicines on the phone, because all that is also has its legalities. Then lack of experience with technology. Now, this is about people who might be having maximum exposure to technology. They have the fact that they can do technology also, but they do not have experience. So if they're inexperienced, they might not be able to troubleshoot the problems that arise or cannot adapt to the digital communication. So I think that is also something which can be a hindrance. Now, one of the most important things which we have to sort of understand is hearing, vision, and communication impairments. I think when we are trying to do telemedicine with older adults, it becomes very, very important that we understand. that these can be bigger impediments. So additionally, for example, telehealth encounters which occur outside the control setting, there can be noise, distractions, missed visual cues, which might increase the impediment as far as patient and provider comprehension is concerned. So we obviously will have to iron out these flaws before we get into a proper teleconsultation. Cognitive issues. I think cognitive issues can be really a big problem as far as telemedicine is concerned. Even a lot of people looking at the screen, people with cognitive impairment, they might not be able to look at the screen and may be able to do things properly. Now, strategies might have to include appointment reminders, notes for operating the technology, and seeking a family member's help. So people, of course, with not a major cognitive disorder, but a minor one, they might be able to adjust to telemedicine more easily. Then I think socioeconomic factors is something which we cannot neglect. So older adult socioeconomic factor will obviously affect their willingness or ability to participate. Now, for example, the financial is so bad that they will obviously, the priority will not be technology and try to get on telemedicine. Older adults might obviously have concerns with cell phone plans, data charges, and may prefer only telephone only, just because of the fact that they are just not comfortable on video. There are a lot of older adults who might not be comfortable, but this will limit our provision of care. We will not be able to obviously know what is happening, and the visual communication will go, which is very important as far as comprehension of the problems of older adults is concerned. Now, what are the strategies? I did enlist the barriers. So how are the strategies which we can sort of adopt to make sure that we provide better care? Now, this can be divided into before, during, and after the telehealth encounter. So before the telehealth encounter, what we can do is make sure that they're aware of the ability of telehealth services. They need to be explained about the benefits and limitations of the virtual visits, assure them that we want to provide high quality. Then obviously there could be a staff member contacting them before the telehealth appointments. Usually this will be taken care by the platform if you are already sort of associated with one. They will help in getting through the process of using the application, test the ability to connect and answer any questions that the patient might have. This is obviously to reduce technological challenges, especially during the consult, because the consultation time is limited. It could be 15 minutes, it could be 30 minutes. Now develop clearly written step-by-step instructions. Yes, so that screenshots also, which I mentioned earlier. Now we might have to also evaluate the space. Evaluate the space in which you can conduct the telehealth visits to ensure that there is adequate lighting, that offers privacy, minimizes the potential for noise and disruptions. I think the most important question that a lot of older adults and their relatives have is usually the thing for privacy. So I think that is also important. Then invest in quality telehealth equipment such as cameras and microphones. Yes, to optimize communication with patients. So a headset with a microphone might actually improve the audio quality and reduce the background. You remember, when you are providing a consultation, it's best that you are having a headset, because you have to provide that quality of care which you are actually providing in your clinic. Now, during the telehealth encounter, how do we deal? One is, of course, the 4 framework, which I said, the 4 M's, that is very important. What matters, then medication, mentation, and mobility. So this will help us guide appointments, engage the patients, and ensure the consistency. Now, encourage mostly for older adults to actually use video. However, we will have to be respectful of the fact, limitations and preferences, and whether they will be able to do it or not. Now, we might have to confirm that they are in a quiet and private location at the beginning, and ask if they can hear or see your face, because these are all very important things before we actually get into the actual consult. Then acknowledge the telehealth, that it can be awkward and unnatural, and we need to allay their fears, so that if there is a misunderstanding or they want to clarify anything, because ultimately we need to try to provide care. So this has been developed as a conduit to provide better care and not create more confusion. Now suggest the patients, obviously this could be done by the technical team. They should have headsets or headphones. They might have to have hearing aids, because a lot of times what happens to consults, normal consultations also, a lot of older adults do not bring their spectacles and hearing aids. So it's better that they already have it in. Then speak clearly and concisely while we are trying to look into the camera. We do not want to race. See, communication is still the same when we talk to the patient in person or we are talking normally online. Then watch for the signs that the patients are not following the conversation, or there should not be any confusion or misunderstanding. Now we might have to encourage them to increase the volume, put on their glasses, use maybe a headset, repeat information. In older adults, even in normal practice, you might have to repeat certain information. So online also, it would be better that we're able to repeat some information. Then if an interpreter is needed, then that particular person should be there in place so that they can obviously sort of give better care. Then use a comprehensive technique to confirm that what they have sort of understood. Have they understood also what you are trying to say? Then, of course, after the telehealth consultation is over, as always, as we give a prescription, a written summary of the telehealth appointment, including key points, treatment recommendations, instructions. Make sure that the summary is clear, concise, easy to read and understand. And always, I mean, in any profession, even in our profession, especially on telehealth, I think feedback is very important for the telehealth experience. Some might have a bad experience, some might have good experience. Constructive feedback only helps us in improving ourselves while we are actually trying to provide telemedicine to them. Now, if you have to hit the nail on the head and put at pros and cons, so that we are talking about boon and bane here, I think the real pros will be yes, it is a more convenient and accessible patient care. The cost effectiveness and healthcare savings are there. There is a spectrum which has increased now. Now, for example, an older adult could not think that they would be able to access, I mean, all age groups, of course, the plethora of doctors, not only in India, in one particular region, but even abroad. So even that sort of specialist and referring physician access has increased, where they are able to expand their horizons and even try to consult anybody. Now it increases the patient engagement, yes, and can offer a better patient care quality in a maybe a technological way where we also have data. But it doesn't come without the cons, and very, very important ones. Technical training and equipment is needed. I mean, if you take out the technology out of telehealth, then it becomes very, very difficult for the older adults to even do anything. Then reduced care continuity, it can happen because follow-ups is all directly proportional to how good they are in telehealth, how they are convenient in doing things. Now, fewer in-person consultations. See, as far as we are all concerned as doctors, anytime we would prefer seeing the patient in person, purely because physical examination is something which is a breach, which is a bridge which is not always easy to bridge the gap in that particular. So we will obviously prefer that. And reimbursement and laws, of course, telemedicine laws have come up. They are still, I think, in a very infant stage, but what I feel in future, there will be a hybrid model which we sort of follow now. One of the most unfortunate cons which has also happened is there have been a lot of doctors who have been harassed also on telemedicine, because there have been appointments which have been taken by patients. There has been just recordings. There have been appointments which have been just taken even for, there has also been cases of sexual harassment, especially for females. So there have been those sort of dark areas also. But I think one of the most important things that telemedicine has helped, which I have sort of seen in the last 1.5 to 2 years, is we have now been able to connect to those older adults who were bedridden, who couldn't come to the hospital. We have been able to monitor them. We have been able to connect a patient who is living alone with the child who is abroad, and we have been able to do the consultation together. Maybe earlier that wouldn't have been possible. So obviously telemedicine has its cons and pros, but time only will tell whether it is obviously a boon or a bane. The best step forward, of course, would be to take it as a hybrid model in which we obviously explain to the older adults that this is not a substitution for the physical consult, but it helps us in getting a lot of parameters on board, and it can only help to make our physical consult stronger, because a lot of data, a lot of you can say investigations, everything can be collected, and then adding our physical consultation to that is only going to make our way of diagnosing even more stronger. So yes, it is here to strengthen our arm. It cannot replace it completely, but I think the best step forward would be the hybrid model. So thanks a lot for your patient hearing. I think this was more to, you can say, invoke the thought process whether the telemedicine is a boon or a bane. I feel it is more of a boon than a bane, but we need to make sure that we go hybrid so that we are able to judge ourselves better. Thank you.
Yeah, thank you, Dr. Prem Narasimhan, for the wonderful talk. And you have aptly said that definitely we have to use telemedicine. It is a boom only. Many elderly people will get consultation online. That will be very helpful for them, because moving out in this COVID era is a tough task. I think COVID has elevated these telemedicine options. Many people are already utilizing, and your talk has enlightened all the important aspects of telemedicine in elderly people. Definitely, we all will try to implement it in our practice. Thank you so much for the nice presentation, and thank you organizers for giving me this opportunity. Thank you so much.
Thank you. Thanks a lot.
Over to the next talk. Thank you.
Yogesh.
Chandrasekhar sir, please chair the session.
Light की point using it's maybe better. नहीं better light आ रही है, अच्छी light आ रही है.
Good morning, everyone. I thought I was chairing the session for Dr. Ashish Goyal, is it not? Organizers, please.
Kindly read out the speaker.
No, sir. Kindly read out the
Okay.
ma'am's CV.
Good morning, everyone. I thank the organizing committee for giving me an opportunity to chair the session today. The next session is proton therapy. The speaker will be Dr. Sapna Nangia. She is Senior Consultant Radiation Oncology, Apollo Proton Cancer Center, Chennai. Lead head and neck CMT, skull base, breast and gynec CMTs. She is visiting consultant, Indraprastha Apollo Hospital, New Delhi, editorial board, Apollo Medicine. Formerly, she was chief radiation oncologist, Fortis Hospital, Noida, advisor global cancer concern. Among the early adopters of IMRT in the country, special interest in radiation techniques, pioneering proton therapy for head, neck, breast, and gynec cancers in the country. I request Dr. Sapna Nangia, Madam, to take over for today's presentation. Thank you.
Ma'am, unmute yourself, please.
Good morning, and thank you very much, Dr. Chandrasekhar, and also the organizers of GERICON, and my geriatric medicine colleague, Dr. Bhagresh, for having given me this opportunity. And with your permission, I am going to share the screen.
Sure, ma'am.
I'm sorry, it's a lot of things here. Yeah. Just one moment. Yeah, is my screen visible?
Yes, ma'am.
Yes, thank you. So I will be discussing proton therapy for the elderly cancer patient and also how it is a gentler treatment option for cancer patients. We do know that age is a risk factor for cancer, and about, by the year 2050, it appears that in a very large part of the world, the elderly will constitute as much as 20 to 25% of the population. Patients who are aged 65 years and above are about 60% of all newly diagnosed cancer and 70% of all cancer deaths. Age is a risk factor for cancer, as we can see from the results of various cancer registries of the country. We can see a rising trend with age, and we see here that this rising trend is seen most markedly in the registries of Bangalore and Mumbai. And also a very interesting paper by Dr. Vijay Kumar, DK et al., looking at the need for geriatric oncology, has stated that in the last 20 years, there has been 100% increase in the number of elderly patients in India. The reasons why cancer is more likely in the elderly is because of telomere shortening, accumulation of mutations that may unmask oncogenes, as well as decrease the activity of tumor suppressor genes. Of course, with increasing life, there is an increasing carcinogen exposure as well as exposure to hormones. So this has been recognized. The special needs of older cancer patients has been recognized. There is a Society of Geriatric Oncology, which was the first activity towards looking at the special needs of geriatric cancer patients, and which looks at individualizing treatment approach based on risk and benefit of therapy. What are the instruments that help the oncologist, not just instinct or thumb rules, but proper scientifically validated instruments, as well as how cancer patient treatment itself can impact the aging process of the patient. Since the year 2000, the SIOG, of which I am a member, there have been many others, and the most recent has been the EORTC, the European Organization for Research and Treatment of Cancer, the elderly task force that has been founded in the year 2015. 2021 has been landmark In that, 2 randomized trials have been published which look at the role of geriatric assessment in making cancer treatment safer. Both are in the field of chemotherapy. One is the study by Lee et al., which has come from the City of Hope group. That was where Dr. Aarti Huria, who pioneered geriatric oncology, looked at geriatric assessment-driven intervention and noted that when patients were treated for after geriatric assessment-driven intervention, they were less likely, significantly less likely to have hematological and non-hematological toxicity. And they were also more likely to have completed their advanced directive. There was a significant difference. Of course, it is also important to note that this did not impact the average length of stay or hospitalization. After that, there has been recently another study which has looked at by Mohile et al. From Rochester, which has again underlined the fact that geriatric assessment-driven interventions do make treatments safer for patients. Now, coming to the role of radiation in the treatment of cancer, the treatment intent may be radical, where we are using radiotherapy or the treatment by ionizing radiation, basically, in radical intent, for example, in treatment of the nasopharynx, treatment of the larynx, anal canal, carcinoma cervix, or we may be using it as adjuvant to improve the outcomes after surgery, for example, in breast cancer, and multiple other locations, buccal mucosa, tongue, and so on, stomach cancer, where we are using radiation as an adjuvant to improve the outcomes after surgery. We may use it as neoadjuvant meaning that we are using it as a preparatory therapy. For example, we may use this as a preparation for carcinoma esophagus, where we may use it both as a radical treatment as well as neoadjuvant strategy. Or in carcinoma rectum, we use it to reduce the risk of margin positivity and improve the chances that the patient may not require an abdominoperineal resection and a colostomy. We also, of course, use it with a palliative intent. Radiation has become very modern over the last many decades. Incorporation of the availability of linear accelerators as well as computerized treatment planning has made treatment very precise. So every patient will undergo this kind of a CT scan where the doctor will delineate what area has to be treated and delineate all the organs that have to be protected. So this, as you can see, is a model of the patient where the doctor has delineated the stomach bed in a patient who has stomach cancer. So the stomach bed, the porta, etc. have been identified as the areas that have to be treated, and the organs are created in 3 dimensions. Then the radiation plan is created. The radiation plan ensures that the treatment is being delivered very conformly to the area that has been identified as the area at risk. However, the organs at risk are being protected. Am I quite clear? Hello?
Yes, Dr. Sapna, we can hear you clearly.
Thank you. And then this is image-guided radiation. Image-guided radiation means checking the radiation before delivering the treatment. Before you deliver the treatment, you take a scan of the patient on the linear accelerator, match the position of the patient absolutely precisely, and then go forward. So this is what modern-day radiation, even prior to proton, it does and makes radiation safer for patients in general. And there is the concept of organs at risk. So as you can see, there are 3 sides here. In head and neck, the organ at risk is going to be the parotid, as well as the swallowing musculature, the mucosa. In this patient of liver, the organ at risk is going to be bowel, the kidney, the spleen even, and also in this spleen patient, can I request can the organizers please mute everyone? Yeah, thank you. So, sorry. And in this patient who has a brain tumor, the brain itself is an organ at risk. What is the concept of organ at risk? The organs at risk have to be identified. We know that the dose that spills over to these organs at risk is responsible for the side effects of treatment. These side effects come in acute from inflammation and impact on organ function. As an example, I would say that if we are treating head and neck cancer patient, there will be denudation of the epithelium. And because of that, there will be exposure of nerve endings, there will be inflammation, higher cytokine release, there will be neuropathic pain, and there will be loss of the barrier for infection. And this kind of scenario is replicated elsewhere. For example, in the gut, there will be loss of mucosal absorption surface because of villus shortening. And there can be an impact of function. For example, in the parotids, there can be reduced salivary secretions. In the ear, there can be a serous otitis media. In the lungs, there can be pneumonitis. Therefore, the reason that we have to restrict the dose to these normal structures. Chronic toxicity arises from endarteritis, which leads to fibrosis. And this too can impact organ function. For example, the risk of cardiac disease has been correlated with outcomes in esophagus and lung cancer. And the concept of tolerance dose, which is based on radiobiology. So radiobiology is a science, and the science of tolerance doses is very well understood now. What is the dose an organ can tolerate, and what is the protective, mechanism that we have to use. So for example, for a head and neck patient, there would be multiple organs that we would delineate and prescribe a dose constrained to. So what are the issues and dilemmas when irradiating the elderly? We have to be cognizant of the special needs and the different goals. We also have to be cognizant that frailty is our destiny. This was a lovely editorial by in the Red Journal, which is a special issue on radiation therapy in the elderly. What are the special issues of the elderly? We have to balance life expectancy. We have to note that the patient may be frail and therefore not able to tolerate the treatment or even come for treatment. There may be cognitive dysfunction about being able to follow the advice of the treatment team. If the length of treatment is long, then there may be social issues. Who is going to bring the patient to the treatment for treatment? There may be, will the child or the grandchild be able to take leave to bring the patient to the treatment? What is the tumor biology of the elderly patient? Is it different from a younger patient? It could be, because, for example, we know that elderly patients are more likely to have ER/PR positive tumors. When we are talking about breast cancer patients, they are likely to have better prognosis tumors. And most importantly, elderly patients are often excluded from trials. So which are the various strategies for radiation in the elderly? One is that we need to define their goals. We could de-escalate treatment, which means that we could give them a smaller dose. We could give them smaller volumes. So in the very elderly, we may omit elective irradiation. So for example, in a head neck patient, we would limit the dose only to the tumor and not treat microscopic spread, which we would do in a younger person. Sometimes it may even mean omission of treatment. It may mean alteration of technique for shorter treatments, such as a planned break. For example, very often in the elderly patient, we will give a planned break of about 5 days or 1 week, understanding that to preserve the quality of life, we are accepting a slightly inferior result of the radiation. And then we come to using more conformal techniques. When we say conformal, we mean we want it to conform to the shape of the tumor and not spill over into the normal tissues. One of the advances that has taken place with this is the development of SBRT, stereotactic body radiotherapy, highly focused, small number of fractions, 3 to 5, very focused radiation, which has now, as you can see, this is in a single year, 80 years old, 90-year-old patients being treated with stereotactic body radiotherapy for lung cancer. And for the elderly patients, we know from meta-analyses that in early stage lung cancer, now stereotactic body radiotherapy has become the treatment of choice rather than surgery, where there may be a 3 to 5% mortality, while SBRT is not associated with any modality. Similarly, with the years, it has become safer to give patients of head and neck cancer chemotherapy, which is what they need. So while in the year 2000, maybe about 20% of 2005, about 20% of patients could receive CTRT. But in this study of 70 patients, concurrent chemoradiation was possible in about 50% of patients, over a time period of 7 years. It had the ability to give chemotherapy had improved because we were using techniques which were more conformal, which we were giving to a slightly more focused to the tumor and separating out, not treating the normal tissues. And the advantage of this was that when patients were given this chemotherapy, their survival was better. This chemotherapy was possible in a higher proportion of patients who were receiving the more conformal techniques, which is what brings us to proton therapy. Proton therapy is a highly focused form of radiation. So I have this cartoon here. This is the tumor, and this is normal radiation. It travels through the tumor and exits behind the tumor. Proton therapy does not exit behind the tumor. And it deposits its energy at a pre-specified location, and no radiation travels posterior to the tumor. So now there's a bit of the tumor that has got missed. So we will use a smaller energy and then another smaller energy and cover this whole area with the adequate radiation, but make sure that the following tissues are not getting radiated. Now, this is the Proton Therapy Center at Apollo Proton Cancer Center, and I will be presenting the work that we have done here. This is the only proton therapy center in this part of the world. So there are a number of centers in Europe and the US, as also in Japan, which has always been a believer in proton therapy. However, Southeast Asia, South Asia, and Middle East have not been, have not had this facility, and we are indeed privileged. And we have a sense of responsibility about bringing this technology into the country, where the current technology that we have, the pencil beam scanning technique, is the latest technique vis-a-vis the previous techniques, in which it is a more conformal technique. Again, the radiation dose is being given in pinpoint 3 millimeter, like arrows, beams of radiation, as you can see here, painting the tumor layer by layer and not going to the surrounding tissues. This is the most dramatic representation of what protons do. This child requires craniospinal irradiation. We wish to treat the brain, the spine, and the vertebral bodies. We do not wish to treat the organs that lie in front. In normal radiation, all these organs are bathed in low-dose radiation, increasing the risk of growth retardation and second cancers. However, in proton, as you can see, the radiation is limited to the area that we have defined, and all this extra radiation is being avoided. And that is the big hallmark of proton therapy. What is its relevance in the geriatric age group? I will use this illustrative example of this 73-year-old gentleman who had nasopharyngeal cancer. He requires radiation, high-dose radiation to the area that is being covered in red, and low-dose radiation to the area that is being covered in mauve. Every other radiation is extra. So this is how a good quality X-ray-based radiation would have been delivered. It would have given dose to his oral cavity. It would have given dose to his nasal cavity and to the posterior pharyngeal wall, none of which was needed. It would also have given dose to the brain, which too was not needed. In proton therapy, all these doses are avoided. And this is a comparison of his proton dose and his IMRT dose. And you can see that all this excess radiation is not being given in the proton treatment, which means that he will have less mucositis and less cognitive dysfunction. Very relevant in a 73-year-old. So this is the kind of comparison. As you can see, there is between 30 to 60% reduction in the dose being received by the temporal lobe, 55 to even 90% dose being received by the hippocampus, which is, again, as we know, the seat of cognition. As you can see here, even the oral mucosa is being spared in the proton plan as compared to the photon plan, which means that his risk of pain, infection, tube feeding, and requiring narcotics is going to be less, all of which are relevant in a senior citizen. As we can see, this oral mucosa can be the dose received by the oral mucosa in this study that we have seen that has come from Europe, which has looked at from Netherlands, basically. The dose to the oral mucosa, radiation dose received by the oral mucosa, is responsible for dysphagia, aspiration, xerostomia, sticky saliva, mucositis, hoarseness, speech problems, oral pain. And when we reduce the dose to the oral mucosa, we make a substantial difference. And this has been our experience at the Apollo Proton Cancer Center. Of 22 patients treated with oral cavity and oropharyngeal cancers. What you're seeing in the red bar diagram, red triangle, is the dose that would have been received if the patient had received X-rays, IMRT, etc. And the blue is if we had treated with proton. So as you can see, at multiple dose levels, the 39 gray volume, the 32 gray volume, 45 gray volume, gray being the unit of radiation, there is a difference between, there is a reduction of dose that is being given when the patient is receiving proton therapy. This is very marked when we look at the oral mucosa that is lying outside the tumor. Outside the tumor, at various dose points, there is the dose reduction ranges from even up to 50% reduction in the dose being reduced by the oral mucosa. What does this reduction mean? This reduction means that the probability of mucositis, we calculate that by using a technique called normal tissue complication probability. That reduces substantially. And I would like you to look at this lower bar here. In the elderly population patients, while with X-ray based radiation, there is a 40% risk of developing mucositis. With proton therapy, that risk is reduced to 26%, a significant difference. And this is the representation of that in the patient. These are actual images of our patient. This patient is an elderly patient who has a C8 tongue and she has a flap in this area. We can see that at the completion of treatment, there is no mucositis. Another elderly 80-year-old lady, post-operative, C8 tongue with no mucositis in the palate or the cheek. Elderly adenoid cystic carcinoma patient with pulmonary sinus tumor with no. Can you please?
Sir, can you mute Mr. Muthineni's iPad? Can you mute, please?
Yeah. So again, we see that there is no mucosal inflammation in the palate and in the buccal mucosa. That is really the critical difference. A few other sites, this 82-year-old patient with an asymptomatic, so this is a chordoma, a 4x4 lesion in 2019, had become an 8x7 centimeter lesion in 2021, presented to us at APCC with moderate to severe urinary symptoms, catheterized, had deteriorating renal functions. This patient was treated under the care of Dr. Srinivas Chilkuri, my colleague who looks after.
Sorry, technical team, can you help us here? Can you mute the microphone? We're not able to hear because of it. Technical team, can you support us?
Yeah, I'll resume now. So this is what we find. This is the sarcoma, the sacral chordoma. It's a very high dose, 70 gray, that we are giving. And yet we find that virtually no dose is spilling on to, so what you're seeing in red is the prescription dose. And what you're seeing in blue here, the blue line that you see, is just 20% of the prescription dose, which means that no dose has spilled on to the bladder, to the bowel, and most importantly, in an elderly person, also not on the femoral heads, to reduce the risk of developing avascular necrosis. And this is in spite of this being a very significantly large target. Another patient, retroperitoneal sarcoma. Now we have to give a very high dose. This patient had multiple comorbidities with very poor cardiac status, not a candidate for surgery, which would have been the ideal treatment. As you can see here, a very large retroperitoneal sarcoma. And then when we see the dose, we have been able to give a dose of, about 70 gray. The bowel does not tolerate this kind of high dose. The bowel tolerates at the max of 45 to 50 gray. And here we have been able to limit the dose. This is the 35 gray volume, and therefore no dose going on to the bowel on this side. And this patient, who was an 82-year-old patient with multiple comorbidities, has recently completed his treatment. You can see here how much attention has been given to creating a sub-volume here, which is adjacent to the bowel loop, where the dose has been reduced as compared to the dose being received inside the tumor. So we have currently treated 57 patients who are elderly, of which 40% had 2 or more comorbidities, the median comorbidity index being 7, and the median frailty score being 4. Large preponderance of patients were male, and the most common patients were head and neck, prostate, lung, as well as brain. A substantial number of patients, 20 out of these 57 patients, were older than 75 years. A significant number of patients were also received re-irradiation. 80% of these patients who required concurrent chemotherapy received chemotherapy, and 80% of them could complete the planned course of radiation, which is very significant for the elderly group of patients. And a very, as we can see here, the grade 3 toxicity, which is the moderately severe toxicity rate, is actually quite reasonable at 6%. Only one patient developed a grade 4 toxicity, which was thrombocytopenia. However, most patients only had grade 2 or more toxicity. As I had mentioned earlier, one of the ways in which patients, what happens to the elderly cancer patients is that there can be a break, an unplanned break. However, in our group of elderly patients treated with proton, only 10% of patients required a break. And the average treatment gap in these patients was only 2.8 days. Again, less than 20% of patients required a hospital stay, and the average stay was quite limited. The treatment gap reasons were also, of these 6 patients, only 2 patients really had acute toxicities. 2 patients had infections, and 2 patients, because their contours had changed, they had either gained weight or lost weight, and their plans had to be redone. So very reasonable, we could say a good tolerance. This indicates a good tolerance. And at a median follow-up of 10 months, about 3/4 of the patients are alive. And no patient, most importantly, has developed a late grade 3 radiation-induced toxicity. These are some of the benefits, as you can see, why these benefits are accruing. These are patients, head and neck cancer patients. The lower bar is what would have happened with conventional radiation. So much of those would have spilled over onto the normal structures. And this is the same diagram that I had shown you earlier. And here we can see with proton therapy, the dose being reduced to the brain, the dose to the bowel and the spleen and the liver being reduced, and the dose to the mucosa being reduced. These patients have also been treated by my colleagues, the liver patient by Dr. Ashwathi Matthew, who looks after GI malignancies, and the brain patient by Dr. Jalali, who's an internationally renowned neuro-oncologist and our medical director. Now a comparison, my last couple of slides, a comparison with already published data of geriatric radiation oncology from India. So we have compared our data with 247 patients published by Vashisht et al. And we can see that the proportion of patients receiving concurrent chemotherapy in our group was significantly higher. The hospital admission in this particular group was about 35% of patients requiring hospital admission versus in our group under about 15%. Treatment interruptions were less. No patients had treatment gaps of more than 10 days. However, in the reported literature, it is more in the range of about 20% of patients requiring treatment gap for 10 days or more. Very few patients who could not complete treatment and no grade 4 toxicities in the long run. So we are, of course, very delighted that we have recently inaugurated a geriatric care cancer clinic where our patients are undergo a geriatric assessment and intervention by Dr. R. Magesh. And this clinic was inaugurated on the International Day of the Elderly by 2 of our senior citizen patients, both nonagenarians and both doing well with God's grace. We have also recently submitted the senior study, which is a pilot study for comprehensive geriatric assessment of elderly patients undergoing treatment at APCC. And I'd like to acknowledge our scientific officer, Dr. Pankaj Panda, for his assistance in preparing this study, along with Dr. Magesh and a few of my colleagues. I would also like to acknowledge, besides my radiation oncology colleagues whom I have already introduced to you, Dr. Utpal Gaikwad, who is also a young radiation oncologist who has helped me prepare the data as well as slides. And this is our team of medical physicists and radiation therapists who do both photon treatments on tomotherapy as well as proton therapy, and of course the entire team that goes towards a holistic management of a geriatric patient. Thank you very much for your attention.
Thank you, madam. The technical team, can you unmute my mic, please?
It is unmuted, sir.
Thank you, madam. Thank you for the very nice presentation. Thank you for enlightening us regarding the proton therapy, its advantages versus the conventional radiation therapy, regarding less treatment gaps, the less toxicity, as a promising modality of management for our future geriatric patients and geriatric cancer patients. You had a very good presentation, madam, because I was totally naive to this topic. I don't know one such kind of modality exists also. Thank you for enlightening us today morning, madam. Do you have any questions for madam on the screen, please? The tech committee. The tech team.
Thank you, Dr. Sapna. I think it was very valuable to have this talk to our physicians and geriatric colleagues. It was well presented, and it was very clear for us to understand the benefits of proton therapy. Thank you.
Thank you very much, Dr. Magesh.
Thank you, madam.
Magesh sir, can you please read out Alladi Mohan sir?
Yeah. Good morning, all. I invite Dr. Alladi Mohan, sir, for the talk on TB in elderly. He is well-known speaker and he is very much expertised in tuberculosis. He has done so many research on tuberculosis. Now we would like to listen from the legend speaker of our API. He has so many publications and he has received Best Teacher Award, and he has worked a lot in tuberculosis part, and he has edited textbook of tuberculosis mycobacterial disease along with Professor S.K. Sharma sir, and would like to listen him on the topic of TB in elderly. I invite Dr. Alladi Mohan sir to deliver the talk. He is presently Dean and Professor and Head of Department of Medicine, Sri Venkateswara Institute of Medical Sciences, Tirupati. I welcome Dr. Alladi Mohan to deliver on the talk.
Thank you, sir, for those kind words of introduction. And in the next 20 minutes or so allotted to me, I'll share my view with regard to the TB in the elderly. If I may be permitted to share my screen. Yeah. The topic is intriguing and interesting because it's a topic which is of great relevance in the modern era. I declare that I have no conflict of interest and I have not received any financial support to deliver this talk. I would like to first bring to your notice the data from the 2021 Global TB report that was just published about 35 days ago. If we look at the TB incidence for the year 2020, India remains a high TB burden country, which is a cause of concern because India has 1/4 of the world burden of TB. Now, if we look at the population pyramids of the world, which is shown in the upper panel, and the population pyramid of India, which is shown in the lower panel, as we progress from 1950s towards 2025, it is obviously evident that the elderly population is gradually increasing. Given that a major chunk of the world's burden of TB is in India, and the Indian elderly population is growing exponentially, the deadly interaction between the TB epidemic and its effect on the elderly is tangible and is of great clinical significance. If we see the trends over 1993 through 2011, these are the data from the United States. I'm sharing these because these data are very meticulously documented. The same is seen in the other parts of the world, including India as well. It is obvious, while there is a declining trend in TB across all the age groups, the slowest decline or the highest occurrence has been in the persons aged over 65 years. There is a decline, but in the elderly, TB still constitutes a major diagnostic and treatment problem as well. Is aging a risk factor for TB? There has been a lot of debate and research in this particular area. Generally, one can simplify that the absolute risk of TB in the elderly is primarily influenced by two things: the prevalence of the latent TB infection and the risk of reactivation. Now, there is a epidemiological concept which one should keep in mind. This is called as the generation or the birth cohort effect. The peak of TB related mortality in later life does not represent the postponement of maximum risk to a later period, but rather would seem to indicate that the present high rates in the old age are the result or the residuals of higher rates in earlier life. It's a very important concept to keep in mind. But notwithstanding this, in the contemporary era, it is obvious that the elderly are at a higher risk of developing TB, and this is particularly evident in countries where there has been a sustained improvement in TB control. We are worried caring for the elderly because the elderly are at a higher risk of developing TB. What is the importance of reactivation versus reinfection? In TB high burden countries like India, 85% of post-primary TB is because of reactivation. Post-primary TB means TB which we see in the adults and the elderly, because in high TB burden countries, primary TB is a disease of children. So post-primary TB is seen in adults, and the relative distribution of the reactivation versus reinfection is 85% and 15%. That means in high TB burden areas, exogenous reinfection is an important cause of post-primary TB. But with regard to the elderly, even in low burden countries, at least 1/4 of the cases could be because of exogenous reinfection. So we should keep in mind not only the reactivation, but also the reinfection as a tangible cause of TB in the elderly. I will touch upon this significance a little later in the course of my talk. There is something called immunosenescence. Immunosenescence is a decline in the immunity which occurs with aging. And this is manifested by defects in the hematopoietic bone marrow, impaired peripheral lymphocyte migration, maturation, and function, as well as the chronic involution of the thymus gland. Among the many other things, immunosenescence is considered to be a major risk factor for the higher occurrence of TB in the elderly. The other points which are risk factors for TB, such as alcoholism, diabetes mellitus, use of other drugs which are immunosuppressants like corticosteroids, the anti-cancer chemotherapy drugs, post-solid organ transplantation, immunosuppression, etc., are pretty much common, more common, relatively higher in the elderly compared with the young, and therefore, in addition to the aging and the immunosenescence, the higher occurrence of other risk factors, which I have just now mentioned, also makes the elderly vulnerable to catch TB as they age. What are the tangible differences, clinical differences in the features of TB in the elderly? While in the young, the constitutional symptoms like fever, night sweats, and these are very common in the young with TB. They may be absent or minimal in the elderly. When you take pulmonary TB, symptoms such as cough, hemoptysis may not be so prominent in the elderly compared with the young, where they are the obvious symptoms. And if you look at breathlessness as a presenting symptom primarily in the elderly, it is a prominent symptom as opposed to the young. The comorbid conditions are quite common in the elderly compared with the young. as is hypoalbuminemia and a poor nutritional status. Tuberculin skin test positivity may also be low in the elderly compared with the young. This is the tuberculin anergy, which may be related to the immune senescence with aging. One should also keep in mind there are more number of adverse drug reactions in the elderly as compared to the young as far as anti-TB treatment is concerned. So if we look at how TB presents in the elderly, TB may present as pulmonary TB or extrapulmonary TB. This is the classical textbook description. However, in the elderly, one may encounter what is called PUO or pyrexia of unknown origin as the initial presentation of TB. It can be occult TB, it can be overt TB, it can be local focal TB, it can be disseminated TB or miliary TB. There's one particular entity I'd like to bring to your notice is what is called as cryptic miliary TB. Described initially in the late 60s by Proudfoot, cryptic miliary TB is a form of miliary TB in the adults, especially the elderly, in whom there are no symptoms except wasting. And after the person dies, when you do an autopsy, the post-mortem examination will show evidence of miliary TB. This is a very important presentation. Till the late 60s, miliary TB was considered a disease of the pediatric age group, the very young. The hard data that miliary TB, especially the cryptic miliary TB, would be seen in the elderly was documented in the late 60s. And till 1990s, cryptic miliary TB was a post-mortem diagnosis. But for the first time in the world, we showed in this paper that cryptic miliary TB can be diagnosed in the elderly when they are alive. That is the ante-mortem diagnosis of cryptic miliary TB. Let's see how this can be done. This person presented to our outpatient service with hardly anything other than tiredness, feverish feeling, and weight loss over 8 to 10 weeks. This was the chest X-ray taken at that time. We thought it was normal. The radiology at the institute reported it to be normal. Later on, the person kept on coming week after week for another 2 to 3 weeks with nothing but fatigue, weight loss. At that point in time, there was a new kid on the block. CT became available, the HRCT. The story goes back to the early 90s. So there was a new technology that was available, and by some premonition or good luck, we thought we'll do the CT of the chest. The CT of the chest done a few days after the chest X-ray showed a florid classical nodular shadows suggestive of miliary TB. Given that there was no history of fever, there was, other than wasting, nothing was there. The radiology suggested it is probably lymphangitis carcinomatosa or some other such differential. Then we re-examined the patient again. It was till 2-3 weeks, this was a ritual. But suddenly we hit upon a tangible lymph node in the neck. And when we did the biopsy, it showed a classical histological proof of miliary TB, epithelioid cell granulomas, caseation necrosis, AFP. This case taught us very important lesson. In the elderly, presenting with nothing other than fatigue, inanition, weight loss, even with the chest X-ray normal, a HRCT of the chest can show a miliary pattern, and careful re-examination, doing the physical examination at each visit again and again and again will provide access to tissue which will help in getting a tissue diagnosis of TB. Then when we looked at the fundus showed choroid tubercles. After this, we have been teaching to generations of postgraduates over 2 to 3 decades. My first year PG will pick up cryptic miliary in the elderly within no time because they are sensitized to this particular way of presentation. I thought I'll share this experience with the experts who deal with the elderly so that a HRCT chest, which is a very useful tool, which is widely available now to screen whenever there is a suspicion of a treatable cause like TB, to look at the chest. What are the treatment outcomes of the elderly with TB? Hard data show that treatment outcomes in the elderly are often worse. The risk of death in the elderly remains elevated. Many reasons: compliance issues, poor eyesight, poor memory, lack of determination to complete 6-month-long therapy, dependence on others to access healthcare, and so on and so forth, coupled with poor immune response to TB infection and so on, the outcomes have been poor. And the bright side is, since more than 80 to 85% of TB in the elderly is due to reactivation. When the elderly were young or children, that TB they caught would be less likely to be drug-resistant TB. The likelihood of drug-resistant TB in the elderly is somewhat less, definitely. The occurrence of HIV co-infection in the elderly is also less compared with the young. These are the brighter things, but the outcomes are poor in the elderly. So there is a check-balance system here. One has to be very careful in performing an aggressive diagnostic workup of TB in the elderly. And the occurrence of the adverse drug events is very high in the elderly as well, because the elderly have poor renal function often. The elderly have poor hepatic function also. I will address this a little later, speaking about the latent TB in the elderly. This is a very important take-home message, because even the program is thinking of treating the LTBI. Now, as on date in high burden country like India, elderly age alone is not an indication for treatment of LTBI. If there are other boundary conditions, they may require treatment. So the elderly, in summary, are vulnerable and they have more likelihood of developing TB. The clinical presentation of TB is atypical. In the elderly, TB is often a delayed diagnosis, a misdiagnosis, a misdiagnosis, I would even say a messed diagnosis. Compared with the young, treatment outcomes are worse. Drug-induced hepatotoxicity is 5 to 10 times higher in the elderly. That will result in poor compliance. A low renal function is pretty common in the elderly due to associated diabetes, hypertension, and per se higher occurrence of chronic kidney disease. Now, note the importance. The RNTCP of the older time, now called the National TB Elimination Program, since 2020 January, has introduced ethambutol throughout the treatment. So presently, the intensive phase is RHZE, the continuation phase is RHE. E is used throughout with declining renal functions like the elderly, the ethambutol nephrotoxicity. When there is clearance of ethambutol is reduced, ethambutol-induced ocular toxicity is also a major concern. Ethambutol-induced ocular toxicity, especially when you use throughout the treatment, is a major concern. Declining renal function in the elderly associated with higher occurrence of chronic kidney disease. And this has a bearing on ethambutol metabolism, reduced renal clearance, and higher occurrence of the ocular toxicity of ethambutol. Mind you, the ocular toxicity of ethambutol is a retrobulbar neuritis. It is a disease where the doctor sees nothing and the patient sees nothing because patient will go blind. It's very important to keep in mind this. You have to do a Goldman perimetry with a red-green target in the elderly, especially if you are giving ethambutol throughout the duration of treatment. As I told earlier, the treatment outcomes are worse in the elderly, and it remains unclear what is needed to be done to mitigate, to lessen, to reduce the excess mortality among the elderly with TB. The important take-home message is, notwithstanding all these things, TB is curable, treatable, curable. There is a need for a high index of suspicion to consider TB in the differential diagnosis and institute specific anti-TB treatment early in the course of disease. This can be life-saving, especially in dangerous forms, life-threatening forms of TB like TB meningitis, miliary TB, which can be a component of the cryptic form of presentation of the TB in the elderly. As we have an Indian standard time, not an Indian stretchable time, I think I'm well within my limits. I would like to place on record my heartfelt thanks to my mentor and my teacher, Professor S.K. Sharma from the All India Institute of Medical Sciences, New Delhi, because of whom I am here. And I reiterate Rantideva's prayer. Let's all join to end the misery of all creatures who are afflicted with grief, including the elderly with tuberculosis. I thank the organizing committee, especially Professor Chandrasekhar and Professor Y.S. Raju, who gave me this opportunity to share a few of my thoughts regarding the TB in the elderly in this important conference today. With this, I complete my presentation, and if the chair permits any questions, I'll be glad to take them. Thank you.
Magesh sir, please, chair.
Thank you, Dr. Mohan, for an enlightening talk and for sharing your experiences. It was definitely very useful for all us geriatricians when we encounter a patient with frailty. If there are any questions, I would like to be shared with me so that I can ask Professor. No questions have reached me, sir. So I take it we enjoyed your talk. Thank you very much.
Thank you very much, sir.
Next session in Hall B is inaugural session. It will start at 11:50. Thank you.
so much of contribution in the advancement of the academy, and we all are aware that Dr. Prasad was the head of Department of Geriatrics at Christian Medical College, Vellore, where he is right now medical superintendent also, and he would be delivering the presidential oration. Over to you, Professor Prasad Matthews, please.
Thank you, sir, for that kind introduction. I'll be, is my screen seen, sir?
Yes, sir. Yes, sir.
Yeah,
It is visible, sir.
we can
But make it
it's
in a slide mode, sir.
Okay.
Slide
I'll
mode, not
be
yet.
giving a talk
Sir,
on the spectrum of vascular cognitive impairment. This is not meant to be a comprehensive lecture, but more of an overview of some aspects of vascular dementia. A lot of the I hope you can see my slides, sir.
Yes, sir. We're able to see your slides clearly.
We can see it.
Okay, the DSM-5 criteria have been around for many years now, but they're still mysterious for many because of their complexity. So when you compare the DSM-4 criteria and the DSM-5 criteria, so the DSM-4, memory impairment has to be there, plus at least one of the following, one of the other domains. While in DSM-5, there has to be, you can diagnose minor neurocognitive disorder or major with even involvement of just one domain. So one or more domains have to be involved. If it's interfering with day-to-day activities, then it's major. If not, it's minor. So as you know, some more domains have been added in DSM-5, and these are complex attention, which can be classified as sustained attention, divided attention, selective attention. For example, difficulty with coping with multiple stimuli, easy distracted. Perceptual motor incorporates apraxia and agnosia, also visual perception, visual construction. And social cognition is basically problems with behavior, social insensitivity, etc. So obviously the complexity of assessment with neuropsychology, DSM-5 is more. But this is more for research, and for practical standards, I think DSM-4 is quite good for us. Now, as medical students, as PGs, we all knew about multi-infarct dementia, and Newcastle upon Tyne has been one of the pioneering institutes for pathological assessment of the brain before imaging came out in a big way. So according to their research in the 60s, vascular dementia was related to multiple brain infarctions exceeding a certain threshold. And it was through occurrence of multiple small or large infarcts. And this led to the widespread use of the term multi-infarct dementia as being synonymous with vascular dementia. And classically, what we learned as medical students was that of an acute event followed by stability and stepwise deterioration with each new infarct. So this is a classic multi-infarct dementia. Two old infarcts on the left side and one new one marked by the arrow on the right side. So that is a classic multi-infarct dementia, multiple wedge-shaped infarcts. So vascular dementia is the second most common type of dementia, and it's a cause or contributor in 25 to 50% of cases of dementia. In clinical pathology, the interesting thing about vascular dementia is in pathological studies, pure vascular dementia is relatively uncommon, accounting for only approximately 10% of dementia cases. And mixed dementia with a vascular component, most often in combination with Alzheimer's, is more common. And this accounts for approximately 30 to 40% of all dementia cases. So mixed dementia is more common than pure vascular, and this is especially so in the elderly. So again, these two studies show that vascular comorbidities may be present in 30 to 60% of Alzheimer's patients, and Alzheimer's pathology may be present at autopsy in 40 to 80% of vascular cognitive impairment. This Professor Erkan Junti from Finland is one of the pioneers of research in vascular dementia. And at one conference, which I happened to attend, he made this statement: dementia in the elderly is always mixed. Of course, he was exaggerating, but basically what he was saying was, with number of comorbidities and problems, as you get older, there may be more than one cause of dementia in an elderly person. Now, I'll just go through some of the common types of vascular abnormalities that can cause cognitive impairment in the elderly and in younger people. An MRI, as I said, is a revolutionized diagnosis of vascular abnormalities causing dementia. So this axial flare MRI shows a chronic cortical infarct in the right parietal lobe. It's white on flare. And you can also see some white matter disease there. So this is a classic infarct. Now this MRI, axial flare, shows lacunar infarcts which are marked by arrows. So these lacunar infarcts are round or ovoid fluid-filled cavities of between 3 and 15 millimeters in diameter with a white rim on flare. So what is the significance of lacunar infarcts? They are more easily recognizable in MRI and less so in CT scans. So what is the significance of lacunar infarcts for cognitive impairment? So there are certain guidelines in a person with memory impairment. So if the baseline cognition was normal, more than 2 lacunes outside the brainstem would generally be considered as necessary to support a diagnosis of VCD. So you should have 2 or more, with just that. And single lacunes placed strategically in the striatum or thalamus may produce a VCT, vascular cognitive disorder, that is called strategic infarct dementia, but it should be temporarily related to the lacunar infarct. And occasionally, you can have single lacunar infarcts, which can also precipitate vascular dementia, especially when associated with extensive periventricular and deep white matter lesions. Now, this axial flare MRI shows extensive white matter disease, what used to be called as Binswanger's disease, involving almost the entire white matter. So we are familiar with Fezzica scale, which we have seen reported on MRIs of our patients. Grade 1 with just periventricular caps on the top images. Grade 2 with smooth periventricular halo on the second one. And grade 3 is severe with confluent white matter disease extending into the subcortical deep white matter. So can white matter lesions be sufficient for mild vascular cognitive impairment or vascular dementia? According to the guidelines, white matter lesion should be extensive and confluent. And if previous imaging was there, if the white matter lesion is extensive and new, this could also be supportive. But generally, you would need some lacunar infarcts as well, as I said in the previous slides. For mild VCI, white matter lesions may be sufficient without other vascular pathology. For vascular dementia, additional presence of lacunes is necessary, which is not uncommon. Now, the picture on the left is showing a cortical bleed, which is the white lesion in the temporal lobe, and also multiple cortical microbleeds, which on this axial SWI MRI look like little black holes in the cortex. All these black holes here are signs of microbleeds, lobar microbleeds. And the picture on the right side, we are seeing a deep bleed in the basal ganglia here, and we are seeing microbleeds in the opposite basal ganglia. Now, when we see lobar hemorrhages, we are thinking of cerebral amyloid angiopathy. and we are seeing deep hemorrhages, we are thinking of hypertensive hemorrhages, both with respect to the microbleeds and the larger bleeds. So multiple hemorrhages or hemorrhagic infarcts are often associated with vascular cognitive disorder. As I said, the cortical ones are mainly related to amyloid, and the deep ones mainly related to hypertension. So since microbleeds are not uncommon in cognitively normal older individuals, before attributing VCD to these, especially vascular dementia, should carefully exclude other causes of cognitive impairment, only if these lesions are numerous. This is a paper from JAMA Neurology in 2016, showing an association of cerebral microbleeds with cognitive decline and dementia. So model 1, model 2, and model 3 are adjusted for various covariates. So in model 1, you can see that microbleeds were at baseline were significantly associated with development of dementia. Model 2, once you adjusted for a lot of risk factors, it was no longer significant. But model 3, it was significant. So basically, all these lesions, microbleeds, lacuna infarcts, and white matter disease are consistent with small vessel disease, except for the cerebral large bleeds, and can cause dementia. Now, looking at amyloid angiopathy, now the first part which I've marked with an arrow relates to postmortem, which we hardly ever get. But generally, when you're seeing lobar hemorrhages, you are thinking of amyloid angiopathy. Now, the other abnormality that is seen in MRIs with patients with vascular cognitive impairment is enlarged prominent perivascular spaces. They've been marked with arrow. They also look like holes on axial T1 weighted MRI. So evidence is accumulating that these enlarged spaces may be another feature of small vessel dementia. These compartments surround perforating cerebral arteries and are involved in exchange of fluid and solutes. However, a recent review found no independent association of these enlarged spaces with prevalent or incident dementia, but more research is required into this field. So this initiative called STRIVE, Standard Reporting and Neuroimaging, was a structured process by an international working group to develop definitions and imaging standards for markers and consequences of small vessel dementia. So this is the table, the STRIVE table. So you can see from left to right, first one is subcortical infarct, seen on acute subcortical infarct, seen on diffusion weighting imaging. Then you have the lacunar infarct. Get it right. This is the lacunar infarct. These are the enlarged perivascular spaces, and these are the cortical microbleeds. This is again a classification of cerebrovascular pathology associated with vascular cognitive impairment, and this is from the group from Newcastle. And this Professor R.N. Kalaria from Newcastle, who is a cerebrovascular pathologist, is a renowned expert in this field and is part of many of the groups forming guidelines and classifications. And his classification, mainly based on pathology, classified into these 6 groups: large infarcts or critical infarcts, multiple small infarcts or lateral, strategic infarcts, which I'll talk about later, hypoperfusion lesions related to all in BP or including hippocampal sclerosis, which he feels is also caused by vascular problems and not just by Alzheimer's, cerebral hemorrhages, and vascular pathology along with Alzheimer's. So these are the parenchymal lesions of vascular etiology. I've already described most of them. I won't go over them again, except to reiterate that small vessel disease encompasses multiple lacunar infarcts, ischemic white matter disease, dilated spaces, and microinfarcts and microhemorrhages in the cortex and deep matter. Now, about the etiology, the common ones I've circled above are atherosclerotic embolism, arteriolosclerosis, lipohyalinosis, some a common cause of obliteration of deep perforating vessels, and amyloid angiopathy. The others are rare, but need to be looked for in appropriate cases. I won't go into them. Now, when we talk about vascular cognitive impairment, especially in the deep small vessel vascular dementia, memory is often not involved early or even for quite significant period of time. And this is what differentiated from Alzheimer's. So rather than memory being involved, first what's involved is executive functioning, manifesting as slower information processing, poor working memory, and reduced judgment, set shifting ability. And also, since these vascular lesions disrupt many thalamocortical, striatocortical, and prefrontal basal ganglia pathways, it may affect cortical and limbic brain structures and is often associated with disturbances in behavior and emotion. Now, for mild and major vascular cognitive impairment, apart from the major affecting day-to-day functioning, mild generally, statistically, on neuropsychology, deficits would fall between 1 and 2 standard deviations below the mean. While in dementia or major, it would fall 2 or more standard deviations below the mean in neuropsychology. As I said before, in DSM-5 and newer criteria, significant impairment in only one domain can be considered sufficient to diagnose vascular minor or major vascular cognitive disorder, and memory is not compulsory. Now, if you compare these three diagnostic criteria for major vascular cognitive disorder or vascular dementia, you can see the red circles. The first criteria is the red circles, which are the same in all three criteria, which say that onset of cognitive deficits follows one or more strokes. So that's common across all three. And the second, which is the green circles, show that if there's no stroke, then there should be a pattern of subcortical dementia with impaired executive functioning. And the last two criteria also show that neuroimaging should show vascular involvement. There's another group which has proposed their classification of major VCI subtypes. So first is post-stroke dementia. Patients with post-stroke dementia may have also had mild cognitive impairment before the stroke, but the dementia occurs within 6 months after stroke. Mixed dementias I've already spoken about. It may not be just Alzheimer's and vascular, but also Lewy bodies and vascular and so on, some of which can be diagnosed only at autopsy. Small vessel disease, I've been talking about it for some time, is the main vascular cause, and I'll have a couple of more slides about that. And multi-infarct dementia we've also talked about. Post-stroke dementia, in a systematic review of 22 cohort studies, 14% of patients hospitalized with stroke on history had a preceding history of dementia, and 12% of patients without pre-stroke dementia had dementia following a first stroke. But this is including all ages, and in the elderly, it will definitely be much more. Now, small vessel dementia, I've already said a lot about it, just few more points. It's more common with long-standing hypertension and diabetes, which cause lipohyalinosis and arteriolosclerosis of the deep penetrating arteries. It's a subcortical dementia. Progression may be smooth, unlike the stepladder progression of classical vascular dementia. Executive dysfunction, planning, abstract thinking, ability to take action goals is impaired. They may have a slower gait and lower half Parkinson's. Emotional lability, depressive symptoms, loss of interest, and urinary incontinence. So some of these features actually look like normal pressure hydrocephalus, especially the gait disturbance, the urinary incontinence, and the dementia. And generally, and there may be cortical atrophy as well, causing dilatation of the ventricles. So in general, when there's suspicion of normal pressure hydrocephalus, if there's extensive evidence of vascular disease, there's a reluctance to operate. Strategic infarct dementia can be due to a relatively small infarct in some parts of the brain, especially in this study, left frontotemporal lobe, left thalamus, and right parietal lobe. Another study, also the medial frontal lobes and language cortices. As far as neuropsychology is concerned, I won't go into details. MMSE is better for Alzheimer's. It's simple. It does not access executive function. So for suspected vascular dementia, you need a better tool such as Montreal Cognitive Assessment, which also assesses executive function and detects mild cognitive impairment, or a frontal assessment battery. These are just some simple tools. I think all of you are familiar with the Montreal Cognitive Assessment, which I've shown here. And the frontal assessment battery has 6 fields: similarity, lexical fluency, motor series, conflicting instructions, go, no-go, and prehension behavior. I won't go into the details. You can probably look it up online, but it's pretty useful. Maximum score of 18, and a score of 12 or less has sensitivity and 77% and sensitivity of 87%, differentiating between frontal type dementia and Alzheimer's type. Now, just by the way, I found this picture in a research paper, December 2017, where 2 patients who presented with MCI, mild cognitive impairment. The first one, patient A, they decided it's vascular because there is no evidence of cerebral amyloid deposition on imaging with floor beta Ben. While patient B below received a final diagnosis of mixed dementia because it was positive for floor beta Ben. This is all more in the research setting. This has not come out into our clinical practice yet. I just bring up, as my last 2-3 slides, I'd like to bring up this matter of brain reserve and cognitive reserve. So brain reserve means when there's tissue compromise, some brains have a greater capacity to rely on spared neurons and pathways to compensate, including activation of latent pathways and formation of new synapses. Hence, even with, say, a small stroke, cognition is not impaired. And cognitive reserve means that age and disease-related cognitive declines may be protected against by higher premorbid cognitive ability, higher premorbid functioning with more compensatory strategies, and also because they may have further to decline before being testing in the impaired range. So this is something we often see, that high functioning individuals just keep testing normal again and again on their neuropsychology. Now, this is a very interesting paper looking at 2 different studies, Nunn and Honolulu Asia aging studies, with about 330 and 700 in these 2 studies, one on the left and one on the right. And they looked at 5 different pathologies. Severity of Alzheimer's, 0 is absent, 0.4 is moderate, 1 is severe. Lewy bodies, microinfarcts, hippocampal sclerosis, and low brain weight. So if you look at this, you can see that 41% of patients with moderately severe moderately severe amyloid deposits in the brain had no cognitive impairment, zero cognitive impairment. Similarly, with Lewy bodies, moderate, even severe, 20% had no cognitive impairment. Similarly, with microinfarcts, hippocampal sclerosis, and low brain weight. Now, this is combining all those scores together up to a maximum of 4.4. You can see that when they went above let's say 2.8, 100% had dementia. But below that, though they had significant burden of some or all of these pathologies, a significant percentage did not have dementia. This is the same data in the form of odds ratios, showing that compared to index of 1, as the disease became pathological burden of all these 5 pathologies kept increasing, you can see the odds ratio increasing. But what is important is that even with significant amount of deficit, many patients remain cognitively normal. So my take-home message, VCI is the second most common type of dementia. Mixed dementia is common, especially in the elderly. Post-stroke dementia is seen in 12%. Small vessel involvement is common, resulting in SSVD. SSVD manifests with executive dysfunction, gait abnormalities, incontinence, and emotional lability. Radiology and pathological findings in VCI have been standardized, and aggressive control of vascular risk factors is important. Thank you.
Thank you very much, Professor Prasad, for elaborating very important clinical issue which we encounter in the older people of vascular cognitive impairment. I think we have some interventions also available to at least delay or prevent this particular type of pathology. In presidential oration, we will not be having any questions, so I'll pass on to the organizers. Thank you very
Dr.
much.
Prasad. That was an excellent lecture.
Thank you.
Sir, thank you, sir. It is very excellent oration, sir. We have learned so many things on it. So as a custom, as Mathur sir said, there is no question, sir. So we will move on to the next oration, sir. That is Venkoba Rao oration. So oration is delivered by Dr. Sureka Madam and chairperson, sir, Dr. YSN Raju, sir, and Dr. D. Nagender. He is the chairman-elect for API Telangana. Sir, over to you, sir, chairpersons, to invite our orator, Dr. Sureka, ma'am, and also tell me about Venkoba Rao oration.
Thank you very much, Dr. Chandrasekhar. Good morning, Dr. Nagender.
Sir, good morning, sir. Can you hear me?
Yes, sir.
Yes.
Yeah.
Now we have the prestigious Dr. Venkoba Rao oration. The topic is Lighted to Lighten Educational Incentives in Geriatrics by none other than the young and dynamic Dr. Sureka. I'll first read a small citation regarding Dr. Venkoba Rao. Many of the younger people would have just heard about him, but I had the good fortune of seeing sir at the Madras conference. After that, Dr. Nagender will introduce the speaker or orator, and then we'll hand over the stage to Dr. Sureka. Late Professor Antapur Venkoba Rao was actually born in Andhra Pradesh in a small village. When he was born on 28th August 1927 and reached his heavenly abode on 25th September 2005. His wife and children also are illustrious members of the medical profession. Some of the highlights of Sir, which is a big CV, I'll just give you a few points. He received the Doctor of Science in 1978 from the University of Madras. And Sir was the professor and head Institute of Psychiatry at Madurai Medical College from 1962 to 85. He was the officer in charge ICMR Center for Advanced Research in Health and Disease. He was a visiting scientist to the National Institute of Health, USA, a WHO consultant on psychiatric disorders. And notably, Sir was interested in effective psychiatry in old age, mainly concentrating on depression. He is also the recipient of the B.C. Roy Award in 1981. He has got almost 40 to 50 other awards. With this, I will hand over the mic to Dr. Nagendra to introduce the speaker.
Yeah, thank you very much, sir. Let me first thank the organizers for giving me opportunity to chair this prestigious oration. Let me introduce the speaker, Dr. Sureka. She is MD FRCP and currently Professor of Department of Geriatrics, CMC Vellore, a prestigious institute. She is also the editor of the Journal of Indian Academy of Geriatrics. And to her credit, she was instrumental in starting many courses at CMC Vellore. And she used to organize yearly CMEs and other programs for elderly in geriatrics. So she was the organizing chairman for year 2019 and currently she's organizing secretary for GERICON 2021. So over to Dr. Sureka to continue the oration.
Dr. Sureka, please.
Good morning. At the outset, I would like to thank the Indian Academy of Geriatrics and the organizing committee of GERICON 2021, especially Dr. Raju, for giving me this honor to deliver the prestigious Venkoba Rao oration this year. The topic I have selected, Lighted to Lighten, highlights my passion for geriatrics and medical education. So without much ado, I would like to showcase the educational initiatives in geriatrics thus far. In my talk today, I would be covering undergraduate and postgraduate training, distance education, training at various levels in geriatrics, and research. According to the WHO survey on geriatrics in the medical curriculum, which was brought out in 2002, they have said the basic principles of special care needs of older persons should not be of exclusive concern to specialists. We specialists live in our ivory cars and actually do not touch the common man at the periphery. So, and the next statement is even much more important. All students, medical, everybody must understand and must be able to practice the basic principles of assessment and management of older people. Regarding geriatrics in developing countries, there has been an exponential rise in the geriatric population all over the world. In the developing countries, access to medical care is difficult for this vulnerable age group. There's lack of infrastructure at the governmental and social level to look at the medical, social, and financial needs of this segment of population. In many of the medical schools, geriatrics does not exist as a separate specialty, and it is fragmented into specialist disease-focused care. According to a study which was done in the UAE on students 3 to 5 years, professional years, this was actually a questionnaire which students answered and covered the health of older adults and determinants in the development of attitudes towards them and their career preference. They have noticed significant improvement in medical student knowledge on physical health by the 5th year, but not on mental and social health. Changes in attitudes of students were influenced by parental attitude, childhood experience with older adults, and religious education. also were told in this particular study that geriatric health and aging topics were scattered in the curriculum. And believe it or not, neither the faculty nor the graduates perceived that geriatric medicine was actually included in the curriculum. 40% of the final years reported increase in knowledge was due to medical education. But of all of them, only 2% opted for a career among older adults. So they came to a conclusion that there is a need to enhance geriatric training and experience in undergraduate medical program. Geriatrics and medical education. As already alluded to, there is no specialized training in geriatrics in most medical schools in India. And of course, this is the lowest low-profile specialty that lacks visibility in academia and finds least favor among medical students. So their options to take geriatric medicine at a PG level is very, very low. Why was geriatric medicine not taught? This is from a study done in 2021. Geriatrics is not in the national curriculum according to this particular study. Older people are not a priority issue. Believe it or not, we are all growing old, remember? And there's lack of interest from the medical school itself. Now, when we want to introduce a curriculum with geriatric medicine, there are a lot of constraints that we face. First and foremost, lack of appropriate training sites, scarcity of qualified teachers with a passion to teach geriatrics, limited financial resources, lack of time in the already overcrowded curriculum, which has been revised recently, negative attitudes, not only of teachers, but of the students and of the public in general. They are old, forget about them. Poor recognition of the importance of such training. Now, we have to see that we have to influence the stakeholders who are responsible for making a change. Who are these wonderful stakeholders? It starts at the top, the Ministries of Health and Family Welfare and Justice and Empowerment at both center and state levels, the national and state medical councils, geriatric associations both at national and state level, non-governmental organizations, all the fraternity, medical, surgery, obstetrics, everything at all medical colleges, the students, medical, nursing, allied health, the communities, and the older persons. These are the major stakeholders. And what do we have to actually tell them? The pros of having a geriatrician on board. We can easily treat non-communicable diseases and assess the unmet physical, psychological, and social needs of older individuals, manage multi-morbidity, assess and reduce unnecessary, invasive, and often expensive investigations, and decrease the harmful effects of a high bill burden. We can do a good acute assessment and intervention for older people with frailty, dementia, delirium, and other mental health problems. We can help liaise with other services like orthogeriatrics, surgical specialties, oncology, and palliative care. And we can coordinate the care across all levels, primary, secondary, and tertiary. What more do they want? We can do all this for the older person and more. So we need a national curriculum. It is actually in the process of being developed for the postgraduate course according to the local requirements and healthcare systems. The competencies which are in the curriculum will strengthen the position of geriatric medicine in the context of multi-professional care of older people. And as assessment drives learning, which is the mantra of medical education, the format of assessment should change. But you look at the truth. Every specialty within medicine believes that its fundamental principles should be included in the core undergraduate curriculum and should be accompanied by a compulsory placement. Look at this fort. This fort is very close to Dr. Arvind Mathur. This is in Jodhpur. And basically what were forts built? They're built on a hillock. They are very strong. They keep people safe inside from intruders from outside. So is our curriculum. It is built on a hillock of tradition, which cannot be changed, and they do not allow any intruders in. So how do we access this fort? Look at the story. I'm sure you would have heard the story of the camel and the Arab. I'm not telling you to be as mean as the camel, but basically that's this camel who tells this Arab, can I put just my neck inside? It's too cold outside. The Arab says, you may put your neck inside. And the next thing we know, the camel is inside, and guess who's outside the tent? I'm not saying please do this and chuck out the rest of the specialities. No, look at the thing given by Medina Walpole et al. There are 10 steps. Actually, this person in the JAGS has said that all this is like a baseball game they have put it. So I put them down and I've highlighted the things which are important. Cooperate, that is the main thing, rather than compete with other specialities. Develop specific learning objectives and a curriculum map. Develop a working relationship with your medical school, your team, your curriculum committee, the medical fraternity at your school. They need to actually realize what work you're doing. So you must showcase your work. Mentor and encourage your medical students. They are your geriatricians of tomorrow. Look at the evaluation process, the effect of curricular initiatives, and look at what barriers are there to success. And incremental growth is okay. You can't make a sudden paradigm shift. A small growth in the right direction is worth the while. Believe it. So as we were trying to make inroads into this particular bastion of the traditional curriculum, I sent out a letter actually to the pre and para clinicians saying that we would like the students to get a flavor at genetics at the undergraduate level. And I actually made a list for the perusal, and I said we would be happy to input any of your departments at any point of time. And it would be appropriate if at the end of each system, each lecturer could highlight the aging changes in that system and how they influence the functioning of the older individual. So to build up what exactly are aging changes in the elderly and what we can do at final year level. So this is just a snapshot of exactly what I have done, how the vertical integration can be done between, and this IM and all is actually from the competency-based undergraduate curriculum from the Indian medical graduate, which is found on the net. There are 3 volumes of it. I've just taken one snapshot. There are about 36 topics which we can actually input it. The other important thing is not just teaching them knowledge, because our people have feelings too. So attitudes, ethics, and communication is a big thing in the MCI and now NMC. So we can actually input. There are many modules in the ATCOM that the medical student has to go through, and we can actually input into communication, the way we interact with relatives and team members, the way we care for the patient and carer, especially those who are undergoing terminal care, and we can showcase the working of a healthcare team. What better place they can learn this than looking at us, because we do this day in and day out. I'm going to speak about 3 other things that we can input into electives. This has become one thing in the competency-based education system that we are following from 2019. Electives for a month in geriatrics, they can perform geriatric assessments, which are so exciting. Dr. Prasad had alluded to some of them. Begin to institute a management plan for common geriatric issues. Understand the role of various members of the interdisciplinary care team, and understand the importance of various services that can be given, either non-governmental or otherwise. And appreciate the non-medical issues in caring for the older patients. Believe me, most of the patients have this as a major criteria, and develop greater comfort in discussing goals of care and advanced directives with patients. I had great problems actually doing this because nobody taught me that. How do you tell a patient that her relative is dead or dying? It was very difficult for me. In clerkship, we usually take bedside clinics, which is just a snapshot of that patient. But in clerkship, where the medical student is with us 24/7 through a month-long clerkship, we can learn to approach care across the continuum of inpatient and outpatient settings. So they actually travel with the patient from the outpatient, the admission, the discharge, and the follow-up in OPD. It is such a fulfilling thing for the medical student, apart from all those that I have alluded to in the electives. And of course, internship is the culmination of all this, and internships have been long valued for providing students with opportunities for practical experience, career preparation, and personal growth. There are many teaching and learning methods, and it's online and offline, and COVID-19 has taught us so many things that we can innovate. So for teaching students, we have lectures, videos, question answer sessions, very interesting ones on, euthanasia, or things like that, panel discussions, seminars, and role plays. You make it interesting. That will strike that spark in your student, believe me. Simulations, case vignettes, quizzes. I remember organizing a quiz for the medical students, and it was such a hit. And the feedback was, I never knew geriatrics had so much to give to the patient. So strike that spark in your student. It is worth it. We should have appropriate handbooks with algorithms, checklists, and assignments, which we have to work on specifically, which makes it culturally relevant to the person. Hands-on, showing them exactly what to do. Shadowing is very important, and community visits, especially to old people care home or to their own homes, the old people's home, to see how exactly they live. And then there is continuing medical education. This has to be followed up. It's not just a one-time exposure. You have to continuously keep reiterating and networking. I think the youth wing of the IAD is actually trying out this networking and successfully managing it. According to the General Medical Council UK's policy document for tomorrow's doctors, they have said there are special problems definitely associated with older people's health. We do agree. Young doctors must learn to respect age and the vulnerability of older people. Graduates must understand human development. Of course, we have a lovely progress growth chart for children, milestones crossed, but this should include growing old. And students must have unique learning experiences. I mean, I had gone to a old people's home, and that experience really changed me. Opportunities to visit older persons, to hear their stories. It's a beautiful experience of growing with them. But there's an unanswered question that is there, that's actually not even asked. Should there be compulsory attachment to a geriatric medicine unit? The pin drops here. In the US, geriatric medicine training placements are optional. And the CDC agrees that geriatric medical education is the largest education gap in any field in terms of numbers of educators available. And the American Geriatric Society has suggested core competencies that should be included in the training at undergraduate level. This is the position paper of the Indian Academy of Geriatrics, which came out in GIAG in 2020. It was written by Dr. A.R. Rao and Dr. Arvind Mathur and Dr. A.B. Day. Just a small snapshot of it. There's a need to increase geriatric content of undergraduate and postgraduate medical programs, improve attitudes towards geriatrics by medical students, staff, and academic administrative leaders, offer more excellent opportunities in clinical research training, and develop public policy initiatives which will increase geriatric training. They've also suggested to give monetary incentives, but I think incentives should come from within. Motivation should come from within. That spark should be ignited. And they also suggested that certification of geriatricians could be intended to provide a means by which family physicians and internists can obtain recognition of their expertise in geriatric medicine. Going on to postgraduate, we all assume, or we want our postgraduates to have the ability to establish a diagnostic formulation for older patients with appropriate use of history, clinical examination, and investigation. The knowledge, skills, and experience to develop management plans for each patient, individualized, no one code fits all. It is different for each patient, different in each setting. the appropriate attitudes and communication skills to effectively manage patients and to work effectively within a multidisciplinary team to promote optimal recovery of patients. So assessments here in geriatric medicine are formative and summative. And we at CMC have appraisals for our postgraduates once in 3 months. It's a 360-degree assessment where we actually assess comments on the seminars presented, journal club presentations, the procedures done, and soft skills. Their presentation on rounds is also looked at, and this last are the requirement by the university that progress on the e-journal or the publication, poster and platform presentations, and an update on their thesis. This appraisal is given in writing and sent to the vice principal postgraduate education in every 3 months for every postgraduate. This is just a snapshot of what we sent to the vice principal. There's also a logbook, and we look at the logbook every time. It would be nice if we could have mini clinical examinations, just 20-minute snapshot of either an examination, a communication skill, or history taking. The other one is a direct observation of procedural skills that should be done to see how well they are performing. This is from the RCP, Royal College of Physicians, and geriatrics. And I think all of us should go through this for with our students so that actually the student grows to love geriatrics and the patient grows to love it. So in summative assessments, there's a thesis everybody has to submit. Then there are theory papers in all universities which cover a gamut of geriatrics. In our university, that is the Tamil Nadu University, there's an OSCE, one long case, short cases, ward rounds which are management based, and finally a viva voce. But please remember, you have to climb the ladder of formative assessment and then you reach your summative assessment. It is difficult at that point of time to say you are not worthy to actually get an MD geriatrics degree. You should have actually done a lot of formative assessment and corrected what is wrong before you send them to their final summative assessment. Because in the end, that MD degree, they're going to treat you and me. So we have to be very, very careful. Regarding distance education, this has become very the norm now because of COVID. This is not only for doctors, it's also for nurses and allied health people. And we should also think of community level workers. And the languages for them, even like regional language, and also the language of medicine that you speak to them is very different. So there have been a lot of inroads by the NPHCE, National Program of Healthcare of the Elderly, the National Health System Resource Center, the National Institute of Social NIST, and the WHO. I think it will be better if all these people get together and do it, present a united front and teach them, because I think that would be better teaching piecemeal what they want. In the DNP, we have to push boundary. The DNP medicine has the goal of we should be able to provide preventive, promotive, curative, meditative. So we can use the same platform and geriatric medicine DNP. I think this is in the pipeline somewhere, but because there are limited MD fields, this should be explored at the earliest. Remember, for all this, train the trainer. That is very important. Doctors in other specialties should realize what is the flavor of geriatrics, what can we do for their patients as a matter of inputs from geriatrics. How can we help them? How can we help quality of life in their patients? They should understand that. How will they understand it? Only when they see the difference in their patients. So you should make a difference in patients' lives for the others to actually understand. For doctors at the periphery, we have to teach them from theory onwards to practice. For an application should be based relevant to their context. Allied health workers and nurses should be able to multitask, should be able to do a lot more than actually they were taught in med school. Community workers should be able to recognize red flags, should be able to do use the basic principles of geriatrics to look after the elderly in their communities. And the most important is student sensitization. I just put up this because most of the time, geriatrics is realized as a stopgap between the grave and the particular specialty. No, it should not be thought like that. Geriatrics is something that we actually input a lot before they reach the grave and improve not only the patient's condition, but also the relative's frame of mind. That's what we aim to do. Teaching and learning methods, we have to talk. Not only talk, we have to walk the talk, we have to teach, we have to show other specialties what great things geriatrics can do. We don't need to say state-of-the-art things, just something which makes a small difference in people's lives. Like even doing a PR to get rid of chronic constipation goes a big, long way, believe me. You go out and teach, don't teach from a tertiary care center. Go out, teach them. There's so many people willing to learn. There's web-based learning, continuing medical education. It has to be done because it's not a one-stop shop. Short-term certification courses will help. I've already alluded to handbooks which are application-based, and students. You know, the world is theirs, and there's so many things that you can do for students. And at the community level, arrange melas, upgrade workers, empower that community. Then you will notice the change. Research has always taken a back burner because we're looking at acute care all the time. But research should go side by side. I'm not a research person, but I guess there are some who are very research minded. So there's so many things you can do research on. Etiopathological mechanisms of aging, socioeconomic support mechanisms for aging, mechanisms to promote healthy and active aging process, and models of geriatric healthcare delivery acceptable, that is most important, and based on our cultural practices and traditions, and they should be scientific and models for medical care in different settings and study of age-related disorders. Many more, I'm sure the research people will bring out a huge list, but these are some of the things that we can focus our research on. I can tell you the ones who lit the spark of geriatrics in my life were not teachers. They were my parents who actually took us to the older people's homes. Till today, I remember getting postcards from my aunts and my grandpa every week to tell me about their life. And I used to send postcards to them to tell them about my life in medical college. So parents have a major role to play towards fostering respect for older adults. The government has a different focus, raising the capacity of health professionals and geriatric care, developing socioeconomic support mechanisms for older people in the community. So signing off, we have to sensitize the stakeholders. The list I've already produced. Faculty development is very important because they need to know. Learn to teach at all levels. Pediatrics, somebody at the community, to a person to look after his foot at the grassroots level. Follow-up is important because people don't remember. I myself forget. So what about blaming others? Begin in your own home and illuminate your corner, illuminate your road, illuminate your community, illuminate everyone who comes in contact with you. It is worth the while. I'm just signing off with a blessing. Please remember, there's God to help you out in this, and you have a mission. You have been enlightened. Enlighten your world. God bless you all. Thank you.
Thank you very much, Dr. Surekha. That was an excellent lecture. And as tradition, we don't have any questions. So thank you very much again.
Sir, in the chat box, there is a one compliment for the Surekha madam from the Meenakshi Sarada. It's a wonderful oration, Dr. Surekha madam. Congratulations. Yeah.
Yeah. Thank you, Dr. Surekha.
Thank you.
Thank you,
Surekha, I would
Dr.
like to
Surekha,
thank you. Surekha, I'd like to thank you for your excellent talk, your vision for the future roadmap. You have drawn a roadmap to the future geriatric care and also the geriatric teaching. Thank you so much.
Thank you. God bless you all.
Yeah.
Okay.
Thank you, Dr. Sureka.
Thank you.
Can you hear me?
Yes, sir, I
Yes,
can.
yes, you're audible.
Thank you.
Okay. Yeah. Because present day, the declining relationship in the family relations, I think your topic has got a real relevance from the professional point of view. All the young medical graduates, as you have already mentioned, the geriatric has got a big role in current NMC curriculum, and students will be benefited from that one. Thank you very much.
Will go. Thank you, sir.
Okay,
Over to
Nagendra sir.
organizer.
Thank you.
Yeah.
We will quickly, already delayed by half an hour. We will quickly move on to next part, that is inaugural session.
Very careful.
So I'll invite all the dignitaries first to join us, sir, and then followed by a little prayer and then welcome address by YSN Raju sir, and our order follows. So first I invite our chief guest, sir. He is Dr. B. Karnakar Reddy, sir. He is the Vice Chancellor for Kaloji Narayan Rao University of Health Sciences of Telangana State, situated at Warangal. Sir, Karnakar Reddy, sir. Are you in, sir?
Yeah.
Sir, please unmute
Are you able to hear me?
Yes, sir. We are able to hear you, sir.
Yeah. So good morning.
And, good morning, sir. Good morning, sir. Sir, then I'll invite the patrons for this Indian Academy of Geriatrics, Dr. V.S. Natarajan, sir. Sir, are you in, sir?
Yes.
Thank you, sir. Thank you, sir. And I invite Dr. A.B. Day, sir. Sir, A.B. Day, sir. I think he has joined, but I don't know.
No, sir is there.
Namaste, sir. Namaste, sir. So next I call upon Dr. I.S. Gambhir, sir. Gambhir, sir?
Yeah,
Are you in,
there.
please?
Namaste, sir.
Namaste, sir. And then I invite Dr. Arvind Mathur, sir, editor for Journal of IAG. And then I invite the present President IAG, Dr. Prasad Matthews, sir. Sir, are you in, sir? Prasad Matthews, sir.
Yes, he's here. I'm here, sir.
Yeah, thank you, sir. And then President-elect Dr. Ashish Goyal, sir.
Yeah, good morning.
Ashish
I'm
Goyal.
here.
Yes, sir. Yes, sir. And then Scientific Committee Chairman, Dr. Shanti, ma'am.
Yeah, good morning. Good morning. I'm here.
Good morning, ma'am.
And Secretary for IAG, Dr. Rajendran Magesh. Magesh, sir.
Namaste. Thank you.
Then Organizing Secretary, Dr. YSN Raju.
Chairman, organizing chairman.
So, Organizing Chairman, YSN Raju. Sorry. Raju, sir.
Yes, sir.
So,
Yes,
myself, Organizing Secretary. Thank you for joining the virtually conducting GERICON 2021 with the help of IAG and this Kakatiya Medical College, Department of Medicine, Kakatiya Medical College, Warangal. So I invite you all for this program, and then the lightning lamp session virtually it will come, and followed by a prayer song from a medical student from Kakatiya Medical College. Tejasvi, are you there?
Yes, sir. I'm here.
After lightning lamp, please give a prayer song of sir. Start the lightning lamp.
ఇంకో పెద్ద సార్ వస్తాడు కదా సార్ వస్తాడు కదా సార్ వచ్చినాక ఇద్దరం మాట్లాడతాం నీళ్ళు రావటం లేదా నువ్వు ఒక చెంచా గ్లాస్ నుంచి చెంచా తెచ్చుకో
Thank you, technical team. Now, prayer song by Tejasvi, student from Kakatiya Medical College, Warangal. Tejasvi?
Yes, sir.
Please go ahead with the Saraswati song prayer.
Sri Sharada
ఒకసారి కామెంట్స్ లో ఎవరు ఉన్నారు వీళ్ళు?
Surasevita Swameva Mama Sharanam Sri Sharada Sri Shrungagirivasini Vani Pranavaroopini Sri Sharada Surasevita Tvameva Mama Sharanam
ఈ స్టెప్ క్లాస్ సోషల్ ఆఫీస్
Sri
కాంబినేషన్
Sharada Samagana Vilolini Nigamagama Viharini Samagana Vilolini Nigamagama Viharini Prema Swarupini Vidyadayini Komalangi Vara Veena Pani Ragamohini Rasa Vinodini Hamsavahini Jnanadayini Vangmaya Rupini Bharati Chandovasini Saraswati Sri Sharada Surasevita Tvameva Mama Sharanam Sri Sharada
Thank you, Tejasvi. Now we want to welcome address by organizing chairman Dr. YSN Raju. Sir Raju sir.
Namaste everybody. I would like to welcome firstly the chief guest, the Vice Chancellor, Dr. B. Karnakar Reddy of KNR University. And next, I would like to welcome all the joins of GDATX in India, starting with Dr. V.S. Natarajan sir, Dr. A.B. Day sir, Dr. Gambhir, Dr. Arvind Mathur. And I would like to also invite the President of IAG, Dr. Prasad Matthews, President-elect Dr. Ashish Goyal, and one special mention, Dr. Vengama Madam, who is the SWIMS Director. Actually, she's so interested in geriatrics, she made her daughter do geriatrics, and she recently passed her Amrita. I would like to even thank Dr. Shanti Madam, Dr. Magesh sir, and other dignitaries of the dais. I welcome all the faculty members, chairpersons, delegates, and the most important, the students. The 18th annual conference of IAG actually was supposed to be held last year, but because of the COVID situation, we postponed it to 2021. And this has been a total virtual conference. This has materialized and seen the light of day thanks to some of the people, especially the encouragement from all my seniors and doyens who said that we should do it.
There is no one will come.
It started with a scientific committee with Dr. Shanti, Dr. Tangam, Dr. Usha, Dr. Deepa, who actually made us gain confidence by any conference is the scientific program that's most important. And thanks to these people. Then I should thank the organizing committee at the local level, especially special mention for Dr. Chandrasekhar and Dr. Krishna Prabhakar. And last but not least, Dr. Magesh, who is a thorough gentleman and efficiency personified. This conference, there were 400 delegates registered, out of which 150 were students. and we had 30 presentations. Because of the paucity of time, this, I think, is a good number. And what is interesting about this conference is we have a very new set of speakers, topics, chairpersons, and this is going to be an academic feast. And we did not compromise on anything or cut corners. Therefore, we have the thesis awards and presentations, best paper awards in poster and platform. And with this, we are making it as good as a physical conference. I know there are a lot of glitches whenever computers and internets are involved, so kindly forgive us for that. And please sit back and enjoy this academic feast in the comforts of your home. So welcome you all. Namaste.
That's very good summarization, sir. Now moving on to Sir Dr. Rajendran Mangesh, sir. He will give his secretary's report of IAG. Sir, Dr. Mangesh, sir.
Sir, you have to unmute yourself. Unmute.
Sir, unmute yourself, sir.
Thank you. Warm greetings to all seniors in this room. I welcome the Chief Guest, Dr. Karunakar Reddy. My greetings to patron Dr. V.S. Natarajan, sir. All senior patrons, Dr. Day, Dr. Arvind Mathur, Dr. Gambi, who are here today with us. And I would like to greet fellow members in my executive committee and thank Dr. Raju and Dr. Chandrasekhar for organizing this excellent virtual conference. I'll go on to read the secretary report. The Indian Academy of Geriatrics was founded at Chennai in 2003. Goals of the organization are to spread knowledge of pediatrics among medical, nursing, and allied medical professionals across our country. We now have a total of more than 1,100 members. The main annual activity since 2003 has been our annual conference, GERICON. Today, we are proud to have the 18th edition hosted from Warangal virtually. One of the other main branches activities of our organization has been the journal. This is now indexed and the ISI in the International Scientific Indexing, and the journal was granted an impact factor of 1.45. This year, our ICV, which is Index Copernicus value, has improved to 85.11. The journal has been publishing high-quality research work. This has been possible due to the eminent members of our editorial board and reviewers. The journal's impact factor has shown significant improvement. This year, we had ICOP WHO training program for comprehensive care of older people. Our academy has led the trainers program, which was for Southeast Asian region, with geriatricians from across 6 countries. Similarly, our research wing has conducted workshops and training modules on research methodology. State and local city chapters have been active, conduct regular academic meetings, CME programs aim to educate the family physicians. Today, I would like to thank all the speakers who have given their valuable time to deliver an excellent academic session. On behalf of the IAG, I would like to thank Division of Geriatrics, Department of Medicine, KMC, MGM Hospital, Warangal, Dr. Chandrasekhar and his team for taking this task of organizing an excellent academic feast despite the challenges of short notice and the pandemic. Thank you.
Thank you, sir, for that. And now next I invite Dr. Shanti Madam to report of scientific committee. Report from the scientific committee. Shanti Madam.
Yeah, good morning. Respected Chief Guest, Vice Chancellor of KNR University of Health Sciences, Warangal, the Registrar of KNR University, Dr. Praveen, the Dean, Kakatiya Medical College, Warangal, Dr. Mohandas, the Organizing Chairman of GERICON 2021, Dr. Y.S.N. Raju, the Organizing Secretary and Joint Secretaries, Dr. Chandrasekhar, Dr. Krishna Prabhakar, the President of IAG, Dr. Prasad Matthews, the Secretary, Dr. Magesh, Dr. Tangam, and our patrons of IAG, Dr. V.S. Natarajan, who is with us now in this conference, and also our founder members, Dr. Arvind Mathur, Dr. Gambir, Dr. Professor A.B. Day, and all the senior members of IAG, the executive committee members, and all the faculty and delegates who have joined in this e-conference, and specifically the postgraduates from various institutions, and whoever is participating in this e-conference. And dear friends, a warm welcome to all of you. It's my pleasure to be with you all in this scientific conference organized at Warangal on behalf of IAG. And this scientific program is framed in such a way to address the important clinical aspects of geriatric care and the ways to be managed by the efficiently by the geriatricians, physicians, and other practicing doctors. So this is in fact a good mix-up of the topics of well-known geriatric syndromes up to the latest advancement in the medical fields. And the speakers also include various international speakers who are indebted to their specialty of geriatrics, and also from speakers from all over India. We felt that newer advances in the field of medicine and which are applicable to the geriatrics, of like the apomorphine therapy for Parkinson's disease, the role of proton therapy in oncogeriatrics, application of technology in geriatric healthcare will throw light on these areas. And not only that, any practicing physician will face day-to-day problems in the managing the elderly, and the practical day-to-day issues of managing the behavioral problems, psychological problems in demented elderly, managing a chronic and critically ill patients. And this will help us to improve evidence-based knowledge and practice of geriatric care. And also to provide a good scientific buffet to the topics for the 2 days will fulfill the knowledge hunger of the various participants and the postgraduates. And I hope all the delegates will be benefited by these informative lectures and orations. Already we have seen few orations and topics which are delivered in a very nice manner, updated versions, and definitely this is going to improve our knowledge. And this is all because of the efficient and knowledgeable speakers who have been who are with us. And I request you all to extend your support and participation and make this conference a big success. And definitely, I thank the organizing secretary, Dr. Chandrasekhar, for taking this initiative in a short notice. And I hope this should be a big success by all your support. Thank you, one and all.
Madam, I invite Dr. Ram Kumar Reddy, Vice Dean, Kakatiya Medical College, Warangal, because the Dean is in some urgent work, is unable to join the inauguration party. I welcome Dr. Ram Kumar Reddy. And moving on to address by our patrons of Indian Academy of Geriatrics. First, none other than Dr. V.S. Natarajan, sir. Sir Natarajan, sir, please, we want to hear from you, your blessings and all for this conference. Natarajan, sir.
Morning, sir.
Natarajan, sir. Unmute yourself. Sir.
Hello.
Sir. Yes, sir. We could able to hear, sir.
Okay. So, I am Dr. V.S. Natarajan. You know about me, and I'm very happy to join in this GERICON. And now we are in a very critical period, particularly in the COVID situation. After all the group of people, elderly people are the main target of this period. Now the corona still continues, not yet gone completely. And still they are threatening about the third wave and Omicron. And what I can say in this 1 year corona period, many elderly people still they have not taken the vaccine. Probably they have taken first dose, but they have not taken the second dose. But I request all the delegates of the conference to convince your group of elderly people and organize meetings, seminars, and request them to have the injection and let them have a healthy aging. Thank you very much for giving this opportunity. Wish you all the best for the success of the conference. Thank you very much.
Thank you, sir. We'll definitely take your message to all the groups, sir, to take the completion of their vaccination. So moving on to, I invite Dr. A.B. Day, sir, to give his address. A.B. Day, sir. Sir, I think sir is joined.
Namaskar and good morning. Respected Vice Chancellor, sir, and my Guru, Dr. Natarajan, and my colleagues and friends on and off the dais. It's kind of a very unusual situation of doing an inauguration on virtual mode, but this is also an experience that one has to have in a 100-year-old, once in a century pandemic. So these are the new experiences of life. I'm extremely pleased to see that despite all these logistics problem, the team has been able to put in place a conference with a huge number of participation, and it's really a very positive development in the field of geriatric medicine in India. The previous 2 years have been very difficult, but our backroom team in the form of the president IAG and secretary IAG and all their support staff, as well as editor JIAG, have been able to maintain the flow of events and activities in the society, in the academy, so that we are, though the pandemic has put our spirits down, but the activities have been on. I congratulate the team for this very successful conference on a distant mode. It's a new experience, and the two orations I have already heard, and I felt very good that things are moving in the right direction. And thank you for inviting me, and all my good wishes to the conference. Thank you.
Thank you very much.
Thank you, sir. Now I invite Dr. Gambhir, sir, for your message for this conference, sir, and your blessings also. Dr. I.S. Gambhir, sir. Sir?
Yeah. Am I audible?
Yeah, sir.
Yes.
Audible, sir.
Thank you. I feel greetings. I bring greetings from the abode of Lord Shiva, Kashi, to all of the participants and the organizers. My greetings to respected Vice Chancellor, sir, and organizing chairman, Dr. Raju, Dr. Chandrasekhar, and G. Shanti, scientific committee chairman. I think in this difficult time, this is one of the best things to happen to IAG, because there has been a long hiatus, and last year also we insisted on a virtual conference which could not materialize, but I congratulate. Very grand success. Thank you very much.
Thank you, sir. Thank you very much.
Thank you. Thank you, sir. Now I invite Dr. Arvind Mathur, sir, editor of Journal of IAG. Sir, a few words from you, sir.
Thank you very much. Our guest of honor, Dr. Reddy, the Honorable Vice Chancellor, Professor V.S. Natarajan, sir, Professor Day, Professor Gambhir, Dr. Raju, Dr. Prasad Matthews, Dr. Magesh, Dr. Shanti, and all our colleagues. It's our privilege to have this conference due to relentless effort of Dr. Raju and Dr. Chandrasekhar and their team, which has made this GERICON happen. And this is a very important event in the Indian Academy of Geriatrics, for which we always look for this annual event. And the interest which the GERICON 2021 has generated amongst our members and others also, I'll say that our students, our practicing doctors, they have all been looking for this particular event. So I wish all the best for the conference, and I thank them and congratulate them also for organizing such important event. I assure everyone that the journal will always be supporting the activities. So I'll request all the speakers, if they could submit their review articles for publication, that will be a welcome thing for us. I wish all the best for the conference. Thank you. Thank you very much.
Thank you very much, sir.
Thank you, sir. So now I call upon a few words from President-elect for IAG, Dr. Ashish Goyal, sir. Sir, Ashish Goyal, sir.
A very good morning and my greetings and gratitude to the Vice Chancellor for his august presence, and all my seniors for having entrusted me with the responsibility to take up the mantle in the future. It's a delight to participate in the IAG conference once again, although on a virtual mode. But the patience and the effort that has gone in to build this program together and put this event together is extremely visible and most welcome. Thank you, congratulations, and wish you all the best.
Thank you, sir, for your message. And now call upon President IAG, Dr. Prasad Matthews, for his address.
Respected Chief Guest, Vice Chancellor Dr. Karnakar Reddy, Deputy Dean KMC Dr. Ramkumar Reddy, Organizing Chairman and Secretary Dr. YSN Raju and Dr. Chandrasekhar, esteemed ex-presidents of IAG, President-elect Dr. Ashish Goel, Dr. Magesh, other office holders and EC members and delegates. I'm delighted to speak on the occasion of the 18th annual conference of the IAG. I would like to thank the organizing chairperson and the secretary and the scientific committee, Dr. Shanti and Dr. Isha, putting together a vibrant program at short notice. I'd like to thank Dr. Magesh for all the hard work that he's put in. I'd also like to thank the editorial team, Dr. Mathur for decades, and Dr. Sureka and team, and Dr. Gopinath for all the work they've been putting into upgrading the journal. With the steadily increasing proportion of elderly in the country, the discipline of geriatrics is becoming more and more important. I'm happy to report that at present there are 8 academic geriatric programs in the country, and I hope that many more may start soon. The IAG has been in the forefront of development of geriatrics in the country, organizing workshops and training programs for healthcare workers and doctors, organizing an annual conference. Our senior members and past presidents have been busy with advocacy with the government to start healthcare programs for the elderly in the country, and also increase the number of training programs in the country. At this moment, I wish Dr. Ashish Goel, President-elect, and the other officers bearers well as they take the IAG and the discipline of geriatrics forward in the country. Thank you again to the organizers for organizing this program.
Thank you, sir.
Thank you, sir. Now I welcome, I invite Dr. Ramkumar Reddy, Vice Dean. Please put a few words. Actually, we want to make this conference as hybrid mode, but because of this Omicron news and all, we couldn't able to. So, but the support from the college principal is enormous. So I invite Dr. Ramkumar Reddy to say a few words about this conference. So unmute yourself, Ramkumar.
Good morning, sir. Thank you, sir. And I'm very much delighted to see this program, sir. And we have started geriatric department here with the help of Dr. Chandrasekhar. And geriatrics is the one subject we very much needed for us. And we, the orthopedic surgeons, always strive for the geriatric problems to look after. And nowadays, the geriatrics nowadays is a upgoing subject where you physicians, orthopedicians, and psychologists, social activists, they all should come together and plan the geriatric healthcare in the India in the future. So this is a very good initiative. I very much thankful to Dr. Chandrasekhar and other delegates who participated in this. I wish very much success in this. Thank you very much, sir.
Thank you, sir.
Thank you, Ramkumar Reddy. Now I invite our chief guest of the day, respected Vice Chancellor Dr. B. Karnakar Reddy, sir. He is my teacher at my undergraduate days, and he is heading first Vice Chancellor for the youngest health university in our country. And happy thing is that that university is located not in the capital of Telangana, but in the Warangal. It is considered the second capital. So in our own campus, Kakatiya Medical College campus. And sir is a very renowned academician. And with his help, we have started so many new departments, emergency medicine, transfusion medicine. The moment we say, he say yes, and affiliation he will give, and he'll strongly fight with the government and NMC. So getting the permitted. This year, we have started geriatric OP at Kakatiya Medical College. But upon the MCA inspection, we have applied for geriatric department. So in this regard, Dr. Karnaka Reddy sir help is immense. So he's a very good visionary. So sir, Karnaka Reddy sir, please give your message for this conference, sir. Thank you, sir. Karnaka Reddy sir.
Am I audible, Dr. Chandrasekhar?
Yes, sir. Yes, audible, sir.
So, right. So, good afternoon, everybody.
Sir, resound is coming, sir. Sir, Karnaka Reddy, sir.
How is it, Chandrasekhar, now?
Now it is better, good, sir.
Better,
okay. So, I'm really happy to be part of today's inaugural function because this is one subject.
Sir, sorry for interruption, sir. There is resounding is coming. Sir, I think you have.
All other participants should unmute it. All other participants to mute it. So only sir will speak.
Yeah.
So now is it
why it is coming like that?
Hello.
So rendu device login ayunnaru sir meeru oka device off cheste it will be
device
very
off
clear.
Phone gaani laptop gaani.
So it is showing two devices.
How is the sound now?
Now it is good, sir.
Right, fine. So happy to be participating in today's function because this is one subject which has been very close to my heart. And I congratulate the organizing team, Dr. Chandrasekhar and others for organizing this. These are our difficult times due to COVID, and slowly conferences have been, started getting organized in hybrid mode. We had recently few conferences in totally physical mode also. But once again, there's a little bit of, fear of COVID due to Omicron. And see, virtual mode is as good as physical mode, and the participation seems to be more. So impact of so much of COVID, particularly in the medical field, we had lots of challenges. And as geriatric specialists, you must have had the maximum, complications, problems, because COVID has affected the elderly in a very, bad way, and maximum complications because of the high risk and all. And a few, things that have come out of COVID are healthcare infrastructure improvement from government side, and extensive use of IT. Now, because of that only now we are having this in virtual mode, and the entire medical in the country, even entire education in the country was on online mode for more than a year or so. And now telemedicine has become quite popular. So it had its advantages and some of the improvements. It has led to improvements in the medical field. Now the importance of geriatrics is going to be on the rise because we are a very large population, and because of the increased longevity, we are going to be, subsequent to China and Japan, we might become the largest, geriatric population country. And unfortunately, it is the most neglected population in the country. It really saddens one because our society was previously with joint families and all, where the elderly people used to get the maximum respect, maximum focus in the families. Now with this globalization and then urbanization, nuclear families and all, they have become the most neglected sect. And unfortunately, if you observe, even in educated families, middle-class families, what we find is the symptoms of geriatric people are neglected. They think that somebody is complaining of constipation or some other problem, this is because of old age. Somebody complains of weakness, somebody complains of breathlessness. It is because of weakness, it is because of old age. And that will lead to a lot of delay in the diagnosis of malignancies, cardiac problems and all. So I personally feel that, geriatrics should be treated on par with pediatrics. And when I was an actively practicing surgeon, now probably for the past 5-6 years, I'm not able to practice. Every day there used to be a class for the patient's attendants. Any elderly patient used to come, because for me, mostly the patients used to become their neglected state, diabetic foot and all those things are neglected conditions. I used to ask the entire family to come and 15 minutes class for them, why they have neglected. And I used to quote them. We had a movie, Tata Manvadu. If Telugu speaking people will know, where the grandson will tell his father that, oh, you are doing this to your father, so I have to do the same thing to you. So those are some of the things. That was the culture. From that we have somehow degenerated, and I feel your organization should again take a lead in getting back the importance of geriatric population. And it's a special status because as a surgeon also I have seen lot of difference in anatomy, lot of difference in the physiology, lot of difference in the wound healing and surgery. The tissues are so friable, in particularly in geriatric age group. If the amount of force we use, the same amount of force which you use in a normal adult, if you use straight away, you'll enter into the peritoneal cavity when you make an incision. So there is a difference, and there is a need for somebody. The previous speaker was rightly talking about the importance of geriatrics to be taught to undergraduates. And slowly the NMC has recognized the importance. Geriatrics has been included as a subject, specialty subject in post-graduation also. So I hope more and more people will take up that. Apart from that, there is a lot of need for teaching the geriatric subject in all elite healthcare subjects also, like nursing, physiotherapy, and other paramedical workers, so that it evolves as a specialty totally like Western countries. Still, we are in our country, still geriatrics is not identified, not percolated to the society level that geriatrics is a specialty and people have to go to a geriatric person, the doctor, to take treatment. And our government also is taking a lot of care with the introduction of some of the schemes like old age pension, and with 104 services providing drugs to non-communicable diseases. Definitely the nutritional status has improved, because rural areas, elderly people were neglected. There were lots of nutritional deficiencies, and now government is providing 2,000 rupees per month. It has made a significant difference in their improvement, and the medicines are supplied for hypertension, diabetes and all. So definitely it has led to some improvement in geriatric health. At the same time, now we are planning for about 4 or 5 super specialty hospitals in the Hyderabad, and every hospital is having a geriatric unit included in that, because I am part of the committee. So we have seen to it that a geriatric unit also is included in that. So what I feel is, from the geriatric society or geriatric association and geriatric physicians, there's a need to educate the population, educate the society about the importance of nutrition, to prevent all the deficiency disorders like iron deficiency, vitamin nutrition deficiencies, which might lead to all other problems like cardiac problems, neurological problems, musculoskeletal problems. The importance of some moderate exercise, regular control of diabetes, hypertension and all. And from government side, definitely there should be, say, the Telangana state government is planning to have health profile created for all the state population. That will definitely help in a long way, because once health profile is there, we'll know how we are aging. See, if your health profile, we start from childhood, we know what are the problems we are going to face and what are the difficulties. Plus, there should be regular health checkups and health camps for diagnosis of, diabetes, hypertension, malignancies, and neurological conditions, ophthalmic, ear conditions, which are all the problems of geriatric age group. Apart from that, society mindset also has to change. So from the most neglected population of elderly, they should be once again brought into the regular fold, regular family setup, and they should get their nutritional, emotional, and other supports, so that a healthy elderly population, healthy grandparents will definitely lead to a healthy family, and they will, bring up the ethics and morals of the younger generation also. So this is where I feel that geriatric physicians have a very important role, not only in treating the geriatric conditions, in diagnosing the geriatric conditions, but educating the population, educating the family members, and educating the general population. Probably you should have some, we have to take the help of social media in having lots of lectures and all in a simple language, which are useful to everyone. How we can prevent problems, how we can, age in a healthy manner and minimize the problems and all. So this is one aspect where I want all of you to, focus, because not only doing some research into geriatric conditions, diagnosing, treating, but prevention is most important, and changing the mindset of the society, changing the mindset of the governments in providing proper geriatric healthcare is very, very important. And, I'm really thankful to the organizers for giving me this opportunity to share my thoughts, because geriatric medical care was something which is always in the back of my mind. And I thank Dr. Chandrasekhar and organizers for giving me this opportunity to be with you today. Thank you.
Thank you very much, sir. It is a wonderful message. Definitely, we will be thinking, adopting your thoughts, and we will take this geriatric forward into the society also, sir, not only for the classrooms and colleges, into the society also, sir. Thank you very much. And this is the end of our program. I'll say the vote of thanks. I thank Dr. Karunakar Reddy, sir, our chief guest, Vice Chancellor, KNR University of Health Sciences at Warangal, sparing his valuable time. Particularly, sir is very busy with his government activities and his Senate meetings and all, but he has spared a valuable time with us and shared his thoughts. Thank you very much, Karunakar Reddy, sir.
Hello,
And,
all. The
I
oral
thank
presentation session will be starting in next 10 minutes.
Indian Academy of
So
Geriatrics,
be
the
ready
senior
with your
most Dr.
presentations.
B.S. Natarajan, sir, Dr. A.B. Day, sir, Dr. I.S. Gambhir, sir, and Arvind Mathur, sir, for their blessings and their valuable address given to this August gathering here. And at the same time, I thank Dr. Ramkumar Reddy, Vice Dean of Kakatiya Medical College, for present in this meeting, inaugural meeting, and giving his address. And I thank Dr. Y.S.N. Raju, sir, for his welcome address and for actively involving and every step in this conference. He is guiding me how to take it forward. Thank you very much, Y.S.N. Raju, sir. And I thank Dr. Rajendra Magesh, sir, Secretary IAG, for his constant help from the day one. It is announcing, sir was each step how to organize, in which way, how to call upon and all. So for his help is immense, sir. Thank you very much for that, and for today's sparing and participating in the inauguration function, sir. I also should thank Dr. Shanti Madam, the Chairman Scientific Committee, for her strength, because all the scientific persons are personal invitation from the Shanti Madam, and they are never refused. And there may be some mistakes from my side because of some miscommunication in getting the phone numbers and delivering the emails. Sorry for that, madam. For without your support, without your guidance, without your intervention, this scientific program wouldn't have been possible, madam. For sincere thanks for that. And also thank you, Shanti madam, for participating in the inaugural session today. And I thank President-elect Dr. Ashish Goyal, sir, for his valuable advice and presence today. And I thank President Dr. Prasad Matthews, sir, for his constant help for time to time advices and today's address, today's president oration. So, which was very beautiful. So many messages has been taken for all the delegates today. Thank you very much, Dr. Prasad Matthews, sir. So I think I
Just
haven't
one,
left any.
Dr. Chandrasekhar, we'd
Sir.
like to announce the Best Thesis Award.
Yeah, sir.
Which was
Sir,
awarded by
in this,
Dr.
yes, sir. So there are a few awards to be announced. One of such is the Best Thesis Award, which is given by IAG. This year, this goes to Dr. Yamini Ajmera. So it is 10,000 cash prize with a certificate of appreciation. So it is congratulating Dr. Yamini for selected as a best thesis for year 2021 and 22. And because there are 30 oral presentations and poster presentations are there, sir. So judges are there. They will announce the results. In the valedictory function, we will announce the winners on the last day, sir. And anything, sir? Vice and Raju, sir? So shall we conclude this inaugural meeting?
And
I thank all the delegates also, all the dignitaries who are presenting, because as of now in Hall A, 236 are watching our programs are in live. In Hall B, 93 are watching, sir. Total out of 400 delegates are registered for this conference. 329 are on board, sir. And 28 talks are there, sir. 5 orations and 38 chairpersons, 10 judges, and oral poster presentations are 30, sir. So that is the statistics of this GERICON 2021. Thank you very much for your August presence for this conference, sir. Thank you very much.
Thank you very much.
So with this, we are concluding the inaugural session, sir. And there is a short break of lunch.
Afternoon all, am I audible? Volume.
Yes, sir.
Yes, I invite Dr. Bijin judging the oral presentation one session. Bijin sir, you can start the session, sir. First speaker, Dr. Arun David.
Yes, sir.
Yes, sir. Arun, can you just project your presentation? Dr. Bijin is here
Yes, sir.
to evaluate. Sir, Dr.
Can I
Bijin
get
sir.
a Google Form, sir? There is nothing.
It was
How do we tabulate? Yeah.
Sir, I forward to your mobile, sir.
1 minute, 1 minute.
Yes, sir.
Is it visible, sir? Sir, is it visible? Sir, is it audible? So totally how many candidates? Yes, sir.
Five members, sir.
The first person can start. Yeah.
Sir, am I audible, sir?
Yeah, yes, yeah, a little bit. Yeah, carry on.
Okay, sir. So, very good afternoon to one and all present here. I am Arun David, and I would like to present a paper on a retrospective study on clinical outcome among the patients who are affected by COVID-19 infection in the elderly versus young patients who are admitted in a tertiary care hospital in Ernakulam, Kerala. So, first the introduction. So, we all know that COVID-19 infection, the pandemic has affected the entire world since the year 2019. And India is one among the worst affected nations with this pandemic. And the disease affects all the people of all the age groups, and it shows a poor clinical outcome, particularly among the elderly patients, due to their multiple comorbid conditions. And hence, the study was done to identify the differences in comorbidities and clinical outcome between the young and the elderly population. The main aim and objective of the study was to analyze the difference in the comorbidities between the young patients, that is less than 65 years of age, and the elderly who are more than or equal to 65 years of age, and to analyze the difference in the clinical outcome between the young patients who are less than 65 years and the elderly who are more than or equal to 65 years who had the COVID-19 infection. So the materials and method. So after getting the clearance from the Institutional Ethical Committee, we conducted the study, which was a retrospective study for a duration of 2 months. And the data we collected from the electronic medical records from the Department of General Medicine and from the Department of Geriatric Medicine. And we obtained a total sample of 330. The sample size, we obtained it based on a proportion of COVID-19 infection observed in the earlier publications with relative precision of 20% and 95% of confidence limit. And the minimum sample size was 322. Hence, we conducted this study on 330 patients. And the patients were again then grouped into 2 categories. So the first category was the elderly population who are more than or equal to 65 years. And the second one was the control group or the younger patients who are less than 65 years of age. And the inclusion criteria was all the patients who are positive for either antigen or RT-PCR for COVID-19 infection who were admitted to Amrita Institute of Medical Sciences, Ernakulam, Kerala, was selected as per the inclusion criteria. And the exclusion criteria was patients who were having improper or incomplete medical records and the patients who were less than 18 years of age. And the data collected was the name, the age, gender, then detailed history about the comorbidities, then details about the clinical outcomes in these patients, and the final outcome of all these patients. And the details about the comorbidities and clinical outcome among both the age group were statistically analyzed. And the data was analyzed with the help of SPSS software and to test the statistical significance of difference in between the 2 groups, the proportion of comorbidities and clinical outcome, we used the chi-square test. And for continuous variables between the 2 groups, like for example, age, we used independent sample t-test was applied. And the final result, what we observed was, out of total 330 patients, 263 patients, that is 79.7%, were below the age of 65 years. And 67 patients, that is 20.3%, were above or equal to the age of 65 years of age. And this is shown in the pie diagram. And among the comorbidities, we observe that coronary artery disease, chronic kidney disease, then cerebrovascular accident, and chronic obstructive pulmonary disease was more among the elderly population. And to our surprise, diabetes mellitus, systemic hypertension, then dyslipidemia, then chronic liver disease and malignancy was more common in the younger age group. And here it shows the comorbidities which are more common in the elderly population. Like coronary artery disease was more like 64.5% in the elderly, chronic kidney disease 63.6% in the elderly, CVA 62.5% in the elderly, whereas bronchial asthma was equal in the elderly and in the younger age group. And COPD was observed more in the elderly age group, that is 75%. And when it comes to clinical outcome, we observed that all of these were more common in the elderly age group. That was non-invasive ventilation, then mechanical ventilation, respiratory failure, then acute respiratory distress syndrome, then acute kidney injury, then renal replacement therapy, sepsis, then coagulopathy, heart failure, hypoproteinemia, and metabolic acidosis was all more common in the elderly age group. So here we again show that the non-invasive ventilation was used more commonly in the elderly, that is 51.2%. Then mechanical ventilation was used 64.7% in the elderly. Then respiratory failure was observed more common in the elderly, that is 52%. Then ARDS was more common in the elderly, 64.3%. Acute kidney injury was more in the elderly, 64.3%. And renal replacement therapy or dialysis was used more common in the elderly, that is 80%. And also sepsis was more common in the elderly, 58.8%. Then coagulopathy was more common in the elderly, 71.4%. Whereas surprisingly, ACS was equal among the younger and the elder age group. And heart failure was also more common in the elderly, that is 85.7%. And hypoproteinemia was more common in the elderly, with 55.6%. And even metabolic acidosis was more common in the elderly, that is 61.5%. And the final outcome, what we observed was that the patients who were stable, that was more common in the younger age group, that is 96.5% compared to the elderly, which was only 80.5%. And death was also more common in the elderly age group, that was 59.09% compared to the younger age group, who were 40.9%. So the discussion is that compared to the younger age group, the elderly population had more comorbidities, and the post-COVID complications and the mortality was more common in the elderly age group compared to the young in our studies. And all these observations were similar to the reference studies. So we highly recommend that once an elderly patient is admitted to the COVID-19 isolation ward, meticulous care should be given, as they have a high chance of developing complication and death. And their comorbid conditions should be clinically studied, and their medication should be optimized, and a management plan should be made for each individual, as adequate management can result in better outcome among the elderly population. These are my reference studies. First one is clinical features and outcome of COVID-19 in older adults. Second one is effects of comorbidities in the elderly patients with COVID-19. Last but not the least, I would like to thank Dr. Alex Baby Paul, Dr. Priya Vijay Kumar, and Dr. George Paul for helping me throughout this paper presentation. Thank you, everyone. Thanks.
जम के बोट के लिए फोटो कर इधर का
Good presentation, Dr. Arun.
Thank you, sir.
Actually, you have some.
Bijin sir, this is Dr. Chandrasekhar.
Yes, sir. Please, sir. Yeah.
Sir, Bijin sir, this is
Yes,
Dr.
sir.
Chandrasekhar.
Yeah, I can.
Yes, sir.
Yeah,
So
yes,
I'm
sir. Yes,
here.
sir. Please, sir.
Where is it? It is coming. నేను కనిపించట్లేదు. So first speaker is over, no sir? This one.
You can have the discussion is there.
Yeah.
We have 8 minutes of presentation and 2 minutes of
Yes, sir.
discussion.
8 minutes, sir, for presentation, 2 minutes for discussion, sir. So I have sent you for your WhatsApp that scoring. So
yes, sir. Yes, sir.
You give the scoring, sir. I'll just supporting you for this program.
Yeah, I will consult and give you the answer. I'll just total it. At the end,
Yes,
I'll
sir.
give you together. That will be
Okay,
better.
sir. Okay, sir. So you can ask the questions, sir. You can ask the questions if any. So I can also ask in between because I joined in middle. So for this first student, you ask, sir. So I think it is Arun David, no?
Yes, sir.
Yes, sir.
So actually, this
right. Kandla calendar illana thala oda mattandi.
Arun David, what is your conclusion of study?
Yes, sir. The conclusion, what we observed that in once and among the elderly patients, the comorbid conditions, the more observed, and post-COVID complications and more observed in the late patients in our study.
Okay.
Yes, Andra.
Okay.
Dr. Arun, actually, this is a e-poster, right?
Yes, sir.
Poster.
Okay.
So this is oral presentation, sir. It is not e-poster. So this is oral.
You told it is e-poster. Okay. This page. Okay. Fine.
It is oral presentation, sir.
Okay. So just 2 questions. You are telling about the study about above 65 and less 65 years. 65 years, am I right? So even though the comorbidities were there in the above 65, you told, but the more incidents in the young age, am I right? As per your study, 263
Yes,
patients
among few
from
diseases,
young
few diseases, like
yeah. So what was the recovery rate out of that?
recovery was much better in the younger age groups compared to the elderly because finally the mortality and morbidity was more and was more
Not
common
clear.
in the elder population. That was around 50.
Sorry. Audio is not clear. Can you just?
Your audio is not clear, Arun. It is totally not heard. I think from your end it is problematic. Yes, but that resound is coming, and so try to talk. We'll try to answer. So check your internet issues and come back, sir. What we will do, sir, Bijin sir? So we'll call upon the next student. Who's the next student? Yeah, thank you, David. So we will call upon the next oral presenter.
Yes, sir.
Dr. K.S. Kesava Raj.
Yes, sir. Myself.
Kesava Raj is here. Yeah.
Yes.
Can you hear, sir?
Am I audible, sir?
Yeah. You are audible, but please check your internet and that clarity.
Okay, sir.
Otherwise, then we cannot able to hear and all. So,
Okay.
go ahead with your presentation by sharing.
Yes, sir. Yes, sir. Able to see, sir? Able? My slides are visible, sir? So, are you able to visible my slides?
Yes, yes.
Shall I start, sir? Yes.
Yeah. Start.
Yes, sir. Good afternoon, one and all. The study which I am going to talk today is correlation between the severity of the chronic kidney disease and the cognitive decline. I am Dr. Kesav Raj, first author.
Okay, others kindly unmute, please. Mute yourselves, please. Yeah.
Shall I continue, sir? Yes.
That's the recommended.
Yes, please.
Okay. Yes. Starting from the introduction, the study was mainly based on three reasons. One being increased prevalence of chronic kidney disease in the Indian population due to long-standing comorbidities like diabetes, hypertension, and partly due to increased longevity. And second reason being CKD patients have a high risk of developing cognitive impairment compared to general population. This may be due to increased cerebrovascular events and the uremic metabolites, and also partly by polypharmacy. And third reason being cognitive decline may affect the level of compliance with the treatment, like dialysis, medical adherence, fluid and dietary restrictions. Therefore, early identification of possible precursors of dementia and treatment of modified risk factors is of paramount importance. Moving on to the aim of the study, primary aim is to determine the correlation between the severity of the chronic kidney disease and the cognitive decline, and also to estimate the impact of chronic kidney disease on various domains of cognition and other associated risk factors affecting cognition. Moving on to the methodology, the study was mainly based on cross-sectional observation study, which was done 1 year and 4 months, which was duly approved, not approved by Ethical Committee of Madras Medical College, Chennai. The inclusion criteria were person aged 60 years and above who are willing to participate in the study with the proven kidney disease as per MDRD criteria, at least for the past 3 months. We used EGFR values based on the formula to categorize the participants into stage 2, stage 3A, 3B, stage 4, and stage 5. The exclusion criteria were patients CKD who are all critically ill and who are already diagnosed with Parkinson's, stroke, dementia, and other neurological conditions may affect the cognition, and those who are not willing to participate in the study. The sample size was 150. The sampling method done by using simple random sample. The data analysis was performed using SPSS software V20, and the level of significance was done by Fisher-Exact test with a p-value kept below 0.05. In addition, the strength of the linear association between the variables was calculated with the ANOVA. The prevalence of cognitive decline was evaluated by using Adler-Brooks cognitive examination, which has 5 domains, namely attention, memory, fluency, language, and visual expression. Maximum score of 100, those who score more than 87 are normal, and those who score less than 87 are named as a cognitive impairment. Moving into result and discussion. This graph shows age distribution in the study population. Among the 64% belongs to 60 to 69 years, 69 years of age, that is young old, followed by 31% were between 70 to 79 years, that's older population, and 5% were more than 80 years of age, that's old one. And regarding literacy of the study, population 59% at least primary school and 41% during after school. And this slide diagram shows stage-wise prevalence of the CKD. And the majority of the study population belongs to stage 3 and stage 4. Among the 46% is major, that is comes under grade 3B category. Next one, 33% belongs to stage 4 category. This shows cognitive decline in the study population. In CKD patients, the severe stages like stage 4 and 5 prevalence were high. The prevalence of cognitive decline high compared to the mild stages like grade 2 and 3. Though the majority of the study population in the milder groups, the percentage of cognitive decline is still high in the severity groups like stage 4 and 5. And their difference between these two was statistically significant. And based on this Adler-Brooks score, the diagram shows the impact of the CKD on the individual domains. Among the 5 domains, memory the most affected, followed by fluency, then visual spatial. The less affected are attention and language. Moving on to discussion. In our study, age of the individual has significant positive correlation with the cognitive decline. That's as age ages, the cognitive decline also increases. In case of literacy, we have a negative correlation, where the lower the literacy, higher the cognitive decline. So logistic regression analysis was done for these individual variables and it was matched with the study outcomes. Other variables like hypertension, diabetes, dyslipidemia, and smoking were found to be not significant to cognitive decline in our study. So our observations are consistent with the findings earlier published reports that were mentioned in the reference one. That too in one particular study, which was done 2018, which concluded that the severity of the renal function was positively correlated with the cognitive decline, which was main aim of our study.
2 minutes more. 2 minutes more.
And going on to the conclusion, high prevalence of cognitive decline was observed in our study population, and the most commonly affected domains were memory, fluency, and visual spatial. The severe categories like 4 and 5 are more prevalent compared to mild categories. Hence, cognitive decline was possibly associated with the severity of this CK. So, though our study is one of its kind to address the cognitive decline in CKD patients based on the MDR classification, further longitudinal study with a large sample needed to confirm our study findings. And these were our references. First one is like the moderate renal impairment and risk of dementia among the older population. The second one is the severity of kidney disease associated with the cognitive decline. Thank you.
Very good. You have presented in time. So over to Bijin sir to ask some questions.
So you're telling about the hypertension, diabetes, and dyslipidemia were not statistically significant. So did he find any other risk factor for CKD that was significant, causing this cognitive decline?
Yes, sir. In our study, it's only age and literacy correlation with the outcome of the study. The other co-founders not found not to be significant.
Were the patient on any drugs? The CKD, no? So did you assess that? Yes, any patient on any drugs?
Yes, sir. The medications also, sir. Drug history and we also dialysis history, everything. It's not associated with any.
So no history of any polypharmacy or any drug interactions, right?
Yes, yes, sir.
Confounding
Yes,
this
sir.
only the
medications, yes, sir.
So what do you say?
I think that's a okay. We'll move on to the next. So next is P. Santosh Manikandan. Santosh Manikandan. So unmute yourself, Manikandan. Yeah.
Can you hear me, sir?
Yeah, you are audible very much. So
Yes,
share your screen and present yourself. Your time
Sure,
is
sir. Sure, sir. Sure, sir.
okay.
Sure,
So
sir. Sure. Sir.
Sounding is coming. Please check.
Yes, sir.
Okay.
Can you see the screen, sir?
Not yet. Please again share.
1 second, sir. 1 second.
Yeah. Yes. But it is coming like now it is okay.
Yes, sir.
Yes.
Yes, sir.
Okay.
Shall I start, sir? Yeah.
Yes. Proceed.
Yeah. Good afternoon, sir.
Good afternoon.
I'm going to present a paper on correlation between cognition and frailty syndrome. My name is Dr. P. Santosh Manikandan, and I'm the first author of this paper. We have no financial relationship to disclose or conflict of interest to resolve. So coming to the study, we know that the frail Indian elderly population is on the rise, and hence it is important to study their characteristics so that we can provide a better care. Frailty is defined as a reduced physiological reserve in multiple organ systems with decreased capacity and environmental, and be it what kind of stressor it is, either physical, emotional, psychological, and it is preceded by a pre-frail stage characterized by increased risk of geriatric syndromes. We also know that cognitive decline is seen with aging, but since the classical Fried's criteria used to pick up frailty phenotype did not include cognition, this study is done to find out if there is a relationship between cognition and the various frailty phenotypes. Hence, the aim of the study is to determine the prevalence of frailty and pre-frailty among our study participants using Fried's criteria and to determine the association between cognition and frailty phenotype. So how did we conduct the study? It is a hospital-based cross-sectional observational study conducted in a regional geriatric center, Madras Medical College, Chennai. Sample size taken as 200, calculated based on the prevalence rate of frailty in Indian population using Cochrane's formula. And ethical committee approval obtained from Institutional Ethical Committee, Madras Medical College, with an IEC number of 26042018. Study was conducted for a period of 16 months, during which participants were recruited based on simple random sampling following the inclusion and exclusion criteria. Participants with severe cardiac, pulmonary, musculoskeletal disorders, stroke, and dementia, and those who are not willing to give an informed consent were excluded from the study. And patients are classified into 3 categories based on the Fried's criteria as frail, pre-frail, and non-frail, based on the scores they obtained by applying this criteria. The criteria we used include the basic classical Fried's criteria, which included unintentional weight loss of at least 5% in the prior 12 weeks, self-reported exhaustion, slow gait speed, low grip strength, or low energy expenditure. People who scored 3 out of 5 are considered frail, 2 out of 5 are pre-frail, and none of the above criteria, fitting in none of the above criteria is non-frail. Minicog is done to the participants who were classified in these 3 classes, which basically included a 3-word recall and clock drawing, which included a pre-drawn circle. And Minicog scores are allotted from 0 to 5, and score less than 3 is considered to be indicative of cognitive decline. So we classified participants in the 3 groups, and the difference in prevalence of cognitive decline among these 3 groups studied using Pearson chi-square test. Multivariate logistic regression analysis done for adjusting all possible confounding factors, which included age, BMI, comorbidities, physical activity, and sex of the individual. P-value less than 0.05 is taken to be significant. In our study, we found that 50 people came in frail group, 109 people came in pre-frail group, and 41 people came in no frail group. So frailty prevalence is 25%, pre-frailty is 54.5%, and no frailty is 20.5%. And also, we also found that among our study participants, 10% had a cognitive decline, whereas 90% had no cognitive decline. This graph represents the percentage of participants obtaining various Minicog scores. According to this graph, 10% had a score of 2. The numbers below indicate Minicog scores. 10% had a score of 2, 63% had a score of 3, 20% had a score of 4, and 5% had a score of 7% had a score of 5. Since we take 2 as to be indicative of cognitive decline, 10% has cognitive decline, whereas 90% have no cognitive decline. This is the overall summative graph. Before understanding this graph, we need to have a few things in mind. There are 3 individual bars here in this graph representing the 3 categories we classified patients according to Fried's criteria. We know that the number of participants who got allotted in each of these categories is different. For example, in non-frail, it is 41, pre-frail, it is 109, and frail, it is 50. So hence, the absolute numbers can't be compared in between these graphs, whereas the relative percentages can be compared. In this graph also, blue represents a score of 2, red represents a score of 3, green represents a score of 4, and purple represents a score of 5, which are Minicog scores. And so for the sake of simplicity, let us focus only on the cognitive decline group, which is blue. And this indicates that in non-frail group, 2% had cognitive decline. In pre-frail group, 7% had cognitive decline. And in frail group, 22% has cognitive decline, which is the lowermost part of the 3 graphs. So from all the above results, we found that the prevalence of frailty is 25% among our study participants, which is similar to the prevalence rate of frailty in the community-based study done in Tanjavur in 2019 by Kribakaran et al. In our study, cognitive decline is seen in 22% of frail individuals, 7% of pre-frail individuals, and 2% of non-frail individuals. Applying in interferential statistics, we found that the association between frailty and cognitive decline is statistically significant with a p-value of less than 0.05, whereas the association between pre-frailty and cognitive decline is not statistically significant. So we conclude that in our study based on 200 elders, we find that frailty is associated with cognitive decline, whereas pre-frailty is not associated with cognitive decline. The limitation which we feel is that Minicog is only a screening tool for the detection of cognitive decline, though it has a very good sensitivity and specificity. None of these participants are diagnosed to be having either MCA or dementia based on the criteria. They need to have cognitive decline. Further community-based study with a large sample size and a longitudinal study is needed to prove this association in a better manner. And these are my references I used for the study. I would like to thank IAG for giving me an opportunity to present my study in this forum. Yes, sir.
Yeah, okay. Yes, sir. Vijay sir, ask some questions.
Yeah, good presentation, Dr. Santosh.
Yes, sir.
Okay.
Yes, sir. Thank you, sir.
You are telling about the frailty and frail people
Yes, sir.
in cognitive decline. Some 22% you are telling, and some percent
Yes, sir.
fail. So you are assessing the Minicog and all, the
Yes, sir.
clock
Yes, sir.
drawing and the thing.
Yes, sir.
How was literacy of these patients? Like educated or uneducated, able to understand because
Yes, sir.
in the age group also.
Yes, sir. Actually, we did not have any criteria to exclude people who didn't attend school as in the study itself. Basically, we use only 3-word recall and clock drawing, which are not much affected by the literacy in Minicog, sir. That is the one reason we selected Minicog for the study. Most of the people we included were accustomed to both clock drawing as well as recall, sir. So.
And any age group you said, for example, above 60 to 60 to 70, 70 to 80, the age group we fixed. Which age group were more prone for cognitive decline? Anything like that? Based on frail?
Sir, we
about
found that.
22%.
Sir. Yes, sir. We found that both frailty as well as cognitive decline is more prevalent as in old, sir, compared to the young old. In old, both rates were high. And among those frail elderly, we found that cognitive decline is more prevalent.
Okay. One final question.
Yes,
did
sir.
you assess for any evidence of sarcopenia in these patients?
Actually, yes, sir. I also assessed sarcopenia, but for the sake of simplicity, I restricted myself to cognitive decline and frailty, sir. I also have the data, sir. I'll present it in once complete analysis over, sir.
Thank you. Thank you.
Any other questions?
So we can conclude, sir, Santosh talk.
Yes, sir.
Thank you, sir.
Yeah, thank you, Santosh.
Thank you, sir.
We'll move on to the next speaker. That is Ebenezer Lal Ruhati Luanga.
Yes, sir.
To pronounce the second part. So we'll call you as Ebenezer. So are you there?
Yes, sir. Am I audible?
So unmute yourself. I'm unable to hear you.
Sir, can you hear me now?
Voice is not coming. You're unmuted, but your voice is not coming. Ebenezer?
Yes, sir. Can you hear me now? Am I audible, sir?
Yeah, now you are audible.
Okay, sir.
And share your screen and start presenting your paper.
All right, sir. Sir, can you visualize the screen?
Yeah. Your skin is very much visible. So go ahead.
All right, sir. Good afternoon. My name is Dr. Ebenezer, and I'm a third-year postgraduate from Madras Medical College. And today my topic for presentation is correlation between neutrophil to lymphocyte ratio, NLR, and the severity of sepsis in elderly patients. Coming to the introduction, Sepsis is a major cause of morbidity and mortality in elderly patients worldwide, especially in developing countries. In elderly, due to immunosenescence, there is decreased function of both innate and acquired immunity, which makes them more vulnerable to infection. So sepsis is more common in them. NLR has been used to assess the prognosis in various diseases, including cancer, inflammatory condition, surgical condition, etc. And its validity in sepsis assessment can be done by comparing with validated sepsis severity scores like SOFA, APACHI-2, and SEP2 score. So the aim of the study is to determine the efficacy of NLR as a prognostic marker for sepsis in comparison to already established scores like SOFA, APACHI-2, and SEP2 score, and to correlate the association between NLR and the outcome in elderly sepsis patients. The methodology, the study is a prospective observational study, which is done in RGGH and MMC Chennai. Institutional ethical committee permission is obtained, and the sample size is 200. The method we use for sampling is consecutive samplings. The duration is 15 months. The inclusion criteria is elderly patients above 60 years who fulfill at least 2 out of 3 QSOFA criteria on admission, which are low blood pressure, systolic blood pressure less than or equal to 100 millimeter mercury, high respiratory rate more than or equal to 22 breaths per minute, altermentation, which is a Glasgow Coma scale less than 15. Exclusion criteria is patient in whom NLR were likely to alter, such as chronic inflammatory condition, hematological disorder, history of steroid usage, history of chemotherapy and radiotherapy, and who developed sepsis after initial hospitalization. With the patient consent, blood was drawn for hematological workup and relevant culture from suspected source of infection along with radiological investigation were done. For each patient, SOFA score, APACHI-2 score, and SEP2 score on admission were calculated. Then NLR was correlated with all 3 scores, and those patients in whom sepsis was proven by investigation were followed up until discharge or death up to 1 month. Analyses were performed using the SPSS software version 20.0. Difference in the proportion were tested using the Pearson chi-square test, and a two-tailed p-value less than 0.05 was considered as a level of significance. The result. In our study conducted in RGGH, which involved 200 patients, 108 were male and 92 were female, which is shown in the pie chart below. Among these patients, 55 patients died during the study and 145 recovered from the sepsis, which we can see in the pie chart below. And coming to the causes of sepsis, among the patients we studied, 57.2% were diagnosed with respiratory infection, which comprise of majority of the causes. And next is the urosepsis, abdominal infection, skin and soft tissue infection, meningitis, other infection, and sepsis of unknown foci, which is depicted in the pie chart. The patients were arbitrarily categorized into 5 groups based on the NLR values of 1 to 3, 3 to 6, 6 to 9, 9 to 18, and more than 18. Out of the patients we study, majority of them have an NLR value of 9 to 18, which is 36.5%. In our study also, SOFA scores is divided into 3 groups, and majority of them has scored between 7 to 10. Likewise, APACHI-2 scores were divided into 3 groups, with majority of them having a score between 11 to 20. While SEP score is also divided into 3 scores, majority of them have a score between 21 to 40. And coming to NLR and disease outcome, as we can see in the graph below, as the NLR increases from 1 to 3 range to more than 18, we can see the mortality rate also increases. On the other hand, as the patient has NLR with 1 to 3 has a better recovery rate than patient with NLR more than or around 9 to 18. So we can say that as the NLR increases, the outcomes is also poorer. And this is the correlation between the NLR and the sepsis scores. We can see as the NLR also increases from 1 to 3 to more than 18, all the sepsis scores also increases from SOFA, APACHI, and SEP2 scores. All of them also shows increases as the NLR increases. Coming to discussion, in our study, it was found that NLR correlated significantly with the sepsis severity scores. Higher NLR was associated with higher values of all scores. This is in accordance with the study done by Belisarius et al., which was a case series involving 50 patients admitted to emergency department with sepsis, in whom NLR correlation was done with already established markers of sepsis. In our study also, there is a statistically significant correlation between NLR and sepsis outcome. Among the patients with NLR more than 9, 37.5% of them died during the study. Higher NLR was associated with higher mortality with a p-value less than 0.05. This is in accordance with the study conducted by Richard et al. And also similar to a study conducted in Italy by Della et al., in which NLR was studied as a marker for predicting prognosis in elderly patients with community-acquired pneumonia, where NLR predicted 30-day mortality. Higher NLR was associated with poorer outcomes. So to conclude, NLR correlated well with SOFA with a p-value less than 0.01, APACHE2 with a p-value less than 0.01, and SEP2 score with p-value less than 0.1. This indicated NLR can be used as a prognostic marker of sepsis in elderly patients, as it correlates with all the established sepsis severity scores. In our study, NLR also correlated well with outcome in sepsis patient, as higher NLR was present in non-survivor than survivor with a p-value less than 0.05. Therefore, we can say NLR can also be used to predict mortality in elderly sepsis patients. The limitation can be single center study with a less sample size, and serial NLR was not done to assess the change. And these are the references which I taken from my study. Thank you.
Okay, Ebenezer, it's a very good presentation and you have finished within the time. So over to you, Bijin sir, to ask a few questions.
Yes, sir.
Okay. Good presentation, Dr. Ebenezer. Just you were mentioning about that cause 57.2% of respiratory infection, right?
Yes, sir.
Your data.
Yes, sir.
Cause of sepsis. So what respiratory infection most commonly did you encounter? Is it pneumonia, any other infection? Is it community pneumonia or any other infection?
Yes, sir. Lower respiratory infection were most common in our study.
Okay.
And followed by pneumonia.
Okay. So now you're also telling about some of the deaths, no? Some deaths that occurred, some percentage you mentioned. So what was the cause of that fatality? I mean, within how many days those deaths occurred? Majority. Suppose most of them recovered, some of them recovered. Within how many days any death of admission, from date of admission? Yeah.
The study is conducted within 30 days from the day of admission. So during the 30 days, 1 month period, we follow up the patients. So at the end of the 30 days, during the 30 days, whether the patient recovered or whether the patient died, we followed. So as we can see that more than NLR of 18, the mortality rate is very high.
Okay. So did the NLR improve with any specific antibiotics, like for example, yeah?
Yes, sir. As we are giving treatment also, the NLR can improve. As we treatment is going on for the patients, so NLR also improves.
So you mean to say the delayed presentation of the patients probably is one of the cause of mortality, right? Even though the same treatment is carried. You mean to say like that?
Yes, sir.
Fine. Okay.
Thank you, sir.
Okay, sir. So, okay, Ebenezer, all the best.
Okay, thank you, sir.
Okay. Then we will be moving on to the last speaker of this session. Abhijit, Dr. Abhijit or Rao. Are you there?
Yes, sir. I'm here.
Yeah. Please present your
sharing my screen, sir.
Yeah, your screen visible.
Okay. So, very good afternoon to all. My name is Dr. Abhijit. I'm a geriatrician and currently a fellow in geriatric oncology at Tata Memorial Hospital, Mumbai. The title of the study that I'll be presenting is Intrinsic Capacity of Community Dwelling Older Adults, an observational study from South India. So, I have no conflict of interest to disclose. WHO has defined healthy aging as the process of developing and maintaining the functional ability that enables well-being in older adults. So functional ability is the combines the intrinsic capacity of the individual and the environment a person lives in, and how people interact with their environment. Whereas intrinsic capacity is the composite of all the physical and mental capacities of an individual, and environment is all the factors which is in the extrinsic world where a person lives, from home, communities, and broader society. To put it in perspective, let's say an older adult is currently watching this presentation right now on his monitor screen wearing a spectacle. If so, that would be his functional ability, that he is able to see and comprehend what is going on in the monitor. Now if he would remove his spectacles and see his because of the diminished vision, he may not be able to see the content of the monitor. That would be his intrinsic capacity. But because of his interaction with the environment, that is, he's using spectacles, he's improved his functional ability to comprehend what's going around him. So this is a graph which shows the functional ability in the blue and the intrinsic capacity in red. Whereas in the initial stages, when they are younger adults, there is high and stable capacity, and we see that there is not much gap between the two. Whereas in the early declining phase, there is a gap which is and in the there is significant loss in capacity in later age. But this gap can be bridged by using of other instruments which are available in the environment to facilitate and improve their functional abilities. So what are the domains of this intrinsic capacity? The domains are, there is vitality, visual capacity, hearing capacity, cognitive capacity, psychological capacity, and locomotor capacities. So the aim of the study was to investigate the proportion of impaired intrinsic capacities among older adults aged 60 years and above living in the community, and also to determine the prevalence of decline in each of these domains. It was an analysis of a cross-sectional observational study conducted in the community setting in the coastal city of Mangalore, conducted over 1 year, and the participants were community dwelling older adults who were aged 60 years and above and who had consented for the interview and the geriatric assessment. The assessment included collection of demographic details such as age, gender, education, income, anthropometric measures, and medical evaluation, which included blood pressure, comorbidities, substance use, and geriatric assessment included assessment of domains of cognition, mood, gait, functionality, nutrition, hearing, and as well as vision. So we had to derive the score of intrinsic capacity. For this purpose, we scored each domain into a score of between 0 to 2. A score of 2 meant that the domain was completely intact, whereas anything less than that meant that there was a decline in the domain. So for this purpose, for the purpose of assessing vitality, we used two things, that is unintentional weight loss of more than 3 kgs in the past 3 months, as well as low BMI. If both of them were normal, then the person was scored as given a score of 2 for vitality. If one of them was abnormal, he was scored as 1, and if both were abnormal, he was given a score of 0. Similarly, for cognition, we use 3-word recall and the Hindi cognitive screening test. Here again, if both were normal, that is, if they could recall all 3 words, as well as they had a HCST score of more than 24, they were given a score of 2. And if one of them was impaired, they got a score of 1. And if both were impaired, they got a score of 0. Sensory included assessment of hearing as well as vision. So for the purpose of assessing hearing, we used a whisper test, and for the purpose of vision, we used a screening questionnaire which asked them if the deficiency in their vision caused any impairment in their activities of daily living. Psychological domain was assessed using a screening question as well as a GDS-15. And for the purpose of locomotor domain, we used timed up and go test and 30-second chair rise test. Here we used a cutoff which was recently published from the Indian population by Dr. Venugopal et al. From AIMS New Delhi. So statistical analysis, we used the Stata version 14. Continuous variables were described as means and standard deviation or median with range. Categorical variables were described as frequencies and percentages. Association between categorical variables and intrinsic capacity was analyzed using Pearson's chi-square test, and the p-value of less than 0.05 was considered statistically significant. Coming to the results, a total of 1,000 participants for community dwelling older adults were included. Among them, 63% of them were women. The mean age was 68.5 and around 78% of them were below the age of 75. Among the entire population, we found that only 5.5% of them had a completely intact intrinsic capacity score. That is, they scored only 5.5 of them got a score of 10. We took ADL as a gold standard, and we derived a cutoff score for intrinsic capacity, which was 7. So anyone who got a score of 7 and above was defined as having an intact intrinsic capacity or a good intrinsic capacity, and those below the score of 7 were categorized as having impaired intrinsic capacity. And we found that around 790 of them had intact intrinsic capacity, whereas 210 of them had impaired IC. And we found on analysis that those who were older, that is more than 75 age group, had more percentage of them with impaired intrinsic capacity. That was 29% when compared to only 19% among those with intact intrinsic capacity. Gender and socioeconomic status had no statistically significant association. Similarly, marital status, substance abuse, or BMI had no statistically significant association. Because ADL was taken as a gold standard for cutoff, that would obviously show a significance here. Among the comorbidities, we found that presence of 2 or more comorbidities, that is called as multimorbidity, was significantly associated with decline in intrinsic capacity. And among the different comorbidities, we found the presence of chronic neurological illnesses such as a CVA or Parkinsonism or cognitive impairment was statistically significantly associated with declined intrinsic capacity. Though we found that the prevalence of hypertension and chronic respiratory illness was slightly more in the intrinsic declined group, but it was not statistically significant. Among the various domains which were assessed, we found that sensory followed by locomotor were the most impaired domains of intrinsic capacity, which was 75 and 73%, whereas which was followed by vitality, mood, and cognition. So the main findings of our study was a declining in intrinsic capacity with increasing age, association with multimorbidity and chronic neurological illness. Locomotor and sensory domains were the most which were impaired. In a cross-sectional similar study, so a cross-sectional study published in BMJ by in a study in China, which was in 5,823 people, they found that 40% of them had a decline in intrinsic capacity, and they too found that locomotor and sensory were the most commonly impaired domains, though their prevalence was much lesser than what we found in our population. Another population-based cohort, which is done by the 1066 dementia group, which included countries of Latin America, India, and China, which included 17,000 people, found mocomotor, vision, and cognition to be the most impaired groups, and only around 30% of the total population had a full intrinsic capacity score. They found that between 2/3 to 3/4 were affected by decline in at least one of the domains, and most of those with significant decline at baseline had not yet gone to become physically frail or developed needs for care. So to conclude, the proportion of older adults with declined intrinsic capacity was high. Sensory and locomotor domains were the most affected. Increasing age, presence of multimorbidity were associated with decline in the intrinsic capacity, and these domains have a scope for intervention which may improve the functional ability, and further longitudinal studies are needed to establish the prognostic role of intrinsic capacity. So these are my references, which includes the integrated care for older adults by WHO and the group of publication by Martin Prince. And this is our department in back in Mangalore, which is Department of Geriatric Medicine in Yanapaya Medical College. And I'm also happy to announce that we are will be starting our PG program here, and we'll be adding to the strength of geriatricians in our country. Thank you very much.
So wonderful presentation, Vijit.
Thank
so
you, sir.
Over to Bijin sir to ask few questions.
Yes, thanks, Dr. Abhijit's wonderful study, a new study basically considering the healthy aging, and it's exhausted some 1,000 individuals who are taken good. So you are telling about multimorbidity and other chronic neurological illness and all. Okay, did you assess for any cognitive impairment? Out of the 1,000 individuals, how many percentage were found with cognitive impairment? Something. Yeah.
Yes, sir. So one of the domains of intrinsic capacity is cognition. So for the purpose of assessing this, we used a hybrid score called as the Hindi screening tool, which is a hybrid of MMSC as well as HMSC, and it is also available for in public domain for use. So in that we did find, I do not have the exact number right now for the purpose of presentation, but that is why we found that around 11% of them had a decline in cognition domain, sir. 11% of them had a score of less than 24.
ఇది ఎవరు వచ్చారు? ఓకే, ఎవరు పంపించారు?
And what was the commonest risk factor that you found? You were telling about multimorbidity, right? So like hyper non-communicable diseases. So how much they're ambulant, they're mobile.
రేపది రేపటి
Sir?
ఎజెండాకి
Sorry, I couldn't hear you.
రేపు డొనేషన్ చూడండి.
And you're telling a lot of the multimorbidities, right? So which is
Yes,
the
sir.
most
Yes, sir.
commonest morbidity, comorbidity you find among those community dwelling individuals?
Okay, that was hypertension, sir. As we would expect, it was hypertension, which was the most common, which was followed by diabetes and chronic respiratory illness, which had almost similar. CVD and CVA were at the lower end, sir. The commonest was hypertension in community dwelling, but it didn't have any statistically significance with intrinsic capacity.
Sure. Thank you.
Thank you.
Thank you very much, sir.
With this, we are concluding oral presentation session 1, OP1. And sir, Vijin sir, we are concluding for lunch, sir.
Okay, sir.
2 p.m. sharp, another session of oral presentation will be there, sir. Sir, Vijin sir, again, you continue, no, sir, because of there is a clash with another judge. So after lunch, I think you are not.
Sir, what time? 2 o'clock, huh?
At 2 o'clock. 2 or 2:10, not a problem.
Okay, sir. Sure, sir.
Okay, sir. I'll call you again, sir. Okay. So Venkatrajam will be there, sir. And USL will be there. Another 5 will be there, sir. 1, 2, 3, 4, 5. So we will share at the end of the day. And after that, e-posters are there, sir, in hall 2. That will be YSN Raju and Buchireddy sir will take. Sir. Okay, sir. So now 145. So 215 we say, sir. 215 to 315 and 3.
Okay, sir. Sure.
Will be other session.
Sure, sir. So only one session. E-poster did not come now. Only for this, right?
No, your e-poster under judges will come, sir. Raju sir and Buchireddy sir.
Okay, sure.
And for this next session, yourself and Dr. Venkatrajam sir is there. So if the Venkatrajam is not available, I myself will join with you. Sir.
The same link. I'm not closing. Just mute it.
Just mute and go for the lunch and come, sir. So whenever you
thank you.
Start again. So the
sure, sir.
You are logged into this session, other oral presenters. So come after by 2 p.m. sharp after having lunch. Okay.
Sure, sir. Okay, sir.
So next session will start at 2 p.m.
మ్యూట్ అన్నప్పుడు మాట్లాడాలి.
ఇప్పుడు యూ కెన్ టాక్. అయిపోయిన తర్వాత ఇప్పుడు నువ్వు మాట్లాడవచ్చు అన్నట్టు.
హలో, వాళ్ళకి వినబడతాయి.
ఏందో ఉంటది ఉమ్.
హలో పార్టిసిపెంట్స్ వాళ్ళు రాలేదు.
ఆరు బదులు
హలో హలో వాళ్ళు రాలే కదా
ఫోన్ చేశాడు వాళ్ళు, ఇది తీసేయి, అది తీసేయి, అది కింద మ్యూట్ చేయాలి.
మ్యూట్ బటన్ చెప్పండి.
నోటే ఉన్నా నేను మాట్లాడాలంటే మ్యూట్ చేయాలి.
నువ్వు మాట్లాడాలంటే అన్మ్యూట్. యూఆర్ అన్మ్యూటెడ్. ఇక్కడ అన్మ్యూట్ అని అన్మ్యూట్ అయిపోయింది కదా, మళ్ళీ ప్రెస్ చేస్తే మ్యూట్ అవుతుంది.
మ్యూటే ఉన్నది కదా.
మ్యూట్ లేదు. The next ఇప్పుడు మాట్లాడుతున్నావు. Now you want to stop.
ఇక్కడ వాయిస్ మ్యూట్ అవుతుంది అట్లా.
ఇప్పుడు ప్రెస్ చేయి. ఇప్పుడు
ఇప్పుడు నేను మాట్లాడేది వినబడుతుంది. హలో హలో
వినబడుతుంది. ఒక్కసారి
హలో
Good afternoon, sir. Dr. Bijun here.
మేడం ఇంకోటి Sir, Dr. Bijin sir will join in 5 minutes. Sir, yeah, he joined, sir. Sir, Venkatrajan, sir, you can start the session.
హలో
హలో
చెప్పండి అమ్మా
హలో
వాట్స్
వెంకటరాజన్
చెప్పండి అమ్మా
సార్ మీ వాట్సాప్ కి
Sir, please start the session.
Yeah, who are the candidates for the session, sir? Can you just call out the names? Yeah.
So, first candidate is Amtoj Singh, sir. I spotlighted him. Yeah, he is.
Good afternoon, sir.
Hello.
Hello.
Are you able
Hello.
to hear me?
Good afternoon.
Sir, should I start?
You can start. Now the first speaker. Amtoj Singh.
Yes, sir.
Lamla.
Yes, sir. Yes, sir. So, are my slides visible?
Yeah, yes, doctor. Yeah.
Okay, I'll start, sir. Good afternoon, respected jury. I'm Dr. Amtoj Singh Lamba, postgraduate resident from Government Medical College and Hospital, Chandigarh. The topic of my paper presentation is prevalence of sarcopenia among ambulatory elderly patients aged 65 years and above with type 2 diabetes mellitus. This study was conducted by the Department of General Medicine along with Department of Radiodiagnosis and Physiology. Population aging is a human success story reflecting the advancement of public health, medicine, and economic and social development. However, although prolongation of life remains an important public health goal, the preservation of the capacities to live independently is of even greater significance. Aging is accompanied with multi-system functional decline and important changes in body composition, the most important of which is sarcopenia. Initially, sarcopenia was described as age-related muscle loss, but the current definition includes age-related decline in skeletal muscle mass as well as decline in muscle function, which is defined by decreased muscle strength and low physical performance. And all this can in turn result in reduced physical capability, falls, disability, and mortality. The importance to study sarcopenia is that sarcopenia is potentially reversible, and it is possible to restore physical capacity through musculoskeletal rehabilitation. Diabetes, as you know, is a very common chronic disease in the elderly population, and it affects all major organs, therefore affecting multi-system function, which in turn could lead to functional disability, mobility, limitations, and increased mortality. The underlying mechanism by which diabetes coexists with sarcopenia has not been fully elucidated. However, chronic inflammation, oxidative damage, and mitochondrial dysfunction have also been hypothesized. Besides this, diabetics have increased insulin resistance, and reduced insulin signaling can lead to decreased protein synthesis and increased protein degradation, which in turn can lead to reduced muscle mass. So the need for carrying out the study was that we all know that association of diabetes and sarcopenia is described in the literature with prevalence of 2 to 3 times higher in diabetics than control.
Can you please unmute yourself? Someone the mic is unmuted. Yeah.
Should I continue, sir?
Yeah, yes, sure.
High prevalence among diabetics makes the screening of sarcopenia of great value, as an early diagnosis can result in interventions that can allow the prevention of lean body mass deterioration and a better quality of life. So the aim of the study was assessment of prevalence of sarcopenia in ambulatory elderly patients with diagnosis of type 2 diabetes mellitus. This was a cross-sectional study with a sample size of 50 ambulatory patients aged 65 years and above with a diagnosis of type 2 diabetes mellitus. The optimum sample size for the present study was calculated on the basis of 15.7% prevalence of sarcopenia in type 2 diabetes mellitus, with the confidence level assumed to be 90% and permissible error assumed to be 10%. Using this, the optimum sample size came out to be 78. However, due to the COVID pandemic and paucity of patients visiting the OPD, the sample size was reduced to 50. This study was conducted over a period of 1 year. And it was conducted after due clearance from the Institution Ethics Committee and informed patient consent. Statistical analysis was done using the latest SPSS software for Windows. Prevalence of sarcopenia and categorical demographic and clinical variables were reported in frequencies and percentages. Muscle mass, hand grip strength, SBBP scores were reported as mean and standard deviation. The inclusion criteria was patients aged 65 years or older and who were ambulatory with a diagnosis of type 2 diabetes mellitus and either gender who gives consent. The exclusion criteria included people with degenerative and inflammatory arthritis of lower limbs, patients with old cerebrovascular accident with functional deficit, advanced Alzheimer's disease or cognitive impairment, heart failure with NYHA grade 3 or 4, non-ambulatory patients, patients with chronic kidney or liver disease, patients with body mass index of 18.5 or less, and chronic obstructive airway disease. The methodology for this study was that all the enrolled patients underwent measurement of muscle mass, muscle strength, and assessment of physical performance. Muscle mass assessment was done using bioelectrical impedance analysis, and the device output includes appendicular skeletal mass. Appendicular skeletal mass is the sum of skeletal mass of all the 4 limbs. And using this, the skeletal muscle index was calculated by the formula in which we divide the appendicular skeletal mass with height with the square of height in meters. And this gives us a skeletal muscle index, and it has different cutoffs for both males and females. Muscle strength measurement was done using a hydraulic Jamar hand grip dynamometer, which measures the hand grip strength in kgs. The hand grip strength of the dominant hand was used. And lastly, physical performance was assessed using the short physical performance battery. It is a composite test that includes assessment of gait speed, a balance test, and a chair stand test. It has a minimum score of 0 and a maximum score of 12 points. So basically, after carrying out all these 3 tests, patients were divided into sarcopenia and severe sarcopenia. The main common factor was that to fall into either of the categories, a patient needs to have a low skeletal muscle index or a low appendicular skeletal mass. A patient having a low appendicular skeletal mass with either low muscle strength or low physical performance falls into the category of sarcopenia. And for a patient to fall in the category of severe sarcopenia, a patient needs to have low skeletal mass with low skeletal muscle strength and low physical performance. So if 2 out of 3 are present, the patient becomes sarcopenic. And if all 3 are present, the patient becomes severe sarcopenic. And similarly, we've got cutoffs as suggested by the Asian Working Group for Sarcopenia. They have given us cutoffs to divide patients into sarcopenic and non-sarcopenic, as shown in the flowchart. So the results of this study was that while studying the distribution of age of the study subjects, it was seen that almost 76% or 38 individuals were in the age group of 65 to 69 years. 10% of the study population was in the age group of 70 to 74 years, and more than 75% and more than 14% from more than 75 years of age, making the mean age of the study population to be 68.8 years. While studying the gender-wise distribution in the study population, 27 patients out of 50, that is 54%, were males, while 23 out of 50, that is 46%, were females. Area of residence distribution showed that 28 individuals, that is 56%, resided in urban areas, while 44% of the study population resided in rural areas. And while studying the marital status, we concluded that 70% of the population were married, while the remaining 30% were either single or they did not have their spouse living with them. While studying the distribution of comorbidities of the study subjects, it was diabetes was present in all the patients, as that was the inclusion criteria. Besides that, the leading comorbidities among the patients was hypertension, followed by cataract, history of cataract surgery, followed by coronary artery disease, hearing impairment, hypothyroidism, and BPH. And while studying presence of multiple comorbidities in the study subjects, it was seen that 41 individuals, that is 82% of the study population, had multiple comorbidities, while only 9 had only diabetes mellitus. While assessing the muscle assessment of the study subjects in terms of skeletal muscle index, short physical performance battery score, and hand grip strength, we concluded that out of a total of 50 subjects, 39 patients had a normal skeletal muscle index, of which 18 were males and 21 were females. While studying low muscle mass, that is a skeletal muscle index less than 7 kg per meter square in males and less than 5.7 kg per meter square in females, as devised by the Asian Working Group for Sarcopenia, we realized that there were a total of 11 subjects who had low muscle mass, of which 9 were males and 2 were females. The mean skeletal muscle index in the study population was 7.47, while among males it was 7.92, and among females it was 6.93. While assessing the patients for their short physical performance battery score, as I mentioned earlier, the score ranges from 0 to 12. A score less than 9 was considered to be low physical performance. And we concluded that only 10 patients had normal performance, while 40 patients had low performance. And out of these 40, 19 were males and 21 were females. Similarly, while studying hand grip strength, 45 patients had low hand grip strength, of which 25 were males and 20 were females. While studying the mean skeletal muscle index in patients with normal and low physical performance status, we saw that patients with low physical performance had a lower skeletal muscle index in both in males and females. However, the same could not be concluded while studying the mean skeletal muscle index in males and females while comparing the hand grip strength. So the total prevalence of sarcopenia in the study was that a total of 11 patients were found to have sarcopenia and severe sarcopenia, with severe sarcopenia to be present in 7 males and 1 female. The discussion is the study is that the overall prevalence of sarcopenia among elderly with type 2 diabetes was about 22% in our study, which is pretty much similar to the findings from a Singapore-based study, which also used the same definition for sarcopenia. The findings of our study indicate that despite having preserved muscle mass, majority of the study population had poor muscle strength and poor physical performance status.
Hello.
And our study also found that
Time is over.
Gender was associated with increased prevalence of sarcopenia.
So
in conclusion, 11 patients were defined to be sarcopenic. But if we look at the muscle strength and muscle function, we might have a greater number of people who are sarcopenic. So therefore, we need to redefine our definition of sarcopenia, and we need to redefine a separate cutoff for the Indian population. Thank you.
hello. So what is the difference between atrophy and sarcopenia?
So atrophy is occurs when when a muscle is not being used, sir. But sarcopenia is when it is age-related loss of muscle and function, muscle mass and function, sir. Atrophy can occur because of some injury. A patient cannot use a particular part of the body, and that part of the body, the muscles of that part of the body atrophy, sir. Loss of muscle cells of that body, sir, of that part of the body, sir.
Muscle cell loss is sarcopenia, muscle mass is atrophy.
Yes, sir.
What is the difference between the sarcopenia in diabetic patients older age and non-diabetic?
So, first of all, in diabetic patients, sir, because as I mentioned earlier, that they have decreased, they have insulin resistance and decreased insulin signaling. And because of that, sir, there is increased protein breakdown and decreased protein synthesis. So this can result in increased or accelerated muscle loss in diabetics in comparison to non-diabetic patients, sir. And also, sir, India is on the verge of becoming a diabetic capital of the world. So that is why, sir, there needs to be there needs to be early surveillance of sarcopenia in diabetic patients.
Next year. Conclude చేయమను. Okay అండి.
Hello. Okay. I'm not only. Hello.
Hello, good afternoon, sir. Good afternoon, everyone.
Sir, Hem Kumar. Emma
Yes, sir.
Kumar.
Yes, sir.
So
Can I start the
post-
session, sir?
Okay, you can start.
Good afternoon, everyone. My name is Dr. Hem Kumar, postgraduate resident, Department of General Medicine, PS Institute of Medical Sciences and Research, Kuppam. Today, my topic of discussion is cross-sectional comparative study of risk factor for acute ischemic stroke in young adults and elderly in a tertiary care hospital in South India. Introduction and need for this study. The prevalence of stroke increases with age, and it is the major cause of death in 1/3 of affected individuals and severe disability in 2/3 of affected individuals. The patients who survive from stroke have problems of prolonged bedridden, social dependency, social isolation, and depression. Hence, an ounce of prevention is better than a pound of cure. There are very few studies comparing the prevalence of traditional risk factors in young adults and old patients with acute ischemic stroke, and also among elderly. Contribution of traditional risk factors for acute ischemic stroke with increasing age has hardly been studied. Aims and objectives: to compare the traditional risk factor profile in young adults and elderly patients with acute ischemic stroke, to compare the same among young old and old patients. The young old patients are between the age group of 60 to 75 years, and the old are more than 75 years. Materials and methods. This is the observational cross-sectional study. It is done in medical wards or ICU of PS Institute of Medical Sciences and Research, Kuppam, and the duration of study is 1.5 years. Inclusion criteria: adults admitted with clinical and radiological evidence of acute ischemic stroke, and the exclusion criteria is adults with hemorrhagic stroke and stroke mimics. The sample size is 121 patients, and it is a convenience sampling. Statistical analysis was analyzed using SPSS version 21, and p-value less than 0.05 was considered as statistically significant. Traditional risk factors for stroke include diabetes, hypertension, dyslipidemia, smoking, alcohol, and heart disease were compared in the young adults, which includes less than 60 years old, and the elderly, which includes 60 and more than 60. Results: the total number of patients presented with acute ischemic stroke are 121, among which the young adults include 42, whereas elderly include 79 patients. Among the elderly, it is again divided into young old and old. The young old comprises of 51 patients, whereas old includes 28 patients. This is a pie diagram depicting age distribution of the stroke, which shows that elderly patients accounts for more number compared to the young adults. Gender distribution in study patients. In both young adults and elderly, there is slight male predominance compared to the females in the incidence of acute ischemic stroke. Comparison of traditional stroke risk factors in young adults and elderly. It shows that hypertension, which is seen in 25 out of 42 individuals in less than 60 year age group, accounts for 59.5%, whereas in old patients, it is 64 out of 79, accounts for 81.1%, which is statistically significant. This suggests that hypertension is consistently associated with increasing age group. The remaining risk factors, diabetes, smoking, heart disease, alcohol, and dyslipidemia, were more or equals having same incidence in both groups. Multiple risk factors in the study patients were studied. The mean number of risk factors were 2 in both the groups, whereas out of 6 risk factors, more than 2 risk factors were present in 1/3 of patients in each group. Comparison of the traditional risk factors in young, old, and old patients. It shows that heart disease, which is seen in 9 out of 51 patients in young old, accounts for 17.6%, whereas it is seen in 12 out of 28 patients in old, which accounts for 42.8%, which came as statistically significant. This suggests that as the age advances, the amount of heart diseases were increasing and they are posing a significant risk factor for acute ischemic stroke in old patients. The remaining risk factors, hypertension, diabetes mellitus, smoking, alcohol, and dyslipidemia, were more or same, having equal incidence in both the groups. 2 risk factors were present in around 19 out of 51 patients in young old, whereas 12 out of 28 in old patients. More than 2 risk factors were present in 1/3 in each group. Discussion. Hypertension, the commonest risk factor, which is consistently associated with increased risk of stroke, especially in elderly. Hence, early identification and strict control of hypertension is important to prevent stroke. Conclusion. Comparing the young adults and elderly, hypertension and diabetes mellitus were the commonest stroke risk factors in both young and old. Hypertension was found more frequently in the elderly with acute ischemic stroke among the traditional risk factors. The mean number of risk factors in both the groups were 2. Out of 6, more than 2 risk factors were found in 1/3 in each group. Conclusion regarding comparing young old and old. Hypertension and diabetes mellitus were the commonest stroke risk factor in both young old and old. Heart disease was found more frequently in the old patients with acute ischemic stroke among the traditional risk factors. Out of 6, more than 2 risk factors were found in about 1/3 in both groups. Limitations of the study. Only traditional risk factors for acute ischemic stroke were studied. The rare risk factors such as protein C, protein S deficiency, other hypercoagulability states, which are predominantly seen in young patients, were not included in the study. Summary. Traditional risk factors were compared in young and old patients and again in different age categories in elderly with acute ischemic stroke, among which hypertension was the most common risk factor in all categories. Hypertension was significantly more common in elderly with acute ischemic stroke. This study reiterates and re-emphasizes the need for identification and strict control of hypertension in stroke prevention. These are the various references from which our study has been done. Then the special thanks to Dr. Betsy Matthew, who is our professor, for constantly supporting us, and the special thanks to Dr. Eddie Bargo for sharing his data from his dissertation. Thanking you, sir.
Thank you.
Thank you, Doctor, for the presentation. Like you were telling about hypertension and stroke, right? Hypertension was a risk factor. So,
Yes,
what
sir.
was the time interval between the diagnosis of hypertension and the onset of stroke in these patients?
Usually, on an average, the average time duration is around 5 to 10 years, sir, in most of the patients.
So these patients, they are presented, so they were detected later. Is it like that? Hypertension was
Yes, sir.
detected late.
Yes, sir. Only a few patients were newly diagnosed hypertensive presenting as stroke, sir. Around 10% of the patients has presented as newly diagnosed hypertension, presenting itself, the presenting symptom having end organ damage like stroke. The remaining patients are having a history of 5 to 10 years of hypertension in most of the patients, sir.
So those patients, were they on treatment, regular treatment?
Yes, sir. They were on regular treatment. The problem here is most of the patients are having resistant hypertension and requiring more number of drugs. Because of polypharmacy, they are avoiding drugs. They are taking irregular treatments. That is also one of the reasons for increased prevalence of stroke in geriatric population. because of poor drug compliance.
So any difference with any patient with a secondary hypertension had a stroke age-wise?
Yes, sir. There are there are some patients around which accounts for 5% of patients usually having like chronic kidney disease associated individuals. They have resistant hypertension, and they have presented with ischemic strokes. They also.
Hello.
Hello, sir.
Third person. Good afternoon.
Your name? You notice the first introduction slide.
Hello.
The first
Hello.
slide. First slide.
Sir.
Hello.
I mean,
you can start.
What's the title? Show us the title. Yeah.
Sir,
First
is
slide.
this visible? Sir, can I start, sir?
Yeah,
Yes.
go ahead. Yeah.
Good afternoon, sir. Today my topic is correlation between polypharmacy and gait speed in older adults. Introduction. With the advent of increasing elderly population and presence of multiple comorbidities, use of multiple medication in elderly population is a challenge to the healthcare system. Polypharmacy is an important geriatric syndrome in elderly, and itself is an independent risk factor for falls, disability, and mortality in elderly. Polypharmacy is defined as use of 5 or more medications, and polypharmacy itself increases the chance of poor compliance, drug-to-drug interactions, side effects, and poor functional capacity. Gait speed is a marker of adverse outcomes like falls, mortality, and disability in elderly. Aims and objective of the study was to analyze the relationship between polypharmacy and gait speed in older adults. Materials and methods. The study was conducted at Geriatric Outpatient Department at Rajiv Gandhi Government General Hospital, Chennai. Study was conducted for a period of 1 year from December 2019 to February 2020. The study design is a cross-sectional analytical study. The study population consisted of 305 older persons aged 60 or more years attending the Geriatric Medicine Outpatient Department. The sample size included 144 patients more than 60 or more years from both sexes selected by simple random sampling after application of inclusion and exclusion criteria. Methodology. First, institutional ethical committee approval was obtained, following which random screening of 305 elderly population, 60 or more years, was done. General information like name, age, sex, address, phone number was obtained. Medication history and medical history was obtained from pre-existing as well as old records. Sample size of 144 patients of 60 or more years from both sexes were selected by simple random sampling after application of inclusion and exclusion criteria. Exclusion criteria included those patients with known neurological disorder like dementia, stroke, Parkinson's disease, those using assistive devices, patients with hearing and vision impairment, and those with condition which impaired mobility. Those were excluded from the study. Gait speed of the participant was following after application of the exclusion criteria. Gait speed of the participant was assessed by instructing the individuals to walk at the usual pace along an 8-meter track. First 2 and last 2 meters were excluded, and central 4 meter was noted as first 2 and last 2 meters coincided with the point of acceleration and deceleration of the gait. Time taken to complete 4 meters was noted. Statistical analysis. Statistical analysis of the data was tabulated and was done using SPSS software. Results of the study. In this slide, we can see that the gait speed between polypharmacy and no polypharmacy, the gait speed in polypharmacy was lower than no polypharmacy group, and it showed significant association between this group. Between polypharmacy and non-polypharmacy in sex distribution, it was found that 47 males and 45 females were in polypharmacy group, while 25 males and 27 females were in no polypharmacy group, and it showed no significant association. In this slide, we can see that the participants with polypharmacy were more likely to have diabetes mellitus, hypertension, coronary artery disease, chronic kidney disease, osteoarthritis, hypothyroidism, and chronic obstructive pulmonary disease, showing that the individual comorbidities were much more in polypharmacy group compared to non-polypharmacy group. Also, the polypharmacy group had more number of comorbidities than no polypharmacy group, and it was found to be significant statistically. In our study, we also found that the males had higher mean gait speed than females. Male had a gait speed of 63.63, and females had gait speed of 58.67, which showed significant association. Compared to relationship between comorbidities, BMI, gait speed, it was found that there is a significant association between number of drugs, number of comorbidities, and gait speed, but not with BMI. In this study, you can see that in our study, the groups, first we divided the study participants into groups which use 1 to 4 drugs, and polypharmacy group which use 5 to 7 drugs. So in this mean difference between gait speed between these two groups, it was found that there was a significant association between polypharmacy and no polypharmacy group. Participants with the polypharmacy group walked 10.13 and 10.08 centimeter per second slower than no polypharmacy group. There was statistical significant association between no polypharmacy group and polypharmacy group of 5 or more medications after adjusting for age, sex, education, and BMI, but not with number of comorbidities. Discussion. In a study done by George et al., participants with polypharmacy walked 6 centimeter per second, which is lower than the no polypharmacy group. In our study, participants with polypharmacy walked 10.18 centimeter per second, which is lower than the no polypharmacy group. In another study done in Brazil, the number of medication was associated with poor gait performance in a cross-sectional community-based study in older adults. Limitation of the study, the causal relationship between polypharmacy and gait speed cannot be demonstrated in our study as it is a cross-sectional study, and the relationship between groups of drugs and gait speed was not studied in our study. Also, there was a limitation as the sample size was small. Conclusion of the study, in this study, elderly people taking multiple medication exhibited slowness in gait speed, which clearly indicates that polypharmacy adversely affects gait speed. Hence, minimizing the number of medications to minimum will help avoid complications, and it should be practiced. These are the references. Thank you. Hello.
So, you'll have to unmute Dr. Vijay.
Hello.
Yes, sir.
So what is the what advice you want to give the old people regarding polypharmacy?
Regarding
who are having the multiple complications, multiple comorbidities, hypertension, diabetes, COPD, osteoarthritis.
Regarding patients with multiple comorbidities, it is always advisable for the elderly people to come for regular follow-up so that the medication accordingly it can be changed, and if there is any need of escalation of dose, or we can even advise people regarding dietary modifications in some patients if it's possible.
Right. We'll move on to next.
Good afternoon, sir. Am I audible, sir?
Right.
Good afternoon to all the delegates and faculties. I am Dr. Kavini Lavu, postgraduate, MD Geriatric Medicine, Department of Geriatric Medicine, Madras Medical College. Mine is a descriptive study on fall risk assessment in older fallers attending the fall clinic. As WHO cites, falls are the second leading cause of unintentional injury deaths worldwide, and it is said that adults greater than 60 years suffer the greatest number of fatal falls. The increased risk for falling results in serious outcomes and associated healthcare costs. The falls in elderly are of utmost importance because the function and the quality of life deteriorate drastically following a fall. Fall risk assessment in routine clinical evaluation is important for early identification of fall risk in them and provide information that can guide interventions at the earliest. So the objectives of my study are to assess the risk of fall among older fallers by various scales and to assess the risk factors for falls in older adults. My study in this design is a cross-sectional study was conducted at the Fall Clinic Geriatric Outpatient Department, Rajiv Gandhi Government General Hospital, Chennai. My study was for about 2 years, from January 2019 to 2021. It included all elderly patients aged 60 and above who have had a history of fall in the past. My sample size includes patients with 113. Those patients with severe cognitive impairment, those patients with psychiatric disorder who could not perform tests, and those who are not willing to take part in the study were excluded from my study. Yes, the detailed history on age, sex were obtained from the patients. Detailed history on the environmental hazards like falling on the floor, obstacles, indoor and outdoor falls were elicited from the patients. The comorbidity list were asked for. History of any hearing impairment, history of vision impairment, history of any urinary incontinence was asked. Complete list of medications, the dosage with which the patients are taking, the duration for which the patients were or on medications were also asked. The use of assistive devices were also asked from the patients. The patients were then put on for examination. Along with the routine examination, blood pressure was measured in both the arms, and we also looked for a fall in systolic BP of more than 20 millimeters of mercury from supine to upright position. With the other systemic examination, the sensory motor system was examined, and sensations of both the feet were assessed to look in for any evidence of peripheral neuropathy. Vision was assessed using Snellen's chart, and hearing impairment was assessed using whisper chart. Then the records of the patients were assessed, and review of all the medications, the list of medications as said in the history, the duration and the dosage of the medications were also asked for. They were then assessed for the risk of fall using timed up and go test and performance-oriented mobility assessment test. The results were then interpreted as follows. So with respect to the demographic characters, we can see that the age group 60 to 70 years of age group had a higher frequency of fall when compared to other age groups. So around 60 patients out of 113 had a high risk of fall when compared to other age groups. Between male and female, it was the female preponderance. Around 53% of female were falling more when compared to male. They were around only 53 when compared to 60 out of 113. With respect to the environmental factors, it was the indoor fall which was more common than the outdoor fall. So we had around 59 patients out of 113 who were falling indoors. They gave history like slipping over mats, slipping over hazardous obstacles like wires, etc. Outdoor falls, the most common activities which they were during the fall were walking, standing, and turning. So with respect to the environmental factors, it is the indoor fall which is more common when compared to the outdoor fall. These patients were then subjected to timed up and go test. We could see that around 70 patients out of 113 have a high risk of fall. These patients were not able to complete a 3-meter distance within 10 to 13 seconds, and they were found to have high risk of fall. Whereas 43 patients out of 113 were able to complete it within 10 to 13 seconds, and thus there was no risk of fall among them. With tug test, with timed up and go test, the risk of fall was higher. It was amounting to about 61%. These patients were then assessed for balance and gait using performance-oriented mobility assessment test. Around 35 patients scored more than 25, so they were under low risk. 36 had an intermediate risk with a score of 20 to 25, and it was around 42 patients out of 113 who had a score of less than 19. So we had more older fallers with a high risk of score less than 90. So the various risk factors were analyzed, and it was found that around 45% of the patients were on more than 5 drugs each day. And it was also found that around 40.70 percentage of the patients were on multimorbidity. 15% of the patients were with visual impairment, and it was found that around 8 patients had unoperated cataract. 13% of the patients had hearing impairment, and we could find only 3 patients who were using hearing aids for impaired hearing problems. 11% of the patients had urinary incontinence, and they were patients who were on assistive devices, but still they had incidents of fall, and it was around 5% because of inappropriate use of those assistive devices. So 6% of the patients had peripheral neuropathy, and 5% had orthostatic hypotension. So of the risk factors analyzed, it was found that Polypharmacy and multimorbidity were the most major contributing factors for the risk of fall in older adults. When it comes to the comorbidity, we can see that hypertension and diabetes hold the most common comorbidities among the 113 individuals, followed by coronary artery disease, which is around 18%. So we had 3% of the patients with COPD, 2% of the patients with CKD. So the other 2%, Parkinson's disease, CVA, and hypothyroid were included in the other 2% of the population. So with comorbidity, it is the hypertension and diabetes, which is more common, followed by CAD and other diseases. So on comparing with the other two studies, the risk of fall was 37% in my study, and it was more or less equal with the other studies. It is a female preponderance, which is in my study, and study conducted by Shirohi et al. It was more or less equal in a study by Pothraj. When compared with all the three studies, it is the indoor fall which is more common, and it is the polypharmacy, one of the major contributing factors for the risk of fall. So to conclude, in this study, nearly 1/3 of the older followers have fallen in high risk of fall category. And of the risk factors analyzed, we could see that polypharmacy and multimorbidity are the most common contributing factors. There were patients with untreated hearing and visual impairment, and there were patients with urinary incontinence. So followed by polypharmacy and multimorbidity, these three were the major risk factors. So treatment of which will definitely decrease the incidence of further fall in the older fallers. Proper and appropriate use of assisted devices is very much essential, because we had found that around 5%, even with the use of assisted devices, had been falling. So review of medications and prescription of appropriate drugs is very essential, and this would reduce the risk of fall among them. Creating a safer environment, a senior friendly environment by removing the potential hazard will improve mobility among the followers. Anti-skid tiles, ramps and rails, and grips in bathrooms would help these patients. And very essentially, training on strengthening balance and endurance exercises is highly essential to reduce the further risk of fall in older fallers. So these two are my reference articles. Thank you, sir.
Sir, Venkatrajam sir is not there, so please tell.
So telling about this polypharmacy and multimorbidity, the main contributors, am I right?
Yes,
so
sir,
can you
yes,
also
sir.
mention about the internal environment and the external environment causes, the skidding and etc. etc.
Yes.
So are they both combined? So even the patients who are falling inside,
yes, sir.
Is it due to
Yes, sir.
multimorbidity and polypharmacy?
Yes, sir. Yes, sir.
Both all contributed.
Yes, sir.
Okay. So hypertension, as you told, your studies show that hypertension and diabetes are the more common comorbidities.
Yes,
Am I
sir.
right?
Yes, sir.
Okay.
Technical support.
Can we start with the next topic?
So we have one more candidate, right?
Yes.
Yes, sir.
Final
Yes.
candidate.
So there was some problem, technical problem.
Dr. Vijay. Hello.
Yes, sir.
Dr. Raju here.
Yes,
This
sir.
lady actually was given a chance because she got the best thesis award. So this
Okay,
is more to give her a presentation than an award. Venkatrajam sir.
Yes.
Namaste sir. I'm Dr.
Okay.
Raju.
Okay.
This lady has been given a chance just to present her work because she got the best thesis award.
So she won't be under this prize category, right?
No,
She's a
no.
special presentation.
She's already,
right?
she's just got,
Okay.
it's just to showcase her work rather than give a second award.
Okay, sir.
It is inappropriate.
Okay, sir. Sure.
Okay, sir.
Sure, sir.
Right.
Okay, sir.
Thank you.
Time enough.
Sir, she has some technical issues, sir. She'll join in 2 minutes.
Hello. Hello.
Yes, yes,
Sir,
doctor.
am I audible?
Dr. Yamini,
Not
share your
clear.
slides.
Yes, sir.
Hello, are you able to hear?
Yes, sir. I am, sir.
Okay, now you can start.
So, are my slides visible? Hello? Sir, am I audible?
Yes, yes, visible. Yes.
Okay. Good afternoon, everyone. My name is Dr. Yamini Ajmera, Senior Resident, Department of Geriatric Medicine, AIIMS, New Delhi. I'm here to present my thesis paper titled Incidence and Prevalence of Delirium and its Socio-Demographic, Clinical, and Biochemical Correlates in Geriatric Population. We shall be proceeding in the following manner: introduction, objectives, methods, results, discussion, conclusion, and then finally the references. So talking about delirium, it is a complex reversible neuropsychiatric disorder with multiple contributing factors, high frequency of occurrence, and significant morbidity and mortality in geriatric age group. In the existing literature, numerous knowledge gaps exist regarding the pathogenesis of delirium and its association with different risk factors. So the primary objective of this study is to determine the incidence and prevalence of delirium and compare its socio-demographic, clinical, and biochemical correlates between patients diagnosed with delirium with those who are not. And the secondary objective of this study was to determine the duration of hospital stay and outcome in patients diagnosed with delirium with those who are not. The ethical approval of the study was obtained from Institute Ethics Committee, and participants were recruited after seeking written informed consent from the patient or informant or immediate attendant. The study was conducted at Department of Geriatric Medicine, AIIMS, New Delhi from July 2019 to November 2019. It is a prospective observational study. Patients were assessed within 24 hours of admission and daily thereafter till the time of discharge or death, whichever was earlier, using CAM or CAM ICU scale with subsequent division into delirium and non-delirium group. Other tools used were CATS Index of Independence in Activities of Daily Living. informant questionnaire on cognitive decline in elderly, Charlson Comorbidity Index, Richmond Agitation and Sedation Scale, Delirium Rating Scale revised version, and Brief Psychiatric Rating Scale. The biochemical variables analyzed were CBC, LFT, KFT, blood sugar levels, leptin, adiponectin, and neopterin. The patients aged 60 years or above, hospitalization under Department of Geriatric Medicine with expected hospital stay more than equal to 1 day, gave written informed consent to participate in the study and were able to communicate in Hindi or English were included in the study. Patients who withdrew consent or had a history of psychotic illness or alcohol-induced delirium were excluded from the study. The sample size was calculated using Cochrane's formula, assuming a prevalence of 42% according to existing literature with 7% margin of error, sample size equal to 200 participants for the conduct of the study. The sampling technique used was consecutive sampling. For statistical analysis, Theta version 14.0 was used and statistical significance was set at p-value of less than equal to 0.05. For qualitative variables, absolute frequency and related percentage distribution were reported. And to compare differences amongst them, Pearson chi-square or Fisher exact test was used for normal and non-normal distribution, respectively. For quantitative variables, mean plus minus standard deviation or median minimum to maximum were reported. And to compare differences amongst them, independent sample t-test or Wilcoxon-Ransom test was used for normal and non-normal distribution, respectively. These variables were further subjected to univariate and multivariate regression analysis to determine the independent predictors of delirium. So this study showed mean age of participants to be 73.1 plus minus 8.83 years, and incidence and prevalence rates were found to be 5% and 20% respectively. Hypoactive delirium was found to be the most common motoric subtype. Most common etiologies identified were sepsis, that is 50%, followed by intracranial pathologies, that is 20%, and electrolyte disturbances, that is 12.5%. As per phenomenology of delirium, almost all patients were found to have disturbances in sleep-wake cycle, orientation, attention, long-term, and short-term memory. The univariate analysis showed older age, HDU admission, higher IQ code short form scores, higher BPRS total scores, and lower CATS ADL scores, and higher neutrophil lymphocyte ratio values, higher sodium levels, lower albumin levels, and lower leptin levels to be significantly associated with delirium. After multivariate analysis, following variables were identified to be independent predictors of delirium, that is HDU admission, higher BPRS total scores, lower CATS ADL scores, and low leptin levels. Delirium was also found to be independent predictor of mortality, that is 32.5% versus 8.75%. So the main aim of the study was to determine the various possible predictors of delirium and to help identify those at maximum risk and develop strategies to recognize potential targets of intervention. The prevalence and incidence rates in the current study are lower than those obtained by previous studies conducted by Tossar et al. In 2018 and Khurana et al. In 2011, conducted in old age medicine wards. Possible explanation could be application of targeted multi-component non-pharmacological interventions in geriatric ward like sensory rehabilitation, frequent reorientation clues, visits from family members, early mobilization and regular ambulation, pain management, so on and so forth. The explanation for increase in intracranial pathologies as a frequent cause could be ready availability and advancement in brain imaging and invasive techniques like CSF analysis, early identification and management of metabolic abnormalities with availability of routine blood tests. To our knowledge, this is the first study to identify more general psychopathological symptoms, that is higher BPRS scores as independent risk factor for delirium. Leptin levels, although previously found to be significantly lower in patients with delirium in the studies conducted by Sanchez et al. In 2013. And this study further contributes to this available literature. The study is limited by a relatively small sample size, lack of generalizability, as it cannot be extrapolated to community settings. It is a hospital-based study. Failure to reassess cognitive and functional status of patients at the time of discharge and post-discharge to determine the short-term and long-term outcomes of delirium, and failure to assess temporal association of biochemical markers. In the future, we need large multi-center prospective studies to confirm our results and evaluate the role of various correlates in causation of delirium and its short-term and long-term consequences. To conclude, delirium is a frequently occurring condition in older adults with high mortality rates. Most common etiologies identified are sepsis, followed by intracranial pathologies and electrolyte disturbances. Assessment of cognitive and functional status, as well as psychopathological symptomatology, should be routinely done at the time of admission to establish those at risk. Leptin might serve as a potential biomarker owing to its probable role in the pathophysiological processes of delirium. These are the two most important references. Thank you.
Hello, are you able to hear?
Yes, sir.
So leptin can be taken as a biomarker to find out the delirium.
Yes, sir. Low leptin levels, like this is the previous studies. Only one study has been conducted in old age medicine ward, that is 60 years and above. Previous two studies have been conducted in vascular surgical patients, and one study was conducted before in acutely ill adult patients aged 18 years and above. So yes, leptin can serve as a potential biomarker owing to its pathophysiological role in neuroinflammatory processes. So.
Okay. Hello?
Yes, sir.
So
that's the last presentation.
Last one more is there. It's over.
No, sir, it's over. Oh. Thank you, Dr. Yamini.
Thank you, sir.
So, thank you. Hello.
Madan Murthy garu.
Yes, sir.
Amma, we'll go to the next session, e-posters. Thank you, Dr. Venkatarajan, sir. Thank you, Dr. Bijan.
Thank you, sir.
1 minute, sir. Thank you, sir. And this is here to congratulate again Dr. Yamini Ajmera for getting a gold medal for our best thesis. So from the organization.
Thank you so much.
So very best congratulations, Yamini. No, you unmute yourself. Yamini, unmute yourself.
Thank you so much, sir. Thank you so much, sir, for this honor. I'm truly grateful. Thank you so much. Hello, am I audible, sir?
Yeah, you'll be getting your certificate and your cash prize soon.
Yeah.
Yes, thank you so much, sir. Thank you. Thank you.
God bless you.
I'm truly grateful. Thank you.
And thank you, Venkatarajan, sir, for joining and as a judge. Thank you, sir. Thank you, Bijan, sir.
Thank you. Thank you, sir.
Dr. Jagan?
Good afternoon, sir.
Yeah, could you like
Am
to
I
read it out? Yeah, you're audible.
am I audible, sir?
Yes, sir.
Good afternoon, sir. I'm Dr. Jagan, postgraduate, General Department of General Medicine. I'm here to present a case report on spontaneous muscle hematoma complicating a dengue hemorrhagic fever. Dengue fever is caused by a dengue virus of family Flaviviridae. Bleeding complications in the patient with dengue hemorrhagic fever results from combination of thrombocytopenia, increased vascular fragility, and increased fibrinolysis. Can I proceed?
Yeah, please go ahead. Please go ahead.
Thank you. Thank you, sir.
Which college are you from?
Sir, I'm from Viluppuram Medical College, sir.
Where is that?
In Tamil Nadu, sir.
Okay, right. Go ahead.
Okay. Bleeding complications from in patients with dengue hemorrhagic fever, it results from the combination of thrombocytopenia and increased vascular fragility, and increased fibrinolysis and altered coagulation and anticoagulation factor balance. We report a case of a spontaneous muscle hematoma formed during the critical phase of a dengue hemorrhagic fever. A 37-year-old male presented with fever and thrombocytopenia, progressive thrombocytopenia. The patient was treated with the IV fluids and supporting muscles. He was gradually improving, but during the course of his treatment, he developed severe pain over the right hip on movements. The patient was suspected to have a psoas abscess. When we have evaluated for the patient, we take a CT. The CT.
Can other people, all of you?
Hello, sir.
Go ahead. I was requesting all the other people to mute themselves.
The diagnosis was confirmed using a pelvic computer tomography scan. The patient was managed conservatively. Going on to the discussions, dengue is one of the most rapidly spreading infections of global concern. The clinical manifestations of the dengue.
No, your voice is breaking, Dr. Jagan. Some problem with your transmission?
Am I audible, sir?
No, your voice is still breaking, ma. Could you just talk now? Are you logged in with two devices, only one? Okay, go ahead. Go ahead.
Okay, sir. Among the mosquito-borne infections, dengue is a major global concern. The clinical manifestation of a dengue varies from asymptomatic infections to undifferentiated fever, dengue fever, and dengue hemorrhagic fever. The causes begin the critical stage of the dengue hemorrhagic fever or high degree of plasma leakage, as well as a low platelet count, which may lead to the circulatory failure and other bleeding complications. Along with thrombocytopenia, which is a known complication of dengue hemorrhagic fever, there will be an increased fibrinolysis and there will be an altered coagulation and procoagulation and anticoagulation factor balance that may also complicate bleeding. Among the bleeding complications, we rarely see the muscle hematoma, but the usual sites of intramuscular hematoma includes the rectus sheath, the psoas, and the iliacus muscle. But the hematomas usually are unilateral, and rarely they may be a bilateral hematomas. The imaging modality preferred are the ultrasound and the contrast enhanced CT scan, which can diagnose the muscle hematomas. The face going to the iliacus hematoma. The fascia around the iliacus and is very densely adherent. The femoral nerve crosses above it. So, if any hematoma formed within the iliacus muscle, it may compress the femoral nerve and it may cause numbness and weakness of the femoral nerve distribution. Most patients with hematomas are managed with adequate fluid association and platelet transfusion, transfusions. Patients are also managed accordingly. The femoral nerve compress and more urgent surgical evacuation of the hematoma. To conclude, dengue hemorrhagic fever is a common tropical infection. Recognizing serious complications with the manifesting as simple complaints such as heat pain or cruise to prevent the complications such as femoral compressive neuropathy, asymptomatic.
Your voice is breaking. Your voice is breaking again. You're done?
Yes, sir.
How did you confirm dengue in this case?
Sir, yeah, we have done dengue IgM, sir, for this patient.
NS1?
NS1 IgM is first one. The dengue IgM is also
Okay.
found to be positive, sir.
Why didn't you put the values, absolute values? What is the platelet count where you get spontaneous hematomas?
The platelet count was around 40,000, sir.
Do you think with 40,000 you get spontaneous hematomas? What is
It's
the
less
normal
likely.
value? Yeah, very unlikely.
Really
No.
unlikely, sir.
Next time when you present, you should actually write the investigative values also to convince
Okay,
the
sir.
others, isn't it?
Okay, sir.
Okay, then. Right. Thank you very much for your
Thank you.
presentation. Right?
Thank you, sir.
Okay.
Thank you, sir.
Right. Next, Dr. Prashant.
Good afternoon, sir.
Good
Am I
afternoon.
audible, sir? Yes.
You are audible.
Good afternoon, everyone. Today, I myself, Prashant, from Government Medical College, Chandigarh, is going to present a case report on gemcitabine-induced hemolytic uremic syndrome in a case of lung cancer.
Okay.
Hemolytic uremic syndrome is a principal subtype of thrombotic microangiopathy that are characterized by common clinical and pathological features. Clinical features include microangiopathic hemolytic anemia, thrombocytopenia, and target organ damage, that is acute kidney injury. Pathological features include vascular thrombosis and endothelial damage. Endothelial damage in hemolytic uremic syndrome is due to overactivation of the alternate complement pathway. Secondary, etiologically, it could be divided into the primary causes and secondary causes. The primary causes arise from either gene mutation or autoantibodies, with gene mutations are the being most common. Genetic mutation occurring in factor H is the most common. Other mutation which are factor H, factor I, CD46, and thrombomodulin modulations. Autoantibodies against factor H can also develop. Secondary causes include infection, drug-induced toxicity, pregnancy, autoimmune disorder, and disseminated malignancy. Common infectious agents which causing HUS include Shiga toxin producing E. coli, which presents as a bloody diarrhea in case of children, or HIV, and Streptococcus pneumoniae. The most common drugs which are which causes hemolytic uremic syndrome are cisplatin, bleomycin, and more recently the focus is on gemcitabine. Case report, the case presentation, sorry. In 65-year-old male presented with the chief concern of pedal edema and decreased urine output. He is a known case of lung carcinoma and was on chemotherapy for 5 months. He was investigated and was found to have deranged renal function test, higher BP records, and thrombocytopenia. Patient was diagnosed with lung cancer on CCT chest and was started on chemotherapy. After the biopsy report was suggestive of squamous cell carcinoma, which was moderately differentiated. In investigation, the deranged renal function tests were, the creatinine was higher, that is 9.3. The BP records were higher, more than 150 by 90, and the thrombocytopenia was there of 79,000. Patient was investigated for the tropical fever workup, that is dengue, malaria, scrub, and leptospira. All the above, all these are negative. Later, patient was investigated for the hemolytic uremic syndrome. We got a peripheral blood smear done. The peripheral blood smear was suggestive of schistocytes and the fragmented red blood cells. LDH was high in this case, which was around 460. The urine was negative for hemoglobin, and indirect and direct Coombs test was negative. We started the patient on a treatment, which is the cessation of the gemcitabine therapy. Hemodialysis was done for 3 cycles, and the stabilization of patient was done. After taking the consent and explaining all the options available for the hemolytic uremic syndrome treatment, patient was started on the plasmapheresis. 6 cycle of plasmapheresis was given to the patient, and he was stabilized, and the creatinine dropped down to 3.3 milligram per deciliter, and patient was able to maintain a urine output of 700 ml. In discussion, gemcitabine is a novel pyrimidine antibolite which is used both as a single agent and in a combination in a wide range of carcinomas such as pancreas, non-small cell lung, breast, ovarian, and bladder and lymphoma. It is a well-tolerated, with the main toxicities being myelosuppression, nausea, influenza-like symptoms, skin rashes, and elevated liver function test. The first report of gemcitabine-associated HUS was occurred in 1994. The incidence has been reported between 0.015 to 4%. There is no clear dose-dependent relationship has been established in case of HUS because of gemcitabine. Gemcitabine is cell cycle specific for the S phase. It is phosphorylated intracellularly to bisphosphate and triphosphate. Gemcitabine bisphosphate inhibits ribonucleotide reductase, whereas triphosphate incorporated in DNA and inhibits DNA polymerase. In the pathophysiology of gemcitabine-induced HUS, it is postulated to be direct endothelial damage to the kidneys, resulting in platelet activation, and release of ultra-large von Willebrand factor multiplers and activation of the clotting cascade. To confirm the diagnosis of a HUS, a renal biopsy should be done, which shows microvascular damage of arterioles and small arteries, which are occluded by eosinophilic hyaline thrombi containing fibrin and platelet aggregates. A renal biopsy was planned for our patient, but because of the high risk of the bleeding and comorbidities, patient denied the renal biopsy, and the patient was managed only on the treatment of plasmapheresis. Yes, the initial step of the management in case of suspected gemcitabine-induced hemolytic uremic syndrome is cessation of therapy. Treatment for HUS historically has been plasmapheresis. The goal of plasmapheresis are to stabilize the hemoglobin level, normalize the platelet count, and improve renal function. The role of plasma exchange, though, is uncertain. In a review of literature among 26 patients treated with therapeutic plasma exchange, 56% recovered, whereas only 30% of 18 patients who received treatment did. Recently, eculizumab, a monoclonal antibody which acts as a terminal complement inhibitor that binds with high affinity to the human C5 complement and is a promising treatment for thrombotic microangiopathy. Rituximab, which has been shown to provide an effective and well-tolerated treatment option for gemcitabine-induced thrombotic microangiopathy hemolytic syndrome, is used in case of refractory cases and is commonly employed therapy along with plasma exchange and steroids. So in conclusion, a high suspicion of gemcitabine-induced hemolytic syndrome should be kept, and the physician should vigilantly monitor the renal function test, hemoglobin levels, and a urine output for the patient. If hemolytic uremic syndrome is suspected early and investigated, because of the cessation of therapy and further treatment option, the patient can be salvaged and proper treatment can be given to the patient.
Okay, thank you. So what were your diagnostic criteria for hemolytic uremic syndrome?
Sir, in our case, it is diagnosed clinically and on the biochemical investigation. Sir, in our patient, the hemolytic anemia was present, which was given by low hemoglobin. There was acute kidney injury was present, which was suggested by the high creatinine count and decreased urine output of the patient. And there is thrombocytopenia. Further, thrombocytopenia is investigated by the tropical fever workup, which was not suggestive of any tropical infections. Thus, by the triad, the diagnosis of hemolytic uremic syndrome is made.
Okay, why is LDH raised?
Sir, LDH was raised because of the hemolysis.
Okay.
Sir.
Was this case treated by you or treated by the oncology department? How did you get to this case?
Sir, initially the case was the pulmonary and oncology department, but patient was referred to the general medicine because of the deranged renal function and unable because of the management issues. Sir.
Okay. You're in medicine or geriatrics?
Sir, general medicine, sir.
Okay. Under Dr. Lehel?
Sir, Dr. Lehel is in our department. Yes, sir.
Okay. Okay. Right. Thank you very much. That was a good case. Right.
Thank you.
Next, Dr. Dinesh.
Hello, sir.
Yeah, go ahead. Is it Dr. Dinesh?
Hi, sir. Good afternoon, Dinesh Kumar.
Yeah,
Shall I
just
start,
share.
sir?
Yeah, please share your slides.
Do my slides are visible, sir?
No.
Now,
Now
sir,
it is. Now it is.
shall I start,
No,
sir?
Go ahead.
Hi, thank you, sir. Good afternoon, everybody. My name is P. Dinesh Kumar. I am from Madras Medical College, Chennai, of Department of Geriatric Medicine. I'm going to present a case of primary adrenal insufficiency in elderly. Introduction: adrenal insufficiency is an acute, life-threatening emergency in any age group, more so in elderly, contributing to excess mortality. The incidence of adrenal crisis is 6.3 per 100 per year patient, with reports of increased risk of adrenal crisis in elderly with no difference between males and females. A case report: in the month of June 2021, a 70-year-old male is known case of diabetes mellitus, systemic hypertension, developed left hemiparalysis 1 week after COVID infection. He was admitted in a private hospital and treated for left capsular infection and sent home. On the month of July 2021, patient developed a cough and dyspnea of 3 weeks later and found to be COVID RT-PCR positive. He was referred to RGH for admission considering of age and comorbidities. His CT-CVD score was 1/25 and he was treated with oxygen, steroids and anticoagulants, remdesivir as per protocol, and became COVID negative after 3 weeks of treatment. Patient continued to be sick with anorexia and diarrhea and hypotension. Hyponatremia of patient was consistently there, and the patient was planned to transfer to geriatric ward. And first week of August, patient received geriatric ward. On examination, patient was very delirious with GAM score of 4/4 and dehydrated, febrile, and tachycardic, and tachypneic, and hypotensive, and hypoglycemic. And he had a CBD in situ while receiving, which was draining cloudy urine. And local examination, patient per abdomen found to be lower abdominal tenderness present. And according to field score more than 2 with altered sodium, tachypneic, and low BP, and diagnosis of uroscopy and septic shock was made. The investigation of patient with a total count of 23,000 in the beginning, and sodium was my hyponatremia, and the albumin was very low. The hypoalbuminic is present when the random blood sugar is always less than below normal range. And the radiological investigation found to be CT brain has chronic right axillary infarct, and CT chest be mild right pleural effusion, and the CT abdomen has higher with positively, and the CT abdomen protocol was done as a normal study. And urine culture is found to be E. coli of 10/5, resistant to amikacin and nitrofuran. Patient was started on intravenous fluids, empirical antibiotics, and symptoms improved gradually at patient discharge. On September, he got readmitted with the similar complaints of diarrhea and fatigue after 1 week. She was in altered sodium and hypotension with hyponatremia and had hypoglycemic episodes. Serum cortisol was repeated. It was found to be around 20 microgram per deciliter. Still, the relative adrenal insufficiency was considered, and patient was started on intravenous steroids, and symptoms improved drastically. Patient was started on oral steroids, which was tapered and stopped over a period of 1 month and treated with adrenal corticotropic stimulation test. And now, month of number corticotropic co-syntopine the stimulation test was done with 250 microgram 250 mcg. Done it showed to be levels of lower serum levels of serum cortisol levels of fasting 30 minutes and 60 minutes cortisol levels, and elevated ACTH levels considered to be primary adrenal insufficiency. Since ATM cortisol was less than 3, it was considered as adrenal insufficiency, and followed by ACTH stimulation was done, which is elevated levels of baseline ACTH, and hence the primary adrenal insufficiency of patient was diagnosed. And patient reported to be doing well after regular low dose of oral steroid was started. And diagnosed to be systemic hypertensive, type 2 diabetic, and the urosepsis have the primary adrenal insufficiency probably due to COVID infection. Since the patient has fatigue, altered levels of consciousness, recurrent episodes of hypoglycemia, hypertension, hyponatremia, and the low serum cortisols, and a positive to ACTH stimulation test, which confirm the diagnosis of adrenal insufficiency. The probable cause will be antibodies produced against viral particles will inadvertently destroy the circulating ACTH, as expression of certain amino acids of sequence of COVID-19 infection that are molecular mimics of post-ACTH hormone, which could blunt the stress-induced cortisol rise. There are few reports of adrenal insufficiency developing after COVID infections. The COVID infection affect adrenals by various multiple mechanisms that most probably due to adrenalitis, hypercoagulability, and rare endothelial damage, and microvascular damage, and infection and hemorrhages. Other common cause of adrenal mostly by 80% due to autoimmune adrenalitis, and next to that is adrenal tuberculosis, and followed by infection like HIV and COVID-19, and adrenal hemorrhage and adrenal neoplasms. In conclusion, it is important to consider COVID-19 as one of the cause of adrenal insufficiency in elderly with high clinical suspicion essential, and measuring serum 8 AM cortisol and the initiation of treatment with go-cortisol should be considered along with other treatments. And the reference of is from the epidemiology of adrenal in chronic adrenal insufficiency, and the second is from the new onset adrenal insufficiency in patients with COVID-19. Thank you, sir.
Okay, thank you, Dr. Dinesh. Normally, in a case of COVID, steroids are started initially itself.
Yes, sir.
So, how do we explain that? What are the steroids that do not affect your cortisol test? Any
Actually, low dose steroids of like hydrocort can be not affected, but patient is given a steroid of low dose steroid was not started when COVID positive. So only 5 days it was given during that period, and after 1 month only we have repeated the test. Sir. The cortical storm, cytokine storm is started before the period of COVID. Sir. After 2 months of repeating cortisol test, we got a level of less than 3, so we consider a certain deficiency. Sir.
Okay, thank you. Thank you very much.
Yes. Thank you. Sir. Thank you.
Dr. Girishma.
Sir, am I audible?
Yeah, you're audible. Go ahead.
Is my screen visible, sir?
It is visible.
Okay. My name is Grishma. I'm a general medicine resident in CMC Vellore. So my study was on factors associated with insulin resistance in patients with type 2 diabetes mellitus. And so in this particular study, we looked at patients' insulin resistance of a given set of patients. It was a retrospective review. So as an introduction, insulin resistance refers to a state in which a given concentration of insulin is associated with a subnormal glucose response. So most common factors that we are aware of which contributes to insulin resistance are obesity, certain medications such as glucocorticoids, antiretrovirals, insulin antibodies, genetic defects, stress, lipodystrophy associated, and so on. So in this particular study, we try to identify the lesser known factors associated with insulin resistance and to see its correlation with glycemic control. So the objective of the study was to study the various lifestyle, lab and disease-related factors associated with insulin resistance in type 2 diabetic patients presenting to wellness clinic between Jan 2018 to September 2021. So we did a retrospective chart review of adult patients who attended the Medicine for Wellness clinic between Jan 2018 and September 2021. So among the patients, we obtained medical records of 32 patients who had answered the lifestyle questionnaire regarding the various lifestyle factors, and the required laboratory tests were reviewed, and details were included in the study. So insulin resistance, for the sake of the study, was calculated using the HOMA2IR calculator software.
Okay.
And correlation between insulin resistance and the relevant variables were obtained using Spearman's rank correlation coefficient. And the baseline characteristics of the study participants and the various lifestyle, lab, and disease-related factors associated with insulin resistance were described and analyzed. So the results I obtained, so among the 32 participants, 53% were males and 47% were females. And the mean age was 49 plus minus 9. And the mean duration of diabetes among these patients was 9.2 plus or minus 8. And the BMI also was 28.8 plus minus 5. So we also looked at the various lab parameters. So insulin resistance, as I mentioned before, it was calculated by HOMA2IR calculator, which used the fasting blood glucose and fasting C-peptide levels in a software to give us this specific value. And the other parameters were LDL, HDL, total cholesterol, and triglycerides, the lipid profile. So LDL mean value was 107 plus minus 36, HDL was 39 plus minus 7, total cholesterol was 164 plus minus 41, and triglycerides of 185 plus minus 88. And a few interesting things that we wanted to look at are vitamin B12, vitamin D, HSCRP, which is very commonly described in association with metabolic syndrome, to see if there's any association with insulin resistance. So in this study, vitamin B12, the mean levels were between 464 plus minus 370, vitamin D 21 plus minus 13, and HSCRP levels of 5.7 plus minus 6.2. So yeah, so we looked at the correlation.
Right.
Yeah. So we looked at the correlation between HbA1c, duration of diabetes, BMI, with insulin resistance. And the only significant correlation that we could identify was in patients with high BMI. So it showed a positive correlation. So higher BMI, which predisposes to higher chances of insulin resistance, p-value of 0.05 was obtained. So other lab parameters, actually we checked at HDL, LDL, vitamin B12, vitamin D, HSCRP. However, we could not obtain any relevant significant correlations between insulin resistance and any of these lab parameters. So we also looked at lifestyle parameters according to the lifestyle questionnaire, and found that activity, sun exposure, and sleep were negatively correlated with insulin resistance, which all had significant p-values, which suggests that these parameters may have an influence on insulin resistance. However, the main limitation of the study would be the low number of patients that we had. So any further significant associations, or the sample size was not enough to actually establish or deny any associations, but definitely it shows us an insight to the trend, so that further studies can be done regarding the same. So I would like to conclude saying, according to my study, factors like glycemic control and duration of diabetes did not seem to have a correlation with insulin resistance. Obesity and other lifestyle factors such as decreased activity, inadequate sun exposure, and sleep appears to be associated with higher insulin resistance. And various lab parameters including lipid levels, HSCRP, B12 and D levels could not be elicited to have an association with insulin resistance.
Dr. Grishma, you actually started your study before COVID, right?
Yes, sir.
Then you could have got, okay. Because of COVID, you could not get the numbers.
Sir, actually, we had a lot more data, but the data for patients who actually did the C-peptide and the C-peptide levels was the limiting factor in my study, actually.
Why?
Getting
it done is difficult.
No, sir, it was a retrospective study from the data which was available. So I couldn't get from the.
It was not done in all the cases.
Yeah, sir. There's lots of missing.
Once you say retrospective, again, it becomes very, you can't question anything now. Okay, right. Thank you very much. Thank you very much.
Thank you, sir.
Right. Dr. Rohit. Dr. Rohit, have you logged in?
Sir, he didn't join, sir. I think you can conclude.
Okay, okay.
Yeah, there are like his details are also not there with us. So
No, that's sad. Okay, then in case he gets in touch with you, could you adjust him tomorrow? Do we have any e-posters tomorrow?
yes, sir. I'll ask with Chandrasekhar, sir.
Yeah, please adjust it because this technical problems are always there. In case he contacts you, please adjust and accommodate him tomorrow.
Sure, sir. Sure, sir.
Okay.
Okay.
So thank you very much. With this, we end this session and maybe today's scientific program. And now Chandrasekhar sir is there. Krishna Prabhakar. Okay, does not matter. See you then.
ఫోన్ లో మాట్లాడు
లాస్ట్ పర్సన్
ఇప్పుడు ఏమన్నా అయితే